World Hypertension League is a non-profit, non-governmental organization which has more than 100 societies under its banner. World Hypertension Day is observed every year on 17th May, for which a theme is selected. This year's theme is Controlling Hypertension Together. The World Hypertension Day is intended to create awareness among general public for prevention and control of hypertension across the globe. There is an increasing global burden of hypertension, which had already crossed 1.3 billion people suffering from hypertension. The mortality due to hypertension has already crossed 10 million people every year. Observing World Hypertension Day not only creates awareness to prevent hypertension, but also encourages patients, their relatives, healthcare providers, including clinicians, for a better control of hypertension. This can be easily done provided we all join together and take part in educational activities for public and for healthcare providers. Early screening will help us to alleviate the sufferings of fellow human beings from the adverse complications of hypertension, such as stroke, heart failure, and kidney failure. The theme, Controlling Hypertension Together, I am sure will pave the way for a better outcome related to hypertension in the long run. I am Dr. S.N. Narasingan, Vice President of the World Hypertension League. World Hypertension League is a non-profit, non-governmental organization which has more than 100 societies under its banner. World Hypertension Day is observed every year on 17th May, for which a theme is selected. This year's theme is Controlling Hypertension Together. The World Hypertension Day is intended to create awareness among general public for prevention and control of hypertension across the globe. There is an increasing global burden of hypertension, which had already crossed 1.3 billion people suffering from hypertension. The mortality due to hypertension has already crossed 10 million people every year. Observing World Hypertension Day not only creates awareness to prevent hypertension, but also encourages patients, their relatives, healthcare providers, including clinicians, for a better control of hypertension. This can be easily done provided we all join together and take part in educational activities for public and for healthcare providers. Early screening will help us to alleviate the sufferings of fellow human beings from the adverse complications of hypertension, such as stroke, heart failure, and kidney failure. The theme, Controlling Hypertension Together, I am sure will pave the way for a better outcome related to hypertension in the long run. I am Dr. S.N. Narasingan, Vice President of the World Hypertension League. World Hypertension League is a non-profit, non-governmental organization which has more than 100 societies under its banner. World Hypertension Day is observed every year on 17th May, for which a theme is selected. This year's theme is Controlling Hypertension Together. The World Hypertension Day is intended to create awareness among general public for prevention and control of hypertension across the globe. There is an increasing global burden of hypertension, which had already crossed 1.3 billion people suffering from hypertension. The mortality due to hypertension has already crossed 10 million people every year. Observing World Hypertension Day not only creates awareness to prevent hypertension, but also encourages patients, their relatives, healthcare providers, including clinicians, for a better control of hypertension. This can be easily done provided we all join together and take part in educational activities for public and for healthcare providers. Early screening will help us to alleviate the sufferings of fellow human beings from the adverse complications of hypertension, such as stroke, heart failure, and kidney failure. The theme, Controlling Hypertension Together, I am sure will pave the way for a better outcome related to hypertension in the long run. I am Dr. S.N. Narasingan, Vice President of the World Hypertension League. World Hypertension League is a non-profit, non-governmental organization which has more than 100 societies under its banner. World Hypertension Day is observed every year on 17th May, for which a theme is selected. This year's theme is Controlling Hypertension Together. The World Hypertension Day is intended to create awareness among general public for prevention and control of hypertension across the globe. There is an increasing global burden of hypertension, which had already crossed 1.3 billion people suffering from hypertension. The mortality due to hypertension has already crossed 10 million people every year. Observing World Hypertension Day not only creates awareness to prevent hypertension, but also encourages patients, their relatives, healthcare providers, including clinicians, for a better control of hypertension. This can be easily done provided we all join together and take part in educational activities for public and for healthcare providers. Early screening will help us to alleviate the sufferings of fellow human beings from the adverse complications of hypertension, such as stroke, heart failure, and kidney failure. The theme controlling hypertension together, I am sure, will pave the way for a better outcome related to hypertension in the long run. I am Dr. S.N. Narasingan, Vice President of the World Hypertension League. World Hypertension League is a non-profit, non-governmental organization which has more than 100 societies under its banner. World Hypertension Day is observed every year on 17th May, for which a theme is selected. This year's theme is Controlling Hypertension Together. The World Hypertension Day is intended to create awareness among general public for prevention and control of hypertension across the globe. There is an increasing global burden of hypertension, which had already crossed 1.3 billion people suffering from hypertension. The mortality due to hypertension has already crossed 10 million people every year. Observing World Hypertension
And one of the event is the World Hypertension Day, which need to be commemorated every year. They had selected 17th May as the World Hypertension Day. Why this World Hypertension Day? You may be wondering what is going to happen during this particular day. This day is created mainly to create an awareness among the people, general public, about high blood pressure or hypertension. You must know what is high blood pressure, hypertension, which I will tell you. So the World Hypertension League not only concentrates on the awareness, but also proper screening of blood pressure. How to screen the patients for blood pressure measurement, how to use the machines, what is available with us today, how best we can probably arrive at the proper diagnosis of high blood pressure. These are the things which are being promoted or disseminated as information from the World Hypertension League, which is going to spread across the globe. This World Hypertension Day not only concentrates on awareness, screening, but also control of blood pressure. Control of blood pressure, how best we can control the blood pressure. Is it only with the lifestyle modification, or is it combined with lifestyle modification with the drugs? And people are recommending, these are the messages that they are giving it depending on the blood pressure, what is diagnosed in a particular individual. So the guidelines are framed by various societies. The World Hypertension League promotes those guidelines and then incorporates that into the World Hypertension League newsletters also, so that the public will get benefited about this high blood pressure. Why high blood pressure? This high blood pressure is considered as a silent killer, because without any symptom, the patient can go on and on till he breaks the blood vessel in the brain, till he gets heart attack, till he gets heart failure. Slowly, he may get into the problems of kidney failure. It can also affect the blood vessels, various parts of the body. The lower limb blood vessels can get affected, upper limb blood vessels can get affected. Suddenly, the patient's heart rate can become abnormal. It may be probably 300, 200, which is called as atrial fibrillation. And that will also produce in the form of stroke, also can happen as a complication of this atrial fibrillation. In addition, these patients can also get into problems of dementia. This is most important, because the dementia is the one which is not noticed by many people who are taking the healthcare in their hands. The healthcare provider need to understand what is dementia. The dementia can occur in those people with uncontrolled hypertension, even if they are middle-aged people. Not that it should occur only about around the age of 60 or 70 years. It can occur even at the age of 40, 50 years also. I have seen a number of patients like that coming and telling me that the memory is going down. That is because the blood pressure, which is very high. So you need to control the blood pressure. If you are able to control the blood pressure properly, the dementia will also be reduced. The cognitive difficulties will also become reduced. So we need to concentrate on all these issues. That is why the World Hypertension Day is getting commemorated on this particular day as an event, which will create awareness, which will create about screening, which will create about the methodology of the blood pressure measurement, the proper diagnosis of blood pressure, and then the complications which need to be highlighted to the patients and the public, so that they will become aware about the complications, and then they will seek medical advice quickly. Today, we have arranged free health camp here, particularly focusing attention on how blood pressure can be measured. A normal blood pressure, which was used in the olden days, was a mercurial manometer, where the doctors used to pump it, and then the mercury will go up, and then they try to put the stethoscope and then examine. So that is the one which was being practiced many, many years ago. And of course, for the past 20 years or so, we stopped doing it because the mercurial problems are encountered across the globe as one of the important environmental poison. So we don't want to use mercury anymore. People have now designed various instruments which are called automated oscillometric devices are available. Semi-automatic oscillometric devices are available. These devices are patient friendly, and you can probably measure the blood pressure any number of times, even at home. The small blood pressure apparatus which are now being used for you people to undergo the blood pressure measurement here are the one that is recommended by all of us. If you are able to buy that particular machine, it is possible to examine not only your blood pressure, your patients, your people who are at home, their blood pressure can also be measured. Even children who are obese, they need to be submitted for a blood pressure estimation. Please remember that the blood pressure is the one that can occur not only due to genetics, but also due to environmental factors. The environmental factors are playing a major role in the acceleration of the blood pressure, and the genetics probably play a single role or a smaller role. You need to understand that What are the environmental factors? Poor dietary habits. In the sense, we try to probably depend on the fast food and then the processed food, or the one that is containing high saturated fat, high cholesterol content food. All those things are being enjoyed by our people. I think it is the one thing that is being as an important activity by the youngsters, particularly when they are working at home or when they are working in the office. Also, they buy something and then bite it. Burgers, cheese, butter, all those things. Saturated fat. One thing that accelerates the blood pressure. All the food items contain high quantities of salt. Normally, in our country, people are consuming more than 10 grams of salt. What is recommended today is only less than 5 grams of salt. It is 1 teaspoonful of salt. You take it, take away the top of it. What is remaining in the spoon? Tablespoon, not tablespoon, is only spoon, teaspoon. That teaspoon that contains only 5 grams of salt. That is the one that is recommended for the entire day. I think it is easy. Your taste buds will get used if you are going to reduce your salt, and after some time, you will feel that you will have a normal taste. It is going to take only about 10 days for you to appreciate that there is a reduction of salt. In United Kingdom, people have reduced the salt content in the bread, and they started supplying it to people without informing them. The people did not appreciate any sort of reduction in the salt content of the bread. So all of them had the same quantity of salt which was used. They were probably imagining the same quantity was used, but they reduced the salt content. But they were able to appreciate the same taste of the bread. So I'm trying to tell you that you need to reduce the salt in your diet. There's the most important culprit, not only for the initiation of blood pressure, but also an acceleration of blood pressure, not acceleration of the complications, including stroke and heart attack. If you reduce the salt, you can reduce the complications. If you reduce the salt, you can reduce onset of blood pressure. If you reduce the salt, you can probably give a healthy life for your people who are seeking advice. This is not only the advice that is given for my fellow colleagues who are seated here. It is an advice, general advice given to all of you, so that the one thing that you can practice at home is to reduce the salt, reduce the salt, reduce the salt. I am reminded about a comment given by Crazy Mohan some years back. Uppilla pandam kuppayile, remove it. Uppilla pandam thoppayile, அப்படின்னு சொன்னார். Still I am trying to recollect it. So you need to remember that reduction of salt will pave a way for these individuals to get rid of the problems of hypertension and its complications. So remember, all these important messages that we are going to give it today is not only going to help those doctors who have assembled here, not only to those 100 people or 150 people who are assembled here, it should go beyond. If you leave the hall, at least some messages what you are getting out of this particular meeting should be the message that you are going to give it to your people at home. And when you are walking, you need to tell that I have attended such a program yesterday. People were discussing about so many things, and you need to control the blood pressure. Lifestyle alone may not be sufficient. You need to go and seek the doctor's advice so that blood pressure will come down quickly with the medications. If you are able to control the blood pressure within a matter of 6 months after starting therapy by your doctor, you will live for a long period. The cardiovascular events like heart attack, stroke events come down. The scientific evidence tells you earlier the better. And if you are reducing the blood pressure to the goal what we want, it is within a matter of 6 months, you will get the maximum benefit of reduction of cardiovascular events. I think I've narrated the entire thing. One thing that I would like to tell you is that the World Hypertension League is involved in various activities, including the Congress, which is conducted once in 2 years. Last year in 2025 in Chennai, we had a big Congress called World Hypertension Congress that was attended by very well-known people in the field of hypertension. Who is who in hypertension to dictate terms how to control the blood pressure. They were all there during our meeting. That meeting has been now recognized as a benchmark for people to follow in 2027, which is going to happen in Brazil. So people are shifting their conference venue also. It is going to be happening in Brazil. Every time when I get involved for the meetings which are arranged by these people, they always mention Chennai meeting was the best meeting. Always they tell. So the amount of involvement by all our colleagues who had responded to my invitation, that shows not only the love, not only the affection, your involvement in spreading the knowledge to these people who have assembled here. your dedication to spread the knowledge across your own colleagues, across the entire world. So that is the one that I thought I should tell you. If you have any questions, please ask me. I think I've narrated everything in English. Would like to ask in Tamil? If you want, you can ask. No problem. I'll ask Dr. Y.V. Reddy regarding high blood pressure and heart attack. Tell me.
Heart attack and stroke காமனஸ்ட் கில்லர் டிசீஸ் உலகத்துல நம்ம நல்ல இதுக்கு காமனஸ்ட் காரணம் ஒரு சிங்கிள் காரணம் சொல்லுவேன்னா ஹை பிளட் ப்ரெஷர், சுகர், கொலஸ்ட்ரால், ஓவர் வெயிட், செடென்டரி லைஃப் ஸ்டைல் எல்லாம் இருந்தாலும் காமனஸ்ட் ரீசன் வந்து ஹை பிளட் ப்ரெஷர். வெரி ஈஸி டு டயக்னோஸ், 10 seconds, நோ காஸ்ட். ஒன்ஸ் டயக்னோஸ் பண்ணப்பறம் லைஃப் ஸ்டைல் சேஞ்சஸ்ல ஈஸியா சரியா பண்ண முடியும் ஏர்லி ஸ்டேஜஸ்ல. அதுக்கப்புறம் மெடிசின்ஸ் யூஸ் பண்ணிட்டு nowadays the medicines also are very less expensive, easy to monitor, control ஆயிடுச்சு எல்லாம் கண்ட்ரோல் பண்ண முடியும். So one reason that can be controlled easily and can reduce heart attack and stroke is high blood pressure. That is why உலக ஹைப்பர்டென்ஷன் நாள் இன்னைக்கு செலிப்ரேட் பண்றேன். எல்லாருக்கும் இந்த ஃபோக்கஸ் வரணும், ஈஸியா சரியா பண்ணணும்.
I think Shanmugam, can you just tell about the lifestyle modification in the form of physical activity quickly?
ரத்த அழுத்தம் குறையணும்னா பிசிக்கல் ஆக்டிவிட்டி ரொம்ப இம்பார்ட்டன்ட். அது வந்து குழந்தையில இருந்து ஆரம்பிக்கும். இப்போ பள்ளிக்கூடத்துல எல்லாம் நிறைய இதுல கிரவுண்ட் இல்லை, பில்டிங் தான் நிறைய இருக்கு. அந்த காலத்துல கிரவுண்டு நிறைய இருந்துச்சு. ஈவன் கிரவுண்ட் இல்லைன்னா கூட நம்ம குழந்தைகளை வந்து சின்ன வயசுல இருந்தே விளையாட்டுத்துறையில ஈடுபடுத்துறதுல வந்து எல்லா விளையாட்டும் விளையாடலாம். அது ஈஸியான சிம்பிளான வந்து அடல்ட்டும் பார்க்க வேண்டியது வந்து வாக்கிங். சிம்பிள் வாக்கிங் இஸ் வெரி குட். டெய்லி அட்லீஸ்ட் ஒரு 30 நிமிஷம் வாக் பண்ணலாம். அது காலையிலையோ சாயங்காலமோ உங்களுக்கு நேரம் எப்போ கிடைக்குதோ பண்ணலாம். அதே மாதிரி ஆஃபீஸில் இருக்கும்போது நீங்கள் வந்து கால் கையெல்லாம் ஆட்டி இடையில எழுந்து போயிட்டு நீங்கள் பண்ணலாம். வீட்டிலே பண்ணால் நீங்கள் டம்பிள் வச்சுக்கிட்டு இல்லை சைக்கிள் வச்சுக்கிட்டு இந்த மாதிரி உடற்பயிற்சி தினம் செஞ்சீங்கன்னா, அது வந்து விட்டெல்லாம் பண்ணக்கூடாது. தினம் பண்ணீங்கன்னா கட்டாயம் உங்களுக்கு ரத்த அழுத்தம் கம்மியாகும்.
Parandaman, why not you tell something about the pregnancy hypertension?
ஒரு பிரெக்னன்சி வந்தவங்களுக்கு ஹைப்பர்டென்ஷன் வந்துச்சுனாக்கா 2 வகையில் வரும். ஒன்று வந்து குழந்தை உள்ள கருவில் இருந்து கருனால வந்து பிபி வரலாம், இல்லை அம்மா வந்து ரொம்ப பருமன் அதிகமாக இருந்து சுகர் அதிகமாக இருந்து அதனால பிபி வரலாம். இட்ஸ் கால்ட் ப்ரீ ஜெஸ்டேஷன் டயபிட்டிஸ் அண்ட் ப்ரீ எக்லாம்சியா, லேட் எக்லாம்சியா. ஸோ அதனால கருனாலே அம்மாவுக்கு பிபி வரும், அம்மாவனாலே குழந்தைக்கு பிபி ஏறி அந்த வந்து குழந்தை அஃபெக்ட் ஆகும். ஸோ இதில் என்ன முக்கியம்னாக்கா, இப்போ வந்து கல்யாணம் பண்ணுறது கஷ்டமா லேட் ஆகுது, கல்யாணம் பண்ண பிறகு குழந்தை பிறகு லேட் ஆகுது, குழந்தை பிறந்து அது நம்மளை பிறகு அதுவும் கஷ்டமா இருக்கு. இது என்ன காரணம் சொன்னாலும் லைஃப் ஸ்டைல். சின்ன வயசுல இருந்து அடாலசன்ட் ஏஜ்ல இருந்து 15-17 வயசுல இருந்து நம்ம உடல் பருமனை பார்த்துட்டு டயட்லாம் கரெக்டாக பார்த்து மெயின்டைன் பண்ணிட்டு சுகர் இல்லாமல் பிபி இல்லாமல் பார்த்துட்டே வந்தாக்கா உங்களுக்கு வந்து ஏர்லியா உங்களுக்கு வந்து காம்ப்ளிகேஷன் இல்லாமல் குழந்தை வந்து நமக்கு வந்து ப்ராப்ளம். இப்போ லேட்டாக மேரேஜ் ஆகிறதுனால எல்லாம் வந்து உங்களுக்கு டயபெட்டிஸ் ஹைப்பர்டென்ஷன் முதல்ல வந்துடுது, ஈவன் பிஃபோர் மேரேஜாக வந்துடுது. அதுக்கு பிறகு வந்து ப்ரெக்னன்சியில் வந்து உங்களுக்கு காம்ப்ளிகேஷன் வந்து. ஸோ அது நம்ம ப்ரெக்னன்சியில் வந்து பிபி வந்துச்சுனாக்கா அம்மாவுக்கு காம்ப்ளிகேஷன். ஏன்னா பிபி வந்து கொஞ்சம் ஸ்ட்ரோக் வந்துடும், பிபி வந்தால் ஸ்ட்ரோக் வந்துடும். ப்ரெக்னன்சியில் கொஞ்சம் பிபி ஆனாலும் ஸ்ட்ரோக் வந்துடும். ஸோ நம்ம வந்து 200 போகணும் அவசியம் இல்லை, 150-160 போனாலே வந்து ஸ்ட்ரோக் வந்து வாய்ப்பு நிறைய இருக்கு. பிகாஸ் ஆஃப் ப்ரெக்னன்சி. அதனால ப்ரெக்னன்சியில் வந்து ஹைப்பர்டென்ஷன் வந்துச்சா ரொம்ப கரெக்டாக ஸ்க்ரீன் பண்ணி கரெக்டாக கண்ட்ரோலே வச்சுக்கணும். அந்த 140-130 வச்சு இல்லை அப்படின்னு சொன்னா காம்ப்ளிகேஷன் வந்துடும். குழந்தைக்கும் ப்ராப்ளம் இருக்கும், அது அம்மாவுக்கும் ப்ராப்ளம் இருக்கும். அதனால இதை தடுக்கணும்னு சொன்னா நம்ம பிரெக்னன்ட் ஆன பிறகு குறைக்கிறத விட பிரெக்னன்ட் ஆகிறதுக்கு முன்னாடியே நம்ம வந்து பிளான் பண்ணி அந்த பிபியே வராத மாதிரியும் அது பிபி வந்தா அதுக்கு உடனே எஃபர்ட் எடுத்து அது பிபியை குறைச்சி காம்ப்ளிகேஷன் வராமல் தடுத்தா நல்லது.
Shruti, I think I should ask you about secondary hypertension. நம்ம பிளட் ப்ரெஷர்னு சொன்னால் ஒன்றுமே காசு இல்லை. டாக்டர்கிட்ட போய் எதுக்கு சார் எனக்கு பிளட் ப்ரெஷர் வந்தது, நான் ஒன்றும் ஒபிஸாக இல்லை, நான் குடிக்கிறது இல்லை, நான் சிகரெட் பிடிக்கிறது இல்லை, அப்பாவுக்கு இல்லை பிபி, எனக்கு ஏன் சார் பிளட் ப்ரெஷர் வந்தது அப்படின்னு கேட்டால் நாங்கள் போடுறது பிரைமரி ஆர் எசென்ஷியல் ஹைப்பர்டென்ஷன். பிரைமரி ஆர் எசென்ஷியல்லாம் ஒன்றுமே கிடையாது. நாட் தட் எசென்ஷியல் இட் ஷுட் பி தேர் ஃபார் எவ்ரிபடி, but some terminology was introduced by older people and we continue to use the same terminology. But there are certain situations where the blood pressure can be rectified provided the doctor is able to diagnose the problem in an appropriate way. And that's where Dr. Shruti comes to give us some explanation on it.
காரணம். ஸோ சார் சொன்ன மாதிரி பிளட் ப்ரெஷர் மற்ற காரணத்தினாலே வரலாம். அதை செகண்டரி ஹைப்பர் டென்ஷன் சொல்லுவோம். அதை காமனா பார்த்தோம்னா நம்ம ஊர்ல பார்த்தோம்னா ஈவன் சிம்பிள் தைராய்டு ப்ராப்ளம் கூட பிளட் ப்ரெஷர் வரலாம். எஸ்பெஷலி கீழே இருக்கிற நம்ம டயஸ்டாலிக் பிளட் ப்ரெஷர் ஒரு இந்த ஹைப்போ தைராய்டு கம்மியா இருக்கு, அதுல கூட நமக்கு வந்து பிளட் ப்ரெஷர் வரதுக்கு வாய்ப்பு இருக்கு. ஸோ தைராய்டு ஸ்கிரீனிங் கண்டிப்பா ஒரு எண்டோக்ரைனாலஜிஸ்ட் ஒரு ஹார்மோன் ஸ்பெஷலிஸ்ட் தான் நாங்கள் பண்ணுவோம். அதை தவிர இப்போ அவங்க கிட்ட ஹிஸ்ட்ரி கேட்கும்போது நம்ம கிட்ட பேசி எக்ஸாமின் பண்ணும்போது வேற ஏதாவது எங்களுக்கு ஹிஸ்ட்ரியில எங்களுக்கு வந்து கிட்னிக்கு மேல ஒரு சின்ன கிளாண்ட் அட்ரினல் கிளாண்ட் அப்படிங்கிறது, அந்த அட்ரினல் கிளாண்ட்ல இருந்து நமக்கு ஹார்மோன்ஸ் வருது. அதுல இருந்து ஆல்டோஸ்டரோன் ஒரு ஹார்மோன் இருக்கு, எபினெஃப்ரின், உடம்புக்கு தேவைப்படுற ஹார்மோன்ஸ் வந்து அது வந்து இம்பார்ட்டன்ட் ஹார்மோன்ஸ். சில சமயம் அது அதிகமா சுரக்கிறதுக்கு வாய்ப்பு இருக்கு. அது முக்காவாசி நம்ம பேஷண்ட்ஸை பார்க்கும்போது ஹிஸ்ட்ரி கேட்கும்போதே எங்களுக்கு ஓரளவுக்கு தெரியும். அந்த மாதிரி ஏதாவது ஹார்மோன் அதிகமா இருக்கும் அப்படின்னு தோணுதுன்னா இந்த அட்ரினல் கிளாண்ட்ல இருந்து வரக்கூடிய ஹார்மோன் இவாலுவேஷன் பண்ணும். ஆல்டோஸ்டரான் ரினன் ஒரு ஹார்மோன் இருக்கு. இப்போ பாத்தீங்கன்னா 10 to 20% ஆஃப் த ஹைப்பர் டென்ஷன் வந்து இந்த ஆல்டோஸ்டரான்ற ஹார்மோன் அதிகமா இருக்கிறதுனால வரக்கூடும் அப்படின்னு சொல்றாங்க. அது சார் சொன்ன மாதிரி ரொம்ப ஈஸியா ஐடென்டிஃபை பண்ணோம்னா ஒரு சில ஹைப்பர் டென்ஷனை நம்ம கியூரே பண்ண முடியும் என்னன்னு கண்டுபிடிச்சோம்னா. ஸோ இந்த ஆல்டோஸ்டரான்ற ஹார்மோன் அப்புறம் இந்த மெட்டானெஃப்ரின்ஸ், நான் மெட்டானெஃப்ரின்ஸ், இந்த அட்ரினல் கிளாண்ட்ல வரக்கூடிய சுரபிகளை நம்ம டெஸ்ட் பண்ணுவோம். அது காமன் ரீசன் பாத்தீங்கன்னா நம்ம ரொம்ப காமனா பார்க்கறது விட்டமின் டி டெஃபிஷியன்சி, விட்டமின் டியோட குறைபாடு. விட்டமின் டியோட டெஃபிஷியன்சியில கூட சில சமயம் ஹைப்பர் டென்ஷன் வரலாம் அப்படின்னு ஒரு சில அசோசியேட்டட் ஸ்டடிஸ் வந்து நமக்கு சொல்லுது. ஸோ விட்டமின் டி ஸ்கிரீனிங் சொல்லுவோம். விட்டமின் டி ஸ்கிரீனிங்க்கு முன்னாடி சிம்பிளா ஒரு டெஸ்ட்னா கால்சியம் டெஸ்ட். உடம்புல சீரம் எல்லாருக்குமே கால்சியம் இருக்கு. கால்சியம் நம்ம உடம்புல பாராதார்மோன் ஒரு கிளாண்ட் மெயின்டைன் ஆகுது. கால்சியம் அதிகமா இருந்தா கூட விட்டமின் டி கம்மியா இருக்கிறது எப்படி இம்பார்ட்டன்ட்டோ அதே மாதிரி உடம்புல கால்சியம் அதிகமா இருந்தா கூட அதனால பிளட் ப்ரெஷர் வரலாம். அது வந்து அதுலயும் ஹைப்பர் டென்ஷன், பிரைமரி ஹைப்பர் பாராதைராய்டிசம்னு சொல்லுவோம். அந்த ஒரு மெடிக்கல் கண்டிஷன்ல கால்சியம் அதிகமாச்சுன்னா அந்த கால்சியம்னால ஹை பிளட் ப்ரெஷர் வரதுக்கு வாய்ப்பு இருக்கு. ஸோ இதெல்லாம் வந்து எல்லாருக்கும் ஸ்கிரீன் பண்ணுவோமான்னு பாத்தீங்கன்னா ப்ராபபிலி நாட். நம்ம ஊர்ல ரொம்ப காமன் பார்க்கறது இந்த கொரட்டை அப்ஸ்ட்ரக்டிவ் ஸ்லீப் ஆப்னியான்னு சொல்லுவோம். அதுல கூட நிறைய ஹார்மோன் டெஃபிஷியன்சி எஸ்பெஷலி பாத்தீங்கன்னா செக்ஷுவல் டிஸ்ஃபங்க்ஷன் வரலாம், ஹைப்போகோனாடிசம்னு சொல்லுவோம், மேல் ஆண்மை தன்மை குறையலாம். ஸோ இதெல்லாம் நம்ம கிளினிக்கலா ஒரு பேஷண்ட் கிட்ட ஹிஸ்டரி கேட்கும்போது அவங்கள பார்த்து எக்ஸாமின் பண்ணி கேட்கும்போது ஏதாவது ஒரு குறைபாடோ இல்லை அதிகமா சுரக்கிற வாய்ப்பு இருக்குதுன்னா அந்த பர்டிகுலர் டெஸ்ட் அவங்களுக்கு பண்ணி அதனாலதான் சார் சொன்ன மாதிரி டாக்டரை கன்சல்ட் பண்றது ரொம்ப ரொம்ப இம்பார்ட்டன்ட். நான் ஹைப்பர் டென்ஷன் பல வகைகள் பல அதர் ரீசன்ஸ்னால கூட வரதுக்கு வாய்ப்பு இருக்கு. ஸோ இந்த மாதிரி ஏதாவது ஐடென்டிஃபைபிள் காசஸ் நம்ம பிளட் ப்ரெஷர் இருந்ததுன்னா அதை கண்டுபிடிச்சு ட்ரீட் பண்ணோம்னா கண்டிப்பா உங்களுக்கு பிளட் ப்ரெஷரும் கம்மியாகும். அதனால வரக்கூடிய ஹார்ட் டிசீஸ், ஸ்ட்ரோக், வாட் எவர் காம்ப்ளிகேஷன் பேசிட்டு இருக்கோமோ அதெல்லாமும் குறையறதுக்கு வாய்ப்பு. ஸோ அதனாலதான் ஒரு செகண்டரி ஹைப்பர் டென்ஷன் இவாலுவேஷன் இஸ் ரிக்வயர்ட் ஃபார் சம்.
ஒபேசிட்டி உங்களுக்கு தெரியும். ஒபேசிட்டி மூணுல ஆக்சுவலி 3 பேர் பார்த்தீங்கன்னா ஒருத்தர் ஒபீஸாக இருப்பாங்க. இட் இஸ் இன்க்ரீசிங் இன் அலார்மிங் ப்ரொபோர்ஷன்ஸ் இன் அவர் கண்ட்ரி. அதனால வந்து ஒபேசிட்டி உடல் பருமன் அதிகமாக வந்து பிளட் ப்ரெஷர் ஏறுது. சந்திரசேகர் வில் டெல் மீ நவ்.
உடல் பருமன்றது இப்போ வந்து நம்ம எல்லாத்துக்கும் காமனா நம்ம பார்த்துட்டு குழந்தைகள்ல இருந்து நம்ம குழந்தைங்க பிறக்கும் போதே குழந்தை வந்து நல்லா சட்டியா இருக்குன்னு நம்மளுக்கு எல்லாருக்கும் பிடிக்கும். அது 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 மாதிரி பார்த்து நம்ம வளர்ந்ததுனால குழந்தைங்க கொஞ்சம் குண்டா இருக்காங்கன்னா இந்த உடல் பருமன் கொஞ்சம் அதிகமா இருக்குன்னா அவங்க வந்து ஆரோக்கியமா இருக்காங்கன்னு நம்ம வந்து நிறைய டைம் நம்ம நினைக்கிறோம். பட் அது வந்து கிடையாது. ஒவ்வொருத்தங்களுக்கும் ஒரு சராசரி அவங்களுடைய வயதை பொறுத்து குழந்தைங்களா இருந்தா இல்ல கொஞ்சம் வயசானவங்க அடல்ட் அது மாதிரி இருந்தாங்கன்னா அவங்களுடைய எடையை பொறுத்து அவங்களுடைய ஹைட் வெயிட் அந்த இதுன்றது மாறும். அது பிஎம்ஐ பொறுத்து ஒவ்வொருத்தங்களுக்கும் அவங்களோட உடல் அமைப்பை பொறுத்து மாறும். இந்த உடல் பருமன் அதிகமாகல என்ன ஆகுதுன்னா நம்மளோட உடல் அதிகமாகும் போது நம்மளுடைய ஹார்ட்டுடைய வேலை அதிகமாகும். அதுவும் இல்லாம நம்ம உடல் பருமன் இருக்கும்போது நிறைய சுரப்பிகள் நம்ம உடம்புல சுரக்கும். அடிப்போகைன்ஸ் நிறைய ஹார்மோன்ஸ் உங்களுக்கு வந்து அந்த இது சுரக்கும் போது அந்த ஹார்மோன்கள் வந்து நம்மளுடைய சிம்பத்தட்டிக் நர்வஸ் சிஸ்டம் அந்த அட்ரினல் கிளாண்ட் சொல்றாங்கல்ல, ஸோ அந்த இதுல இருக்க சுரப்பு தன்மையை வந்து நம்மளுக்கு வந்து அதிகப்படுத்துறதுக்கு நிறைய வாய்ப்புகள் உண்டு. ஸோ இந்த உடல் பருமன் அதிகமா இருக்கும்போது சின்ன வயசுல இருந்தே நம்ம இது மாதிரி இருக்கிறது வந்து ஒரு ப்ராப்ளமா இருக்கும்போது இந்த காலகட்டத்தில் நிறைய பேருக்கு மிடில் ஏஜ்லேயே நம்ம வந்து பார்க்குறோம். சின்ன குழந்தைங்களுக்கு கூட நம்ம வந்து பார்க்குறோம். நிறைய பேருக்கு பிபி இருக்கிறது ஏன் பார்க்குறோம்னா இந்த உடல் பருமன்றது ஒரு முக்கியமான காரணியா நம்ம பார்க்குறோம். ஸோ இந்த இதுல வந்து நம்ம என்ன பண்ணணும்னா ஒருத்தவங்களுக்கு உடல் பருமன் கொஞ்சம் அதோட பிபியும் அதிக அளவுல ரத்த அழுத்தம் அதிகமா இருந்துச்சுன்னா அதுக்கேற்ற மாதிரி உடல் பருமன் கம்மி பண்றதுக்கு சரியான முறையில மருத்துவருடைய வழிகாட்டுதல் பேர்ல அவங்க வந்து உணவு முறைகள் வந்து கரெக்டா எடுக்கணும், எக்ஸசைஸ் ரெகுலரா அவங்க வந்து பண்ணணும், அது வந்து தொடர்ந்து பண்ணணும். அதுதான் ரொம்ப ரொம்ப இம்பார்ட்டன்ட். இப்போ வந்து உடல் எடையை கம்மி பண்றதுக்கும் நிறைய மருந்துகள் வந்து இருக்கு. அதனால வந்து நிறைய பேர் வந்து 10 கிலோ 20 கிலோ 30 கிலோ வரைக்கும் கூட அவங்க உடல் எடையை கம்மி பண்றதுக்கு நிறைய வாய்ப்புகள் இருக்கு. இதன் மூலமா அவங்க வந்து ரத்த அழுத்தத்தையும் கட்டுக்குள்ள வச்சுக்கலாம். 6 வருஷங்களுக்கு ரத்த அழுத்தம் வந்து மாத்திரைகள் போட்டுட்டு வராங்க, எனக்கு வந்து கண்ட்ரோலே ஆக மாட்டேங்குது ரத்தம் நிறைய பேர் சொல்றது நம்ம கேட்டிருக்கோம். அதுக்கு அவங்க மாத்திரைகள் தொடர்ந்து போட்டாலும் அந்த வழிகாட்டுதல் பேர்ல எக்ஸசைஸ் மீது பண்ணாலும் உடல் எடையை கட்டுப்படுத்தலைன்னா அவங்களுக்கு வந்து இந்த பிபிங்கிறது கண்ட்ரோல்ல வரவே வராது. அதனால உடல் எடை அதிகமாகுதுங்கிறது ஒபிசிட்டிங்கிறது ஒரு முக்கியமான காரணியா இந்த ரத்த அழுத்தத்துக்கு நம்ம வந்து பார்த்துருக்கோம். அதை கட்டுக்குள்ள வச்சுக்கிறது ரொம்ப ரொம்ப நல்லது.
ரத்த கொதிப்பு அதிகமாகும் போது கிட்னி பாதிக்குது. ரொம்ப ஏர்லியா எப்படி கிட்னி பாதிப்பை கண்டுபிடிக்க முடியும் டாக்டர் சவுந்தரராஜன்?
கிட்னிக்கும் பிளட் ப்ரெஷருக்கு என்ன சம்பந்தம் அப்படின்னு ஏதோ முட்டத்தாய்க்கு முழங்காலுக்கு முடிச்சு போகலான்னு நினைச்சுக்காதீங்க. கிட்னிங்கிறது விக்டிம் ஆஃப் ஹைப்பர்டென்ஷன், ஆல்சோ வில்லன் ஆஃப் ஹைப்பர்டென்ஷன். கிட்னி வந்து பிளட் ப்ரெஷர்னால பாதிக்கப்படலாம். பிளட் ப்ரெஷர் வர்றதுக்கு கிட்னி காரணமா இருக்கலாம். குறிப்பா இளம் வயதுல வர பிளட் ப்ரெஷர். மேடம் சொன்னபடி பிரெக்னன்சி அப்போ வர பிளட் ப்ரெஷர், அதாவது முத குழந்தைக்கு பிளட் ப்ரெஷர் வரும், ரெண்டாவது குழந்தைக்கு பிளட் ப்ரெஷர் வருதுன்னா கிட்னி சரியா இருக்கான்னு பார்க்கணும். அதே மாதிரி வந்து நமக்கு பிளட் ப்ரெஷர் கொடுத்து மருந்துகளால கட்டுப்படலை அப்படின்னு சொன்னா கிட்னி ரீசனா இருக்கும். அதுக்கு நம்ம டீடைல் டெஸ்ட் எடுக்கணும். எல்லாத்தையும் விட நான் பார்க்குற வாரத்துக்கு 100 கிட்னி ஃபெயிலியர் பார்த்தேன்னா அதுல வந்து 20 பேர் பிளட் ப்ரெஷரை டயக்னோஸ் பண்ணி ஒழுங்கா மருந்து மாத்திரை சாப்பிடாதோம். பிளட் ப்ரெஷர் கண்டுபிடிச்சு பிற்பாடும் டாக்டர் எழுதி கொடுத்த டாக்டர் இடையில விட்டுட்டு டாக்டர் மறந்துட்டேன் டாக்டர் அப்படின்னு சொல்றது ரொம்ப காமன். பிளட் ப்ரெஷர் கண்டுபிடிச்ச பிற்பாடும் நம்ம மருந்து சாப்பிடாம இருக்கிறது நமக்கு நாமே வாழ்நாள சீக்கிரமா உயிர் எழுதி வச்சுக்கிற மாதிரி நாம நினைச்சுக்கணும். அதனால பிளட் ப்ரெஷர் என்பது பல உறுப்புகளை பாதிக்கும், இதயத்தை பாதிக்கும், கண்ணை பாதிக்கும், கிட்னியை பாதிக்கும், நரம்பு மண்டல பாதிக்கும். அதனால எல்லா பிளட் ப்ரெஷர் பேஷண்ட்ஸ்க்கும் முழு உடல் பரிசோதனை ஆண்டுக்கு ஒரு முறை பண்ணிக்கிறது, எல்லாம் சரியா இருக்காங்கிற பார்த்துதான் ரொம்ப முக்கியம். இப்போ சத்தியாகிரகம் நடத்தினாங்க அந்த காலத்துல உப்புக்கு எதிராக. இப்போ நம்ம உப்புக்கு வேண்டாம்னு சத்தியாகிரகம் பண்ண வேண்டியது. பிளட் ப்ரெஷருக்கும் உப்புக்கு ரொம்ப சார் சொன்னபடி உப்பு எவ்வளவு சீக்கிரம் குறைக்கிறோமோ எவ்வளவு குறைக்கிறோமோ அது உடம்புக்கு நல்லது. பிளட் ப்ரெஷர் கண்ட்ரோல் பண்றதுக்கு ரொம்ப ரொம்ப முக்கியமானது. பிளட் ப்ரெஷருடைய அளவை குறைக்கிறதுக்கு உப்புனுடைய அளவை குறைக்கிறது சார் சொன்னபடி 5 கிராமா குறைக்கிறது போதும். 20 கிராம்ங்கிறது நாக்குக்கு தான். நாக்குக்கு அடிமை வேண்டாம். நம்ம நிறைய பிரச்சனைகளுக்கு காரணம் நாக்கு தான். அடுத்தவங்களை பத்தி பேசுறதுல இருந்து ருசிக்காக சாப்பிடுறது வரைக்கும் நாக்கை கட்டுப்படுத்துறதுக்கு உப்பை கட்டுப்படுத்தினாலே பிளட் ப்ரெஷர் குறையும்.
தேங்க்யூ சார். ராஜேஷ், பிளட் ப்ரெஷர் கூடவே சில பேருக்கு டயபிட்டிஸ் இருக்குது. டயபிட்டிஸ் முதல்ல வரும், அப்புறம் பிளட் ப்ரெஷர் கூடும். முதல்ல கொலஸ்ட்ரால் வரும், அப்புறம் டயபிட்டிஸ் வரும். இப்படிலாம் காம்பினேஷன் வருது இல்லை? டயபிட்டிஸும் பிளட் ப்ரெஷருக்கும் என்ன தொடர்பு?
டயபிட்டிஸுக்கும் பிளட் ப்ரெஷருக்கும் என்ன தொடர்பு? ரெண்டுத்தையும் பிரிக்கவே முடியாது முதல்ல. ஏன்னா இது தனியாவே நம்ம பார்க்க முடியாது. டயபிட்டிஸ் இருக்கிறவங்களுக்கு பிளட் ப்ரெஷர் இருக்கு. 50% ஆஃப் த பீப்புளுக்கு வந்து டயபிட்டிஸ் கண்டுபிடிக்கும் போதே கூடயே அவங்களுக்கு பிளட் ப்ரெஷர் இருக்கும். அண்ட் இதோட மட்டும் இருக்காது, கூட வந்து கொலஸ்ட்ரால் லெவல்ஸும் ரொம்ப அதிகமா இருக்கும் இந்த மாதிரி பேஷண்ட்ஸுக்கு. ஸோ இதுல என்ன பிரச்சனைனா, டயபிட்டிஸ் எல்லா உறுப்பையும் பாதிக்க போகுது கண்ட்ரோல்ல வைக்கலாம். ஹார்ட், கண்ணு, கிட்னி, மூளை, ரத்த குழாய், நரம்புகள் அத்தனை உறுப்பையும் பாதிக்க போகுது. இது கூட சேர்ந்து பிளட் ப்ரெஷரும் இருந்ததுன்னா இந்த பாதிப்புகள் பல மடங்கு அதிகமாகும். அதாவது நாங்க என்ன சொல்லுவோம்னா, ஈக்குவேஷனே மாறிடும். டயபிட்டிஸும் பிளட் ப்ரெஷரும் சேர்ந்து இருந்ததுன்னா 1 + 1 is not equal to 2. இங்க 1 + 1 is equal to 11 அப்படின்ற மாதிரி சொல்லுவோம். அத்தனை மடங்கு நம்ம உறுப்புகள் பாதிக்கப்படக்கூடிய ரிஸ்க் இது ரெண்டும் இணைஞ்சு இருந்ததுன்னா அதிகமாக்கி விட்டுரும். அதனாலதான் இது அது மட்டும் கிடையாது. ஒருத்தருக்கு டயபிட்டிஸ் அன்கண்ட்ரோல்டா வச்சிருந்தாருன்னா அவருக்கு பிபி இல்லைன்னா கூட மிக விரைவில் அவருக்கு பிபி வந்துடும். இதே மாதிரி தானே இங்கேயும் நடக்கும். பிளட் ப்ரெஷர் மட்டும் இருக்கு, டயபிட்டிஸ் இல்லைன்னா அவர் அந்த பிளட் ப்ரெஷர் அன்கண்ட்ரோல்டா வச்சுட்டு இருக்கிறாருன்னா என்ன ஆயிடும்? சீக்கிரம் பிபி வந்துடும். இதுக்கான தீர்வு என்னன்னா, வாழ்க்கை முறையை நம்ம கரெக்டா வச்சுக்கணும். ஆரோக்கியமான உணவு முறை.
அதே பேசுவாங்க.
பிளட் ப்ரெஷர் மட்டும் நம்ம கண்ட்ரோல் வைக்க முடியாது, டயபிட்டிஸையும் நம்ம கண்ட்ரோல் வைக்க முடியாது. ஸோ இது ரெண்டுத்துக்கும் இருக்கக்கூடிய தொடர்பு வந்து மிக மிக ஆழமான தொடர்பு.
I think Dr. J.C. Sekhar has come from Dindukkal. He is one of the members of our Tamilnadu state chapter. JC Sekhar, how often you are seeing people do alcohol increasing the blood pressure, continues to smoke, and then there is an increase in the blood pressure? How do you tackle those people, and how best you can give the proper advice for them to quit smoking, to quit alcohol? Please.
ரத்த அழுத்தம் ஏற்படுறதுக்கு யார் சொன்ன மாதிரி பரம்பரை காரணம் தான் முக்கியமான சொல்லுவோம். நிறைய நினைச்சிட்டு இருக்கோம். பரம்பரை காரணம் மட்டும் இல்லாம வாழ்க்கை முறைனா ரத்த அதிகமாக முக்கியமான காரணம் ஸ்ட்ரெஸ், உணவு கட்டுப்பாடு இல்லாம இருக்கு, நிறைய ஃபாஸ்ட் அடிமையா இருந்து
Hypertension, dyslipidemia.
3 ரிஸ்க் ஃபேக்டரையும் மல்டிபிள் ஃபோல்ட் ஸ்மோக்கிங்
heart failure.
அன்பார்ச்சுனேட்லி மெடிக்கல் காலேஜ்ல குறைஞ்சிட்டு இருக்கு, இந்தியாவில் கூட்டிட்டு இருக்கு. ஸ்மோக்கிங்கிறது வீடுகள் குடிக்கு மட்டும் இல்லை, புகையில எந்த உற்பத்தியும் வீடியோ, சிகரெட்டோ, குட்காவோ, புகையில போட்ட பான் நடுறது, மூக்குப்படி எல்லாமே ஹை ரிஸ்க் தான். ஒவ்வொரு டோஸ் நம்ம புகையில உடம்புல போகும்போதும் பிபி உடனே ரைஸ் பண்ணி அடுத்தடுத்து தாங்க அடிக்க புகையில ஒண்ணு மட்டும் உடம்ப பாதிக்காதங்கமே கிடையாது. மூளையில இருந்து, இதயத்திலிருந்து, கிட்னில இருந்து, லங்ஸ்ல இருந்து எல்லாத்தையும் பாதிக்கும். அந்த பிபிக்கு ஒரு முக்கியமான காரணம் ஸ்மோக்கிங். ஸ்மோக்கிங் இன்னைக்கு குறைக்க ஆரம்பிச்சிட்டாலே பிபி வந்து குறையாது. 2 வருஷம் 3 வருஷத்துல நல்லா ஓரளவுக்கு ஸ்டேபிளான இது வரும். ஸ்மோக்கிங் குறைக்காம நம்ம வந்து பிபி குறைக்கிறது நமக்கு வாய்ப்பே கிடையாது. ஸ்மோக்கிங் திடீர்னு நிப்பாட்ட முடியாது. திடீர்னு நிப்பாட்டா வந்து படிப்படி நிப்பாட்டுறது ரொம்ப கஷ்டம். ஜோ கூட சொல்லுவாங்க, ஐ ஸ்டாப் ஸ்மோக்கிங் மெனி டைம்ஸ், ஒரு ஜோக் சொல்லுவாங்க. நிறைய பேர் நிப்பாட்டேன், அவங்களை நிப்பாட்டேன் முள்ளுன்னு இருப்பாங்க. ஸ்மோக்கிங் வந்து சுத்தமாக விட்டுரும். ஃபர்ஸ்ட் பேசிட்டு பேசுறதே, நீ உங்க குழந்தைய முக்கியமா, உங்க குடும்பம் முக்கியமான ஸ்மோக்கிங் நிப்பாட்டு வந்து நாங்கள் பேசியே ஆரம்பிப்போம். ஸ்மோக்கிங் சைலண்ட் கில்லர். ஸ்மோக்கிங் வந்து புகைப்பிடிக்கிறது மட்டும் இல்லாம கூட உள்ளவங்களையும் பாதிக்கும். செகண்ட் ஹவுஸ் ஸ்மோக்கிங் பார்க்க வீட்டோட புகைப்பிடிச்சா மனைவி, அவங்க குழந்தைங்க, குடும்பம் எல்லாத்தையும் பாதிக்கும். ஒரு ஸ்மோக் பண்ற ஒரு லேடி மாசமா இருந்தாங்கன்னா அவங்க அப்பா ஸ்மோக் பண்ணிட்டு தான் இருந்தாங்க. அந்த லேடியோட குழந்தைய கற்பத்தை பாதிக்கும். தேர்ட் ஸ்மோக்கிங் பாதிப்பு. ஸ்மோக்கிங் அவ்வளவு மோசமான பழக்கம். அந்த புகையில பழக்கத்தையும் வீட்டுக்கு நிப்பாட்டுது ரொம்ப முக்கியமான ஒன்று. அதை ஒவ்வொருத்தையும் நம்ம கேட்டே இருக்கணும். ரொம்ப கஷ்டம், ஈஸி கிடையாது. பட் பேஷண்ட் மோட்டிவேட் பண்ணணும், கட்டாயம் நம்ம மாற்றணும். ரெண்டாவது ஆல்கஹால் வந்து எந்த வித நம்ம அலோ பண்ணவே முடியாது. ஆல்கஹால் அப்படிதான் மூளை, கிட்னி, இதயம், கணையம் எல்லாத்தையும், கல்லீரல் எல்லாத்தையும் ரொம்ப பிபி பாதிப்பு ஏற்பட்டு பாதிப்பு. சார் கொஞ்சம் போட்டீங்க சார், லைட்டா பாடிக்கிறேன், இல்லை அந்த பேச்சே வேணாம். ரொம்ப வித்தியாசமான ஒரு எஃபெக்ட் அடிக்க சொல்றாங்க. பட் அதுவுமே நம்ம இந்தியன் சுச்சுவேஷனுக்கு ஆல்கஹால் நெவர்ங்கிற பிடிக்கும். ஆல்கஹால் சாப்பிட்டோம்னா நம்ம இழக்கிறோம், கணக்கெட்டு நம்ம இழக்கிறோம். டைரக்டா பிபி அதிகமாகிறதுக்கு முக்கியமான காரணம் இருக்கு. ஸோ நம்ம நல்ல நலமான வாழ்வு வாழணும், குடும்பம் நல்லா இருக்கணும்னா ஸ்மோக்கிங்கும் ஆல்கஹாலும் இல்லாமல் இது நம்மளா உண்டாகிட்ட ப்ராடக்ட் உடம்பு ப்ராடக்ட் கிடையாது. ஸோ இந்த காலத்தில் பிபி அதிகமாகிறதுக்கு முக்கியமான காரணங்கள் இந்த ஸ்மோக்கிங், ஆல்கஹால் தான். அதை நம்ம கட்டாயம் விட்டு வெளியே ரொம்ப முக்கியம். நான் கட்டாயம் புரிஞ்சுக்கணும்.
Dr. Kannan is a cardiologist of Madras Medical College. High blood pressure வரும்போது ஹார்ட்டில் ஃபெயிலியர் ஆகும். ஹார்ட் ஃபெயிலியர்லாம் இப்போ காமன். ஒருவேளை 70, 80 வயசுனா கடைசியில் அவர் செத்து போகிறது ஹார்ட் ஃபெயிலியர் தான். பிளட் ப்ரெஷர் இருந்தால் சீக்கிரம் செத்துருவார். ஸோ அதை பற்றி சொல்லுங்களேன்.
இந்த ரத்த அழுத்தம் வந்து மெயினாக வந்து ஹார்ட்டு, கிட்னி, பிரெயின் 3 அஃபெக்ட் பண்ணுது. ஹார்ட்டில் வந்து எப்படின்னா உங்களுக்கு இந்த ஹார்ட் ஃபெயிலியர்னு சொல்லுவோம், அது இருதயம் செயல் இழக்கிறது. இன்னொன்று வந்து இந்த இருதய துடிப்பு வித்தியாசம் வந்து சார் சொன்னது மாதிரி ஸ்ட்ரோக்லாம் அதனால வரலாம். இந்த ஹார்ட் ஃபெயிலியர் எப்படி வருதுன்னா நேரடியாகவும் வரலாம், இல்லாட்டி ஹார்ட் அட்டாக் வந்து ஹார்ட் ஃபெயிலியர் வரலாம். 2 விதமையுமே நமக்கு ஹார்ட் ஃபெயிலியர் வர்றதுக்கு வாய்ப்பு இருக்கு. இதில் எப்படி நம்ம என்ன நோயாளி என்ன சொல்லுவாங்கன்னா, என்ன சிம்டம் வருவங்க சொல்லுவாங்கன்னா, நடக்கும்போது மூச்சு வாங்குது, கொஞ்சம் நடந்தாலே அதிகமாக மூச்சு வாங்குது, கால் வீக்கம் வருது, இல்லாட்டி படுத்திருக்கும் போது திடீர்னு மூச்சு வாக்கி இருந்துச்சு உட்கார வேண்டியிருக்கு. இதெல்லாம் தான் ஹார்ட் ஃபெயிலோட சிம்டம். இல்லாட்டி ரொம்ப ஒரு டயர்ட்னஸ், ஃபெட்டிக்னு சொல்லுவோம், ரொம்ப சோர்வா இருக்கு, அது ஒரு சிம்டமா இருக்கலாம். ஸோ இந்த ஹார்ட் ஃபெயிலியருங்கிறது இது வந்து முழுமையாக தடுக்கக்கூடிய ஒரு இது. இந்த பிபியை நல்லா கண்ட்ரோல் பண்ணாலே இந்த ஹார்ட் ஃபெயிலியர் இல்லாட்டி இந்த இதயம் செயலிழக்கிற வியாதியிலேருந்து நம்மளால காப்பாற்ற முடியும். இதுக்கு மெயினாக என்னன்னா, உங்களுக்கு இந்த ஹார்ட் ஃபெயிலியர் வர்றது தடுக்கிறது இம்பார்ட்டன்ட். வந்துருச்சுன்னா மெயினாக சார் சொல்ற மாதிரி இந்த உப்பு கம்மியாக சாப்பிட்டாதான் அந்த நீர் வந்து சேர்றதெல்லாம் தடுக்க முடியும். ஸோ சில பேர் என்ன பண்ண வரும்போது கொஞ்சம் உப்பு குறைச்சாலே வீக்கம் குறைஞ்சிடும். ஏன்னா உப்பு கம்மியானாலே உங்களுக்கு வந்து நீர் அதோட சேர்ந்து போயிடும், அதனால வந்து உங்களுக்கு தடுக்க முடியும். ஸோ இது வந்து முழுமையாக தடுக்கக்கூடிய ஒரு வியாதி ஹார்ட் ஃபெயிலியர் டியூ டு ஹைப்பர் டென்ஷனுங்கிறது. இதே ரத்த அழுத்தத்தை நல்ல கண்ட்ரோலில் கொண்டு வந்து நல்ல டயட் ரெஸ்ட்ரிக்ட் பண்ணி உப்பு கம்மியாக சாப்பிட்டாலே இதெல்லாம் தடுக்க முடியும்.
இப்போ எல்லாத்தையும் பேசிட்டோம். ரொம்ப ஒரு முக்கியமான ஒரு இம்பார்ட்டன்ட் இஷ்யூ கொலஸ்ட்ரால் எல்லாரும் கேட்டே இருப்பாங்க. கொலஸ்ட்ராலும் பிளட் ப்ரெஷரும் சேர்ந்து வந்துடும் சில பேருக்கு. இப்போ ஹார்ட் அட்டாக் வருதுன்னு சொன்னால் முக்கியமான காரணம் கொலஸ்ட்ரால். அதுக்கப்புறம் தான் அடுத்த காரணம்லாம் டயபிட்டிஸு, பிளட் ப்ரெஷரு, ஒபேசிட்டி, ஆல் தோஸ் திங்ஸ். சப்போஸ் சம்படி இஸ் ஒபீஸ் ஹேவிங் ஹை பிளட் ப்ரெஷர், கொலஸ்ட்ரால், டயபிட்டிஸ் அப்படின்னு பார்த்தா 400% increased risk of heart attack. 400%, all this combination. I think Dr. YVC Reddy from Apollo Hospital is the correct person to tell me something about this combination.
எல்லா ஹைப்பர் டென்ஷன் பேஷண்ட்டையும் சுகர் கொலஸ்ட்ரால் கண்டிப்பாக செக் பண்ணணும். கொலஸ்ட்ரால் ஃபாஸ்டிங்கில் பண்ணால் ட்ரைக்ளிசரைட்ஸ் ஈஸியாக கண்டுபிடிக்க முடியும், பட் நான் ஃபாஸ்டிங்கும் பண்ண முடியும். நான் ஃபாஸ்டிங் கொலஸ்ட்ரால் டெஸ்டிங்கில் பேட் கொலஸ்ட்ரால் எல்டிஎல் கொலஸ்ட்ரால்னு இருக்கும், ஜெனட்டிக் கொலஸ்ட்ரால் எல்பிஏன்னு இருக்கும். இது ரெண்டும் ஈஸியாக கண்டுபிடிக்க முடியும். எனி டைம் பண்ணலாம், சாப்பிட்டுக்கு அப்புறம் கூட டெஸ்ட் பண்ணலாம். வித்தின் 3 hours ரிப்போர்ட் வரும். இப்போ அட்வான்ஸ்மெண்ட்ஸில் 3 minutes பாயிண்ட் ஆஃப் கேர் ஒரு சின்ன பிளட் ப்ரிக்கில் கூட செக் பண்ணி பார்க்கலாம். பிபி பேஷண்ட்ல எல்டிஎல் கொலஸ்ட்ரால் வந்து 70 கன்னா கம்மியாக வச்சா ஹார்ட் அட்டாக், ஸ்ட்ரோக் வரதுக்கு சான்ஸ் ரொம்ப கம்மியாயிடும். டயட் கண்ட்ரோல், ரெட் மீட் அவாய்ட் பண்ணது, டீப் ஃப்ரைட் ஆயில் ஐட்டம்ஸ் கட் பண்ணது, வாக்கிங் பண்ணுறது எல்லாம் எல்லாமே நல்ல அட்வான்ஸ்டு மெடிகேஷன் இருக்கும், ஸ்டாட்டின்ஸ் இருக்கும். நிறைய பேர் அதில் சைட் எஃபெக்ட்னு நினைச்சுவாங்க, பட் வெரி வெல் டாலரபிள், எக்ஸலண்ட் மெடிகேஷன் டு ரெடியூஸ் ஹார்ட் அட்டாக் அண்ட் ஸ்ட்ரோக். ஸ்டாட்டின்ஸ் நிறைய இருக்கும், அசோசியேட்டட் அட்வான்ஸ் மெடிகேஷனும் இந்தியாவில் அவைலபிலிட்டி இருக்கும். சம் பேஷண்ட்ஸ் 100க்கு 25% எவ்வளோ மெடிகேஷன் கொடுத்தாயும் கண்ட்ரோல் ஆகலை கொலஸ்ட்ரால் என்ன, இயர்லி 2 injections எடுத்துட்டு கொலஸ்ட்ரால் கண்ட்ரோல் பண்ணக்கும் சான்ஸ் இருக்கும். ஸோ இது வெரி இம்பார்ட்டன்ட் அசோசியேஷன், பிபி அண்ட் கொலஸ்ட்ரால். இது ஈஸியாக நம்ம கண்ட்ரோல் பண்ண முடியும். அது ரெண்டும் கண்ட்ரோல் பண்ணாதான் ஹார்ட் அட்டாக், ஸ்ட்ரோக்ஸ் கம்மியாக பண்ணதுக்கு சொசைட்டியில் சான்ஸ் இருக்கும்.
Dr. Narasinghan, you are the Vice President of Indian Lipid Association. What do you want to control?
நீங்கள் உங்கள் டாக்டர்கிட்ட போய் பார்க்கும்போது கொலஸ்ட்ரால் செக் பண்ண வேணாம் சார், வெறும் பிபி மட்டும் இப்போ பாருங்கள் சார், எனக்கு சர்க்கரை இருக்குது, சும்மா ஒரு தடவை சர்க்கரை மட்டும் எவ்வளோ கண்ட்ரோல் சொல்லுங்கள் சார், எப்படி கண்ட்ரோல் பண்ணிக்கலான்னு அப்படிலாம் கேட்காதீங்க. டாக்டரை கொஞ்சம் ஃப்ரீயாக விடுங்க. உங்கள் பேக்கப் மைண்டில் இவர் என்னென்னமோ டெஸ்ட்லாம் எழுதுறாரு, இந்த ஹாஸ்பிட்டலுக்கு லாபம் பண்ணி கொடுக்குறாரு, இவர் கொஞ்சம் நிறைய சம்பாதிக்க பார்க்குறாரு, அப்படிலாம் நினைக்காதீங்க. எந்த டாக்டரும் அந்த மாதிரி நோக்கத்தில் பண்ணவே மாட்டாங்க. எது தேவையோ அதான் செய்வாங்க. கொலஸ்ட்ரால் டெஸ்ட் டாக்டர் எழுதி கொடுக்குறாருன்னா ரொம்ப இம்பார்ட்டன்ட். பிகாஸ் நான் தான் இப்போ சொன்னேன், ஹார்ட் அட்டாக் ஃபர்ஸ்ட் வருதுன்னு சொன்னால் அதுக்கு முக்கியமான காரணம் பிளட் ப்ரெஷருக்குலாம் அப்புறம் தான் ஃபர்ஸ்ட் காரணமே வந்து கொலஸ்ட்ரால் தான். அதுக்கப்புறம் தான் பிளட் ப்ரெஷர், அதுக்கப்புறம் தான் டயபிட்டிஸ், அதுக்கப்புறம் தான் அதர் கண்டிஷன்ஸ். அதனால் கொலஸ்ட்ரால் டெஸ்ட்டு கண்டிப்பாக பண்ணி ஆகணும். அது பண்ணும்போது உங்களுக்கு அந்த பேராமீட்டர்ஸ் கரெக்டாக சொல்லுவாங்க. இப்போ நான் எல்லாத்தையும் சொன்னால் உங்களுக்கு கன்ஃபியூஸ் ஆகிடும். நிறைய பேராமீட்டர்ஸ் இருக்குது. இவர் இன்னொன்று சொன்னார், எல்பிஏன்னு ஒன்று, அது ஜெனட்டிக்ஸில் வருது. அது வந்து எல்பிஏ வந்ததுன்னு சொன்னால் அது வந்து சில பேருக்கு அப்பாவுக்கு இருக்கும், இல்லை அம்மாவுக்கு இருந்திருக்கும், குழந்தை பையனுக்கு இருக்கும். நான் நேற்று ஒரு பேஷண்ட்டை பார்த்தேன். எதுக்காக வந்து என்னை பார்க்க வந்திருக்கீங்கன்னா, கொலஸ்ட்ராலில் ப்ராப்ளம் இருக்குது சார், என்னுடைய எல்பிஏ அதிகமாக இருக்குன்னு சொன்னாங்க, அதனால் வந்திருக்கேன். கூட அவங்க அக்காம்பனி பண்ணது வேற ஒரு லேடி. கேட்டால் ஷீ இஸ் ஃப்ரம் யூஎஸ். சார், ஐ எம் ஆல்சோ டேக்கிங் ட்ரக்ஸ் ஃபார் பிளட் ப்ரெஷர், ஐ எம் ஆல்சோ டேக்கிங் ட்ரீட்மெண்ட் ஃபார் எல்பிஏ. என்னென்னா ஐ எம் டேக்கிங் பராத்தா இன்ஜெக்ஷன். ஸோ லைக் தட். என்னம்மா அப்பா எப்படி இருக்காரு? அப்பாவுக்கு ஹார்ட்டில் டேவி பண்ணியிருக்காங்க சார். டேவின்றது ரத்த குழாயில் சுருங்கி போயிடும் வெசலில், அது சுருங்கி போகிறதுக்கு காரணம் எல்பிஏ. ஹார்ட் அட்டாக் வர்றதுக்கு காரணம் எல்பிஏ. கூட இருக்க அந்த சிஸ்டருக்கு வர்றதுக்கு காரணம் எல்பிஏ. ஸோ ஃபேமிலியில் எல்லாருக்குமே அந்த எல்பிஏன்னு வந்திருக்கு. அந்த எல்பிஏ உடனே கண்டுபிடிச்சி அதுக்கு ட்ரீட்மெண்ட் எடுக்கும்போது தான் அவங்கள காப்பாற்ற முடியும். ஸோ அதை வந்து எதுக்காக சொல்லறேன்னா, இந்த டெஸ்ட்டையும் உங்கள் டாக்டர் எழுதுவார். இந்த டெஸ்ட்டு கொஞ்சம் விலை அதிகம், இல்லைன்னு சொல்லலை, ஒரே தடவை தான் பண்ணணும், ஒவ்வொரு வாட்டியும் பண்ண வேண்டிய அவசியம் இல்லை. ஒரு வேளை அதிகமாக இருந்ததுன்னா ட்ரீட்மெண்ட்டு கொடுத்தாங்கன்னா அப்போ தான் ஃபாலோ பண்ணுறதுக்காக பண்ணுவாங்க. ஒரே தடவை பார்த்துட்டு அது கம்மியாக இருந்ததுன்னா மறுபடியும் பார்க்க வேண்டிய அவசியமே கிடையாது. இன்றைக்கி 42 இருந்ததுன்னா 42 தான் இருக்கும் உங்கள் கடைசி வரைக்கும், மேலே ஏறதுக்கு வாய்ப்பே இல்லை. வேறு 102 இருந்ததுன்னு சொன்னாக்கா அது உடனே நம்ம ட்ரீட்மெண்ட் கொடுக்கும்போது கம்மியாதான் பார்க்கணும். இதான் வந்து அந்த எல்பியை பொறுத்த வரைக்கும். மீதி கொலஸ்ட்ரால் எல்லாம் உங்கள் டாக்டர் கண்டிப்பாக எழுதுவார். அந்த மாதிரி எழுதும்போது தயவுசெய்து வேண்டான்னு சொல்லாதீங்க.
அதை பார்த்துட்டு ஒரு மாத்திரையை கொடுப்பாரு. அந்த மாத்திரை இருக்க உலகத்தில் உற்பத்தியான அந்த மாத்திரையை சாப்பிட்டுட்டு நிறைய பேர் நம்ம உலகத்தில் இன்னும் வாழ்ந்து கொண்டிருக்காங்க. காரணம் அந்த மாத்திரை பேர் என்ன தெரியுமா? ஸ்டாட்டின் மாத்திரை. ஸ்டாட்டின் பெரிய அந்த ஸ்டாட்டின் இப்போ பண்ணுற வேலைகளை பார்க்கும்போது ஏன் நம்ம ட்ரிங்கிங் வாட்டர்லேயே சேர்த்துடலாமே ஸ்டாட்டின், எல்லாரும் சாப்பிட்லாம்ல அப்படின்ற அளவுக்கு ஸ்டாட்டினை பற்றி எல்லாரும் பேச ஆரம்பிச்சிருக்கோம். அதனால் முக்கியமான விஷயம் கொலஸ்ட்ராலு, பிளட் ப்ரெஷரு, டயபிட்டிஸு, வெயிட்டு இதெல்லாம் பார்த்தாவே நம்ம வாழ்நாள் கண்டிப்பாக நீடிக்கும். ஸோ உங்கள் எல்லாருக்கும் ஒரு நன்றி. நீங்கள் எல்லோரும் வந்ததுக்கு, நாங்கள் கேட்டதுக்கு நீங்கள் வந்தீங்க. எல்லாத்தையும் பப்ளிஷ் பண்ணுங்கள். மீடியா பீப்புள் தான் எங்களுக்கு ஃப்ரெண்ட்ஸு. பிகாஸ் நாங்கள் இந்த இதற்குள்ள அரங்கத்துக்குள்ளே பேசிகிட்டே இருப்போம், நிறையவும் பேசுவோம், கேட்குற கேள்விகள்லாம் கூட பதில் சொல்லுவோம். ஆனால் இந்த அரங்கத்தை விட்டு போனதுக்கப்புறம் நானும் என்னுடைய பேஷண்ட் ரூமுக்கு வர்றவங்க அவங்க மட்டும் தான் இருப்போம், 1-to-1 இன்ட்ராக்ஷன். வேறு எங்களுடைய அபிப்பிராயம் என்னென்னா, ஸ்கூலுக்கு போகணும், காலேஜஸ்க்கு போகணும், அவங்களுக்கு ரோட்டரி கிளப்பில் போய் பேசணும், லைன்ஸ் கிளப்பில் போய் பேசணும், எங்கெங்கெல்லாம் மக்கள் கூடுறாங்களோ அவங்களுக்கெல்லாம் போய் பேசும்போது தான் அவேர்னஸ் நிறைய க்ரியேட் பண்ணணுன்றத ப்ராஜெக்ட்லாம் நாங்கள் நிறைய வச்சுருக்கோம். எல்லா டாக்டராலும் எல்லா இடத்துக்கும் போக முடியாது. அட்லீஸ்ட் இங்கே சேர்ந்துருக்கவங்க எல்லாருமே பெரிய பெரிய ஸ்டால்வார்ட்ஸு. அவங்க மூலமாக வச்சு இந்த ஸ்கூலுக்கு போகலாம், இந்த காலேஜுக்கு போகலாம், இதை செய்யலாம் அப்படின்றது எங்கள் அசோசியேஷன் மூலமாக நல்லா செய்வோன்ற எங்களுக்கு ஒரு நம்பிக்கை இருக்குது. ஐ திங்க் இந்த மாதிரிலாம் நம்ம எல்லாரும் ஒன்றா சேரும்போது, நீங்கள் சேரும்போது, நாங்கள் சேரும்போது, அங்கே உட்காந்துருக்கவங்க சேரும்போது, டாக்டருங்க இங்கே சேர்ந்துருக்கும் போது, எல்லாரும் சேரும்போது நம்ம வாழ்க்கை மற்றவங்களுக்கு மட்டும்தான் உயர்த்தம் கிடையாது, நம்மளே நம்ம வாழ்நாள் நீடிக்கிறோம் அப்படின்றது தான் அர்த்தம். தேங்க்யூ வெரி மச் ஒன்ஸ் அகெயின். தேங்க்யூ.
நிறைய விஷயங்களை நம்ம கிட்ட ரொம்ப அழகா எடுத்து சொன்னாங்க. Thank you so much, doctors. It was such a wonderful, informative and insightful session. May I request the doctors to occupy the front rows, please? It's time for us to get the event kick-started formally, so I request you all to be please seated. And the doctors can take the front rows. Elarum breakfast saaptacha? Did you all enjoy your breakfast? First of all, it's so delightful that, I'm so delighted that on a Sunday morning, ivlo pera or effort pote இன்னைக்கு இந்த அருமையான ஒரு இனிஷியேட்டிவ்க்காக வந்திருக்கீங்க. I would like to give you all a big, big round of applause. So please clap for yourself for being so proactive on a Sunday morning, because this is probably one of those days you get to stay back home, but you've still made it to the event today. Thank you so much, ladies and gentlemen. And on this auspicious occasion, we have with us Dr. S.N. Narsingan, the Vice President, World Hypertension League, along with, of course, Dr. K. Kannan, the Chairman, and Dr. S. Chandrasekhar, the Secretary of Tamilnadu State Chapter, with esteemed panel of doctors. They are with us here today for, of course, with a lot of other dignitaries as well. We have the IPCA Laboratories Limited to grace the occasion today formally. And before I take the program forward, I would like to acknowledge and thank the organizers of World Hypertension League, Indian Society of Hypertension and Association of Physicians of India, Chennai chapter, for building and executing such a beautiful concept and taking all audience live 3 blood pressure reading by explaining it's important as well. So, இன்னைக்கு இந்த ஈவெண்ட்டுக்கு முதல் முறையா யாரெல்லாம் வந்திருக்கீங்க? How many of you are coming here for the first time today? And how many people have been coming here consecutively every year? Because this has been happening so many years now. All right. Can we have a few mics passed on to them, please? I would just like to have a small interaction with the audience here. Can I have one of the volunteers pass on the mic? Just a quick. I'll come to that. Meanwhile, I request everyone to be seated while we quickly catch up with the audience. Just for a couple of moments, please. Can I just have one of you people raise up your hand who would like to say a few words about your past experience? Every year you've been coming here. So, yaarella vande every year vandirukkingalo, can I just see your hands up? Mr. Ganapati is here with us. Can someone pass on the mic to him, please? Just a few more words, sir. Can you, please? Yes. So, sir, you can tell us your experience about being here on this event today.
I'm a patient of Dr. Narsingan for over 3 decades. And both me and my wife have been attending all his programs, and it's been very well organized, very informative, very educative. And it has also prompted many of the so-called patients to go in for regular checkups, which has helped them in terms of maintenance of their own health. I think it's a wonderful program organized by Dr. Narsingan, and we are happy to be associated with this program.
Thank you, sir. Thank you so much for the lovely words. A big round of applause for Mr. Ganapati and his wife. Thank you so much. Lovely. So before we get started, I request you all to raise up for the Tamil Thai Varthu. Can we have you just standing up near your seats, please?
நீராறும் கடலுடுத்த நிலமடந்தை கெழிலொழுகும் சீராறும் வதனமென திகழ்வரத கண்டமிதில் எக்கணமும் அதில் சிறந்த திராவிடனல் திருநாடும் தக்க சிறு இறை நுதலும் தரித்தனரும் திலகமுமே அத்திலக வாசனை போல் அனைத்துலகும் இன்பமுற எத்திசையும் புகழ் மணக்க இருந்த பெரும் தமிழனங்கே தமிழனங்கே உன் சீரிழமை திறம் வியந்து செயல் மறந்து வாழ்த்துதுமே வாழ்த்துதுமே வாழ்த்துதுமே.
Thank you, everyone. Thanks a lot. Please be seated. And we will formally get the event started today with a lovely session here, the lamp lighting ceremony, for which I would like to call Dr. Narasimhan up on stage. Mr. Narasimhan, please come up on stage. And also joining them would be another set of dignitaries. I request Mr. Shanmugam. Dr. Shanmugam, please join them on stage. Can we have a good round of applause, please, for Dr. Narasimhan, Dr. Shanmugam. Dr. Kannan, can we have you on stage, please? Dr. Chandrasekhar, Dr. Jeshi Shekhar. A big round of applause once again for all the dignitaries. Dr. Shruti, please come forward. Oh, that's a lovely touch. Mr. Ganapati, can we have you on stage, please? Oh, Mrs. Ganapati, please. Yes, yes, makes sense, sir. It's a beautiful start to this wonderful initiative today. We have some of the best doctors on stage doing the honors, and joining them would be Mrs. Ganapati. Nalla energetica kai tatlame. Where's all the energy? Yes, thank you. Thank you so much. We have all our lovely doctors doing the honors. A wonderful lamp lighting ceremony led by Dr. S.N. Narasimhan, the Vice President of World Hypertension League. All right. I request the doctors to please come up on stage. Maybe have you all seated for a quick Q&A headed by Dr. S.N. Narasimhan. So he'll be leading this Q&A ceremony right now. We'll have a quick Q&A session. You must have heard them speak about the cholesterol level, lifestyle changes that we'll have to make, and also about a lot of other hypertension related problems and all that. So if you have any questions, you can raise your hands. We will have one of the volunteers pass on a mic to you, and you can put forward your questions to any of the doctors here, and they would love to answer to them. இப்போ ப்ரெஸ் கான்ஃபரன்ஸ் அப்புறம் நிறைய விஷயங்கள் நம்மகிட்ட சொல்லிட்டு இருந்தாங்க, ஹைப்பர்டென்ஷன் ரிலேட்டடா, டயபிட்டிஸ் ரிலேட்டடா. ஸோ உங்களுக்கு அதை சார்ந்து ஏதாவது கொஸ்டின்ஸ் இருந்ததுன்னா ப்ளீஸ் ரேஸ் யூர் ஹேண்ட்ஸ். இஃப் யூ ஹேவ் எனி questions to ask the doctors, please raise your hands. We will give the mics. Can we have a mic passed on to the gentleman over here? So, உங்களை introduce பண்ணிக்கோங்க, and then you can put forward your question.
Hello. Good morning, doctors. My name is Nirai Selvan, coming from Tiruvatiur. I have one question. If the diastolic pressure we have to maintain is 80, but if it fall down to 70, 65, 60, 55, and 50, what will happen in the body, and how we have to bring it to 80? This is my question.
I think the correct person to answer this question is Dr. YVC.
See, very important point you raised, sir. Systolic pressure should be below 130 if tolerable. Diastolic should be less than 80 if tolerable. It does not mean it cannot go down. In fact, at night times, the lower blood pressure should go down to less than 70. It should be less than 80 in the waking hours, less than 70 in the night time while you are sleeping, which you can do by ambulatory blood pressure monitoring. And also, you have to remember that as we age, normally, the diastolic pressure for all of us goes down and down because arteries get stiffer. It is not a disease process. So the importance is, if it goes to 60 or 50 or 40, don't worry about that. It should not be above 80. That is the importance. If it is, say, the BP now is 130 by 50, don't worry about that number. In fact, we tell the patients and the family members, from now, don't look at the lower number. You keep looking at the upper number, keep it between 120 to 130 for a good BP control. Extremely rarely, there are some rare conditions where the doctor might say, okay, your diastolic is going low, I will readjust the medicines. They are rare conditions, you leave it to the doctor. But as a general rule, what I told you is to be kept in mind.
I think all of you had listened to our interview to the press people.
Yeah.
Most of them had most of the information regarding hypertension and all were covered. What I thought, I should probably request you people to raise questions because you will have a lot of questions. That is the importance of this particular meeting. Not that it should be only one-way traffic. You should raise questions now. I know you are not doctors, but you need to raise pertinent questions. For example, I have been taking drugs through 1 drug, 2 drugs, 3 drugs, 4 drugs. In spite of that, the blood pressure is not coming under control. What is the reason, doctor? Yes, that's one question. I'm like giving you an example. I don't exercise at all. Do you think my blood pressure will come down? Like that you ask. Just, I'm eating this much of salt. What do you think?
Sir, my name is Bhadresh Shah.
Yeah.
Yes, sir.
My BMI is 26.5 and the age is 67. So whether this is okay or it is more?
Can you raise up? We can stand up so that we can see whether you are obese or non-obese.
Sir, what is your BMI, sir?
26.5.
26.5. உங்களுக்கு வேற ஏதாவது, do you have any other comorbidities, diabetes,
I have only blood pressure.
blood pressure? Fine, sir. Like 26.5 நம்ம இடையில நம்ம இந்தியர்களுக்கு சராசரியா 23க்குள்ள இருக்கிறது BMI ரொம்ப நல்லது. 25க்கு உள்ள வச்சுக்கிறது பரவாயில்ல. பட் 26.5ன்றது பெரிய அதிக அளவுல கிடையாது. பட் இருந்தாலும் நீங்க உங்களுடைய உடல் எடையை இந்த BMI கம்மி பண்றதுக்கு நீங்க இன்னும் கூட கொஞ்சம் முயற்சி பண்ணலாம். இன்னும் கூட கொஞ்சம் ரீஇன்ஃபோர்ஸ் யுவர் டயட். நீங்க என்ன சாப்பிட்டுட்டு வரீங்கன்றத ஒரு டயட் ரீகால் ஒன்று பண்ணுங்க. டயட் ரீகால் பண்ணிட்டு என்னென்ன சாப்பிட்றதுல என்னென்ன அவாய்ட் பண்ணலான்றதுக்கு ஒரு முயற்சி பண்ணுங்க. இன்னும் கூட கொஞ்சம் கூடுதல் நேரம் செலவழிச்சு நீங்க வாக்கிங் இல்ல உங்களால, ஏன்னா 60+ நீங்க, அதனால
generally I walk every day minimum 7,000 steps.
fine.
So that is
fair
every
enough,
day,
sir.
most of the time.
Sir, if you are fit enough, like 26.5 க்கு நீங்க பயப்படவே வேண்டியது இல்ல. ரொம்ப அது ஒரு ஸ்ட்ரெஸ்ஸா கொண்டு வராதீங்க. So if you could possibly reduce the BMI by 1 or 2, it's good, good enough. But if you are fit enough, I tell you, like 26.5 வெறும் ஹைப்பர்டென்ஷன் ஒண்டி இருக்கிறதுக்கு பயப்படவே வேண்டியது இல்ல. 60+, நீங்க you can lead the show. Like நீங்க ஃபிட்டா இருக்கீங்க, you can walk up to 7,000 8,000 steps a day.
7,000 daily I am doing that.
Yeah, then you need not worry at all, sir. நீங்க பயப்படவே வேண்டியது இல்ல. Maintain it.
Yeah, another thing, my blood pressure, actually I was not having BP and all, but last 2-3 years I am having BP. I take recently regular medicine also, but still it is high only.
What is the high level?
I will tell you.
No, அதுக்கெல்லாம் பாக்கெட் இருக்கிறோம்னா 160 170 இல்ல
100 and okay. Just 4. Sorry, 158/104.
சார் நீங்க போட்டுட்டு வர மாத்திரைகள் கொஞ்சம் அட்ஜஸ்ட் பண்ணா போதும் சார். 24 ஹவர்ஸும் யூனிஃபார்மா கண்ட்ரோல்ல இருக்க மாதிரி நீங்க போட்டுட்டு வர மாத்திரையினோட அளவு அதிகப்படுத்துறோம். இல்ல கொஞ்சம் சின்னதா சேஞ்ச் பண்ணனாலே இந்த அளவு நம்ம கொண்டு வந்துடலாம். ரெண்டாவது நீங்க சரியான முறையில உணவு பழக்க வழக்கங்கள் டயட் இருக்கீங்கன்னு சொல்றீங்க. தூக்கம்ன்றது கரெக்டா இருக்கான்றது பாத்துங்க. ஸ்ட்ரெஸ் கொஞ்சம் பேலன்ஸ் பண்றதுக்கு பாத்துங்க. ஸோ இந்த வழிமுறைகளும் நீங்க பண்ணீங்கன்னா கண்டிப்பா உங்களுடைய பிபி நார்மல் பிபிக்கு நீங்க அவசியம் நீங்க கொண்டு வரலாம். பட் அதுக்கு நீங்க டாக்டரையும் ஒரு இது ஒன்று பார்த்துட்டு உங்களுடைய மெடிகேஷன்ஸ்ல ஏதாவது அட்ஜஸ்ட் பண்ண முடியுமா ப்ளஸ் உங்க சைட்ல இருந்து ஸ்லீப் அண்ட் ஸ்ட்ரெஸ் இது ரெண்டுமே
Yes.
ஸ்மோக்கிங் அஃப்கோர்ஸ். ஸோ இதெல்லாம் வந்து இல்லைன்னா ஒன்றும் நோ இஷ்யூஸ்.
For your information, I am a non-smoker,
வெரி குட் சார்.
non-drinker.
வெரி குட் சார்.
So that problem.
Yeah. So இந்த ஸ்லீப் அண்ட் ஸ்ட்ரெஸ் இதையும் கொஞ்சம் பாத்துங்க சார், ரொம்ப நல்லது இது.
நீங்க இப்போ 2 மாத்திரை போட்டிருந்தீங்கன்னா டாக்டர் சில டயத்துக்கு 3 மாத்திரை ஆட் பண்ணுவார், இல்லாட்டி இன்னொரு மாத்திரை ஆட் பண்ணுவார், இல்லை டோஸ் இன்க்ரீஸ் பண்ணுவார். அதை நீங்கள் கேட்டுக்கலாம் நீங்கள்.
Okay, okay. Thank you. Thank you.
Thank you, sir.
எஸ், அங்கே மைக் கொடுங்கம்மா.
Can we have the mic passed on?
The question should come from public.
Yeah, and also we want more of the public to raise questions. உங்களுக்கு தமிழ்ல கம்ஃபர்டபுளா இருந்தா தமிழ்லயே நீங்க கேள்விகளை கேட்கலாம்.
Sir, I am Dr. Rajagopal, surgeon, previously a professor of surgery, Madras Medical College. My age is 88 now. I am diabetic and also hypertensive. I am taking regularly the drug for the past 20 years. I would like to know, if all in sudden, if I get arrhythmias at home, what should I know? What should I do immediately?
I think Vijay Chandra sir.
The commonest arrhythmia, that in the ஏஜில் வந்து காமனஸ்ட் அரித்மியான்னு பார்த்தா நம்ம வந்து ஏட்ரல் ஃபிப்ரிலேஷன் வரும். அது வந்து as ஏஜ் ப்ரோக்ரஸஸ் வந்து ஒரு காமன் அரித்மியா. அந்த ஏட்ரல் அரித்மியா ஃபிப்ரிலேஷன் வந்து above the age of 80 years வந்து ப்ரிவலன்ஸ் வந்து ரொம்ப ஹையாக இருக்கும். So if it comes, see, only thing is when you are at home, first of all you must get an ECG done to the nearest facility to have an ECG done and document that you have an arrhythmia. If the
what should I do? Yeah, at the home when I get it in the sleep, immediately what should I know?
அது வந்து என்ன அரித்மியா நம்ம பார்க்காம நம்ம வந்து ஒரு எம்பரிக்கலா ட்ரீட்மெண்ட் கொடுக்க முடியாது சார்.
As a doctor, I know what is arrhythmia, isn't it?
இல்லை சார், கரெக்ட் தான் சார். ஒரு ஏட்ரல் ஃபிப்ரிலேஷன் வருதுன்னு வச்சுங்களேன் சார், இட் இஸ் உங்களுக்கு சிம்டம்ஸ் வந்து மேக்ஸிமம் பால்பிட்டேஷன் தான் இருக்கும். ரொம்ப பிபி ட்ராப் அப்படி மாதிரி சான்சஸ் வந்து கம்மி, பால்பிட்டேஷன் தான் இருக்கும். ஸோ தெர் இஸ் டைம் ஃபார் யூ டு கோ டு த ஹாஸ்பிட்டல். இட் வில் நாட் தெர் வில் பி டைம் ஃபார் யூ டு கோ டு த ஹாஸ்பிட்டல், டேக் அன் இசிஜி, டாக்குமெண்ட் அன் அரித்மியா. அது ரொம்ப ஹையாக இருந்துச்சுன்னா அந்த ரேட் கண்ட்ரோலிங் மெடிகேஷன்ஸ் கொடுப்போம். இஃப் யூ திங்க் தட் தெர் இஸ் சம் அதர் இஷ்யூ காசிங் விச் ரிக்வயர்ஸ் ஏட்ரல் ஃபிப்ரிலேஷன் as நார்மல் கன்வெர்ட் பண்ணணும்னு சில சுச்சுவேஷன்ஸ் இருந்துச்சுன்னா அதுக்கான ட்ரீட்மெண்ட் வந்து ஹாஸ்பிட்டலில் தான் நம்ம கொடுக்க முடியும். அண்ட் சரி, பில் இன் த பாக்கெட் அப்படிங்கிற ஒரு சிஸ்டம் இருக்குது, பட் ஒன்லி ஃபார் பேஷண்ட்ஸ் ஒரு ஆல்ரெடி டாக்குமெண்டட் ஏட்ரல் ஃபிப்ரிலேஷன். சரி, நார்மலாக இருக்கிறவங்க திடீர்னு வந்து இப்போ பால்பிட்டேஷன் வந்துச்சுன்னா அந்த பில் இந்த பாக்கெட்னு ஒரு கான்செப்ட் இருக்குது. பட் ஃபஸ்ட் எபிசோட் வரும்போது ஹாஸ்பிட்டலுக்கு போய் இசிஜி எடுத்து என்ன அரித்மியான்னு டாக்குமெண்ட் பண்ணுறது தான் கரெக்டாக.
ஓகே, தேங்க்யூ
Sir, good morning, doctor.
I am very happy to see you, sir. You have been my professor, Professor Rajagopal, sir. You have been my professor. I am very happy to see you here, sir. Thank you, sir.
Good morning, doctors. I am Sashidharan. I am a patient of Dr. Chandrasekhar. As the doctors as a whole said, the hypertension and cholesterol is we will be going together. This has some supporting role in the thing. So I have a question on my cholesterol. My doubt is my HD level is started when I started checking my cholesterol levels. My HD level was 25. After the doctor told me that you have to this is very low. Then I tried some. I changed my lifestyle. I did some lifestyle changes, and now I have brought to 40. Is this can I bring this to normal? This like 50-55. I mean, the generally doctor says the HD level is cannot be changed. It is something inborn. It is come along with the thing. So, is there any method, any ideas for bringing these to normal HD levels?
HDL levels is actually we consider that as a good cholesterol.
Yes.
The only way of increasing it is only by diet modification,
okay,
and then exercise. Okay. Exercise mostly aggressive, okay, and it should be for a longer period,
okay,
up to 1 to 2 years. Only okay, then you will have an increase of 2 to 3 milligrams okay, of HDL.
Okay.
Very difficult to increase it only by diet and lifestyle modification, but it does not probably
deny the benefit of exercise
Okay.
and the benefit of lifestyle modification to increase the HDL.
Okay.
There were drugs in the past which were used to increase the HDL cholesterol.
Okay.
But ultimately, we need to tell you that all the drugs have failed to
Okay.
show,
Okay.
in spite of increase to 100 milligrams of HDL,
Okay.
people actually had a lot of problems, including heart attack and death also.
Oh.
So they stopped using any medication to increase the HDL.
Okay.
There's only one medication which has now been approved by FDA, which we don't want to use it here in this country because it has not reached our country.
Okay.
Probably that will be a weapon to concentrate on HDL.
Okay.
At this stage, what we recommend now is to control your diet, try to do the physical activity properly, healthy lifestyle, that itself will take care of HDL. What is worrying all of us is the LDL cholesterol, which is considered as a bad cholesterol.
Yeah.
You need to concentrate only on the reduction of LDL cholesterol. I don't know what is the value of your LDL cholesterol.
My value, till the last 4 years, till 4 years back, I was taking medicines 5 mg statins. Store was. Now I stopped. Now my 140 to 140, 160 is my LDL cholesterol.
No, what you are supposed to do is to concentrate only on LDL all the time.
Okay.
LDL, LDL, LDL.
Okay.
Try to reduce it, bring it down to less than 100.
Okay.
If you are already hypertensive, bring it down to less than 70.
Okay.
If you are bringing it down to less than 70,
Okay.
you will live for a long, long period.
Okay.
There's no doubt about it. So that's the main thing that you should concentrate, not on HDL. There is only one condition where your HDL will be low all the time. 25 milligram now, after 1 year again 25 milligram, after 2 years 25 milligram. There is only one genetic condition called hypo-alpha lipoproteinemia, where the HDL will always be low. So don't get worried about all those important information what we are now sharing.
Okay.
That is not for you, but your aim is to control LDL. I am sure Dr. Chandrasekhar will guide you to the right path.
சார் சசி சார் எல்டிஎல் இஸ் மோர் இம்பார்ட்டன்ட். ஏன்னா எல்டிஎல்ன்றது தான் ரொம்ப கெட்ட கொலஸ்ட்ரால். நிறைய வகையான கொலஸ்ட்ரால் நம்ம வந்து செக் பண்ணுவோம். அது எல்டிஎல்ன்றது ஒரு முக்கியமான ஒரு கொலஸ்ட்ரால். அந்த கொலஸ்ட்ரால் வந்து ரத்த குழாய்கள் அடப்பு ஏற்படுறதுக்கோ சுருங்கிறதுக்கோ நிறைய வாய்ப்புகள் உண்டு. நம்மளுடைய இப்போ வந்து இந்த லிப்பிட் ப்ரொஃபைல்னு சொல்லி நம்ம நிறைய பேராமீட்டர்ஸ் நம்ம பார்த்தாலும் எல்டிஎல்ன்றது வந்து சராசரியாக ஒருத்தங்களுக்கு வந்து 100க்குள்ளே வச்சுக்கிறது வந்து ரொம்ப ரொம்ப நல்லது. அதுவும் ஒரு இணை நோய்கள் இருக்குது, ஒபிசிட்டி இருக்குது, ஹைப்பர் டென்ஷன் இருக்குது, டயபெட்டிஸ் இருக்குது, அது மாதிரி எது இருந்துச்சுனாலும் அதை வந்து 70க்குள்ளே வச்சுருக்கணும். அவங்களுக்கு ஹார்ட் அட்டாக் வந்துச்சுன்னா அதையும் இன்னும் கம்மி பண்ணி 55 கொண்டு வரணும், அதையும் 30 வரையும் கொண்டு வரணுன்ற மாதிரி நிறைய நம்மளுடைய வழிகாட்டுதல்கள் நம்ம இந்தியன் கவர்மெண்ட்ஸ்லேயே நம்மளுக்கு நிறைய இது இருக்குது. ஆனால் எல்டிஎல் கொலஸ்ட்ரால் நம்ம வந்து கண்டினியூ பண்ணணும். ரெண்டாவது முக்கியமான விஷயம் வந்து நிறைய டைம் வந்து எல்டிஎல் கொலஸ்ட்ராலுக்கு நம்ம மாத்திரைகள் கொடுப்பாங்க டாக்டர்ஸ். ஸ்டாட்டின் சொல்லிட்டு அந்த மாத்திரைகள் கொடுப்பாங்க. அந்த மாத்திரைகள் போட்டுட்டு வருவாங்க. அந்த மாத்திரைகளை வந்து அதுக்கப்புறம் கொஞ்சம் எல்டிஎல் கொஞ்சம் கொலஸ்ட்ரால் கொஞ்சம் கம்மியானவனும் அவங்களே நிறுத்திடுவாங்க, இல்லை டோஸ் கம்மி பண்ணிடுவாங்க. அது மாதிரி பண்ணக்கூடாது. அந்த ஸ்டாட்டின்றது வந்து உயிர் காக்கும் மருந்து. அந்த மருந்துகளை வந்து நம்ம வாழ்நாள் முழுதும் எடுத்துட்டு வந்தோம்னா நம்மளுடைய வாழ்நாள் அதிகரிக்கும்ன்றது வந்து அறிவியல் பூர்வமான தரவுகள்ல இருந்து நம்ம அறிந்து கொண்ட உண்மை. ஸோ அதனால அந்த ஸ்டாட்டின்ற மாத்திரையை விடாம நம்ம என்ன அளவு நம்ம டாக்டர் சொன்னாரோ அதே அளவு நம்ம போட்டுட்டு வந்தோம்னா ரத்த குழாய்களில் ஏற்படுகிற, ஏன்னா ரத்த குழாய்களில் ஏற்படுற பாதிப்புனால தான் நம்மளுக்கு ஹார்ட் அட்டாக் வருது, ஸ்ட்ரோக் வருது, சிறுநீரகம் பாதிக்குது, இது எல்லாமே நம்மளுக்கு இதுவாகுது. ஆனால் அந்த ஸ்டாட்டின்ற அந்த மாத்திரையை வந்து நம்ம தொடர்ந்து எடுத்துட்டு வந்தோம்னா ரொம்ப ரொம்ப நல்லது, வாழ்நாள் அதிகரிக்கும். உங்களுடைய HDL பற்றி நீங்கள் ரொம்ப இது பண்ணாதீங்க. சார் சொன்னது கூட நீங்கள் கொஞ்சம் ஸ்ட்ரெஸ் லெவலையும் கொஞ்சம் அப்படி பேலன்ஸ் பண்ணி கொஞ்சம் வச்சுக்கிட்டீங்கன்னா உங்கள் HDL இன்னும் கூட கொஞ்சம் இம்ப்ரூவ் ஆகும். ஸோ அதனால் நீங்கள் ஆல்ரெடி ஃபிட்டு, நல்லா வாக்கிங்லாம் நீங்கள் போவீங்க, எனக்கு நல்லா தெரியும், எனக்கு டென்னிஸ்லாம் விளையாடுவீங்க. ஸோ இது எல்லாமே இருக்குது. பட் இன் அடிஷன் டு தட் ஸ்ட்ரெஸ் லெவல்ஸையும் கொஞ்சம் பேலன்ஸ் பண்ணிக்கிட்டீங்கன்னா ரொம்ப நல்லது. மறந்துடாதீங்க சார் சொன்ன மாதிரி LDL.
Okay, sir. Thank you, sir. Stop smoking if you're a smoker.
I don't smoke, sir.
Okay, good. Because stopping smoking will increase the HDL. Okay. Any other question? Yeah. Venkatesh.
So good morning, doctors.
Yeah. Yeah, please.
My name is Bobili Kamal Kumar. I am of age of 65. At the age of 43, I started my diabetic BP and cholesterol. And 2014, I got 2 stents in Apollo Hospital. After that, I am going to play tennis and golf. and every day I'm walking minimum 15 kilometers. Every day, 15 kilometers. So it is a too much or too less, I don't know. Sometimes I'm going to heavy walking, and at that time I'm going to skip the tablets and all. I don't know whether it is skipping the tablet or I don't know. So please justify that what is it. And I am using alcohol also in weekly thrice, 60 to 90 ml. So I think it is a right question or a bad question, I don't know. Please tell me.
You can answer.
Actually, walking under நல்லது சார். Brisk walking.
Yeah, I'm playing tennis and golf.
Right. So minimum 30 minutes a day or 150 minutes a week is advocated. This is to fresh up the endothelium. அதாவது ரத்த குழா உள்ள இருக்கு இல்லையா, அந்த உள்ள நீ நல்லா ஃப்ரெஷ்ஷாக இருக்கும் போது அந்த ரத்த குழாய் வாஷ் அவுட் ஆகிடும். நம்ம டெய்லி குளிக்கிற மாதிரி மேலே தண்ணி ஊற்றி குளிக்கிறோம். பட் நீங்கள் நல்லா ஃபாஸ்ட் நடந்தீங்கன்னா அந்த ரத்த குழாய் வாஷ் ஆகும். ஸோ மினிமம் half an hour வந்தால் போதும். பட் யூ ஆர் ஏபிள் டு வாக் 15 kilometers, but it is little bit high, but you are able to.
That's why I'm asking.
Yeah, little bit high.
But I didn't get any problem for 15 kilometers.
You already had a 2 stent. Sometimes exertion, you might have some just discomfort.
My highest walking one day is 42 kilometers. 42 kilometers for one day.
One day. Still, I think that shows you are fit. Heart is fit. You
Yeah.
are little long. There is no doubt. But see, if you develop symptoms, be careful. Immediately you assess. You go to a cardiologist. Whether you can do this much of work activity.
But what about alcohol?
Alcohol moderation is good. Moderation means less than 60
Yeah,
ml.
okay.
Don't take too much.
Weekly?
BP you bring down to 130/80. Less than, keep it below 130/80.
Okay.
Right? And cholesterol, as sir said, less than 70. But for you cardiac problem, less than 55 LDL cholesterol.
So I'm good, sir. I'm playing both games and I'm walking well.
Wonderful.
So I think I'm good. But question rises. I don't know whether it is good and bad. But I clear that.
But too much is not good. Too less is not good.
Yeah.
Moderation is good.
And I'm using tablets also sometimes.
Yes, good. Fine. That is very important.
Thank you very much.
Next question.
Good morning, doctors. I don't have any hypertension, but I have a snoring problem. Am I prone for hypertension in future? I am 60 now.
I think somebody can answer this question.
Sir, you told that you have snoring problem, right? So snoring, we have to check whether you have obstructive sleep apnea, sir. We have to check whether you have any obstructive sleep apnea. You have to check with the ENT doctor first. Then what is your sleep pattern? Whether your sleep is good or interrupted sleep. Sleep தூங்கும்போது நிறைய டைம் வந்து நம்ம வில் ஹேவ் ஆப்னியா, இந்த நடுவில் மூச்சு நின்றோம், திரும்ப மூச்சு வரும், அது நம்ம செக் பண்ணோம். இல்லைன்னா தைராய்டு ப்ராப்ளம் இருக்கான்னு நம்ம செக் பண்ணணும். நிறைய டைம் தைராய்டு டெஃபிஷியன்சி இருந்தால் கூட இந்த மாதிரி ஓஎஸ்ஏ வரும், தென் ஸ்லீப் ப்ராப்ளம்ஸ் வரும், தென் யூ கெட் ஸ்னோரிங். இதனால் பிளட் ப்ரெஷர் கூடலாம். அதனால நிறைய ஸ்டடீஸ் வந்திருக்கு ஸ்ட்ரோக் வரலான்னு சொல்லி. அதனால டெஃபினட்டாக யூ நீட் சம் இன்வெஸ்டிகேஷன்ஸ். அதுக்கு நிறைய ட்ரீட்மெண்ட் வந்திருக்கு சார். இப்போ ஃபஸ்ட்டு நம்ம ஸ்லீப் ஹைஜீன் செக் பண்ணிவிட்டு ஸ்லீப் அஃபெக்ட் ஆகிருக்கா, ஓஎஸ்ஏ இருக்கா, தென் தைராய்டு டெஃபிஷியன்சி இருக்கா, இதெல்லாம் ஒரு நல்ல ஃபிசிஷியன் பார்த்து செக் பண்ணிங்கன்னா ஸ்லீப் ஸ்டடீஸும் பண்ணுறாங்க. அதில் பண்ணிங்கன்னா ஸ்லீப் அஃபெக்ட் ஆகுதா இல்லையா, இல்லை நார்மலாக இருக்கா, இதெல்லாமே தெரிஞ்சிடும். தென் வி கேன் டிசைட் வாட் டைப் ஆஃப் ட்ரீட்மெண்ட் உங்களுக்கு தேவைப்படும்னு சொல்லி பண்ணிவிட்டு பிளட் ப்ரெஷரையும் டெஃபினட்டாக கண்ட்ரோல் பண்ணணும் சார். பிளட் ப்ரெஷர் கரெக்டாக கண்ட்ரோல் பண்ணிட்டு இல்லை அப்போனா பிரச்சனை இல்லை. இது நம்ம இதுக்கு ட்ரீட்மெண்ட் எடுக்கணும். இன் ஃபியூச்சர் இது வர சான்சஸ் ஆர் தேர். அதனால ப்ரிவென்ஷன் இஸ் பெட்டர் தேன் கியூர்.
ஓகே, தேங்க்யூ சார். தேங்க்யூ.
Sleep study is important. Sleep study. That's it. Questions? So you must tell me because
தமிழ்ல கூட கேட்கலாம் கேள்விகள். வந்து
சில பேருக்கு வந்து சுகர் இருக்கும், பிபி இருக்கும், கொலஸ்ட்ரால் இருக்கும், ஹார்ட்டில் அட்டாக் வந்திருக்கும், ட்ரீட்மெண்ட் எடுத்திருப்பாரு, சரியாயிருக்கும். கிட்னியில் கொஞ்சம் ப்ராப்ளம் வந்திருக்கும், சரியாயிருப்பாரு. இது என்னுடைய ஒரு பேஷண்ட்டுக்கு அங்கே இருக்க ராதாகிருஷ்ணன். எழுந்துக்காங்க, சொல்லுங்க.
அனைவருக்கும் என்னுடைய காலை வணக்கங்கள்.
நான் வந்து 1993 இன்னைக்கு தேதி வரைக்கும் 33 வருஷமாக டாக்டர் நர்சிங்கிட்ட தான் ட்ரீட்மெண்ட் எடுத்துக்கிட்டு இருக்கேன். ஒரே டாக்டர் தான், வேறு எந்த டாக்டர்கிட்டையும் நான் போகிறதில்ல. வெளியூர் போனால் கூட அவர்கிட்ட சொல்லிவிட்டு என்னென்ன செய்யணும்னு கேட்டுட்டு போவேன். அது பிரகாரம் எனக்கு வந்து அவர் சொன்ன மாதிரி பிபி இருக்குது, கொலஸ்ட்ரால் இருக்குது, சுகர் இருக்குது, எல்லாமே கண்ட்ரோலில் இருக்குது. தொடர்ந்து நான் அவருடைய மெடிசன்ஸ் எடுத்துகிட்டு வர்றதுனால எனக்கு எல்லாம் ஃபேவரபிள் வாழ்க்கை. ஆனால் என்னுடைய ஒரே ஒரு சந்தேகம், சில நேரங்களில் காலில் 2 கால்லையும் வீக்கம் வருது இல்லையா, அது பிபினால் வருதா, சுகர்னால் வருதா, கொலஸ்ட்ரால்னால வருதா, அப்படிங்கிறத கொஞ்சம் தெளிவு பண்ணிங்கன்னா நல்லாயிருக்கும்.
கால் வீக்கம் ஃபஸ்ட்டு நம்ம பார்க்க வேண்டியது வயசானவங்களுக்கு ஃபஸ்ட்டு மெடிசன் ரிலேட்டடான்னு பார்க்கணும். இப்போ எல்லாருக்குமே கால் வீக்கம்னா ஒரு பயம் என்னென்னா இருதய பிரச்சனை இருக்குமா, கிட்னி பிரச்சனை இருக்குமா, பயமே கிடையாது. முக்கியமாக பிபிக்கு எடுத்துக்கிற அம்லோடிபின் வகையான மாத்திரைகளில் கால் வீக்கம் வரலாம். இப்போ கால் வீக்கம் இருக்குது, எப்போ பயப்படணும் அப்படின்னா, வெறும் கால் வீக்கம் பிரச்சனை இல்லை, அதாவது மூச்சு வாங்குறது இல்லை, படபடப்பு இல்லை, படுத்தா ஏதோ ஒரு டிஸ்கம்ஃபர்ட் மாதிரி இருக்கும், அந்த மாதிரி எதுவும் இல்லை அப்படின்னா பயப்பட வேண்டாம்.
அந்த மாதிரி எதுவும் இல்லை சார்.
கால் வீக்கம் படுத்து நம்ம எந்திரிக்கும் போது கால் வீக்கம் குறைஞ்சிருந்து அப்படின்னா அது மருந்து ரிலேட்டட் மட்டும்தான். ஸோ அது கால் வீக்கம் வந்து ஜாஸ்தி ஆகிட்டே போகுது, நமக்கு வேற ஏதோ ஒரு சிம்டம், இருதய சம்மந்தப்பட்ட சிம்டமோ, கிட்னி சம்மந்தம் மூச்சு வாங்குறதோ, கையிலும் வீக்கம் வரும், அந்த மாதிரி இருந்தால் நம்ம உடனே டாக்டரை பார்த்து கிட்னி சம்மந்தப்பட்ட ப்ராப்ளம் இருக்கா, ஹார்ட் சம்மந்தப்பட்ட ப்ராப்ளமாக இருக்கான்னு பார்க்கணும். மேஜராக அந்த அம்லோடிபின் மாத்திரையை நம்ம வேறு ஏதாவது மாத்திரையாக மாற்றிட்டா அந்த கால் வீக்கம் குறைஞ்சிடும். ஆனால் அந்த கால் வீக்கம் இருக்கிறவங்க நடக்கும்போது கால் வலிக்குதான்னு பார்க்கணும், இழுத்து பிடிக்கும் மசில், அது இருந்தாலும் உடனே நம்ம டாக்டரை பார்க்கணும்.
நீங்கள் சொன்ன எதுவுமே இல்லை சார். ஆனால் அந்த வீக்கம் வந்து எப்பயாவது வருது, உடனே 2 நாளில்
சரியாயிடுதுன்னா உங்களுக்கு டேப்லெட் ரிலேட்டடாக இருக்கலாம். இல்லை வயசானவங்களுக்கு நம்ம வந்து ரத்த நரம்புலாம் வீக்காக இருக்கும் போது வீக்கம் வரும், அப்புறம் சரியாயிடும்னு சொல்லுவோம்.
இன்னொரு சந்தேகம் சார், எனக்கு இந்த மாத்திரைங்கள்லாம் ரெகுலராக எடுத்துக்கிறதுனால எல்லாமே கண்ட்ரோலில் இருக்குது. எல்லாமே கண்ட்ரோலாக இருக்கும்போது மாத்திரைங்களை கொஞ்சம் குறைக்கலாமா அல்லது எடுக்கிறத நிறுத்தலாமா? அப்படி
பிபியோட அளவு குறையும் போது டைட்ரேஷன் சொல்லுவோம். பிபி மாத்திரையோட அளவு நம்ம டாக்டரை பார்க்கும்போது அவரே குறைப்பார். இப்போ 130/80 இருக்கு, 2 மாத்திரை எடுத்துட்டு இருக்கேன் அப்படின்னா குறைக்க வேண்டாம்.
சரி.
அப்போ 130/80 இருக்கிறது 110 இருக்கு, 100 ஆகுது, அப்போனா கண்டிப்பாக மாத்திரையோட பவர் குறைப்பும், இல்லை ஒரு மாத்திரை நிறுத்தலாம். மாத்திரை கண்ட்ரோல், பிபி மாத்திரையால் பிபி கண்ட்ரோல் இருக்குன்னா மாத்திரை நிறுத்தக்கூடாது, அதை அப்படியே கண்டினியூ பண்ணணும், லைஃப் லாங் கண்டினியூ பண்ணணும்.
இந்த பிபிஏ லைஃப் லாங் வராமல் இருக்கிறதுக்கு என்ன சார் பண்ணணும்?
உப்பு, நரசிங்கன் சார் எப்பயுமே சொல்லுவாரு, உப்பு இல்லா பண்டம் குப்பையிலேன்னு சொன்னாங்க இல்லையா, அது கிடையவே கிடையாது. உப்பு இல்லாமல் நீங்கள் சாப்பிட்டீங்கன்னா, அதாவது அளவா உப்பு, டேஸ்ட் கம்மியா இருக்கும், சாப்பாடு டேஸ்ட் கம்மியா இருக்கணும், அப்பதான் உப்பு இல்லை, உப்பு கம்மியா இருக்கணும். டேஸ்டா சாப்பிட்டீங்கன்னா பிபி கண்டிப்பா வரும்.
இப்போ 3 கிராம் தான் சொல்லியிருக்காரு ஒரு நாளைக்கு.
இல்ல 6 கிராம் வரைக்கும் சாப்பிடலாம் நார்மல் மனுஷங்க, 6 to 8 கிராம். பட் 5 கிராம்குள்ள நீங்க சாப்பிட்டீங்கன்னா, யாரா இருந்தாலும் பிபி இருக்கிறவங்க வியாதி இல்லாதவங்க 5 கிராம்குள்ள நம்ம சாப்பிட்டோம்னா வியாதி பிபி வரவே வராது.
Okay sir, thank you sir.
He had some other complications, so I advised him to go for only 3 grams because he developed a severe urinary tract infection, became delirious, acute kidney injury, like that. No, so many problems. Okay. Anyhow, let us not discuss about the problems what has been encountered by our patients, and they should voluntarily tell us what is happening and what is to be done. Sir, yes sir, please.
உங்களை முதல்ல பாராட்டணும் டாக்டர் நரசிங்கம் பேஷண்ட்டை. ஒரே டாக்டர்கிட்ட 30 வருஷமாக இருக்கேன், அது ரொம்ப 32 வருஷம். அடிக்கடி டாக்டருங்களை மாற்றாதீங்க. அந்த காலத்தில் குடும்ப டாக்டர் இருந்தார், குடும்ப ஜோசியர் இருந்தார், ஜோசியரை வேணால் மாற்றலாம், ஆட்சி மன்னா. ஆனால் வந்து இந்த ஒரே டாக்டர்கிட்ட இருக்கிறது நல்லது. எல்லாத்துக்கும் இங்கே நாங்கள் அப்போலோ டாக்டர் இருக்கேன், சவிதா டாக்டர் இருக்காங்க, கவர்மெண்ட் ஜிஹெச் ஸ்டான்லி, எல்லாம் பெரிய பெரிய டாக்டர்ஸ், திண்டுக்கல்லேருந்து டாக்டர் வராங்க. ஸ்பெஷலிஸ்ட்டு தேவையில்லாமல் வராதிங்க. உங்கள் டாக்டர்கிட்ட, ஒரு டாக்டர்கிட்ட உங்கள் குடும்பத்தை, உங்கள் உடல் நலனை ஒருத்தர்கிட்ட ஒப்படைச்சிருங்க. இன்னொரு டாக்டர்கிட்ட அனுப்பணுன்னா அவர் அனுப்புவார். நரசிங்கம் தேவைப்பட்டால் கார்டியாலஜிஸ்க்கு அனுப்புவார், நெஃப்ராலஜிஸ்க்கு அனுப்புவார், டயபெட்டாலஜிஸ்க்கு அனுப்புவார். அதனால் அந்த பழக்கத்தை நான் முதல்ல பாராட்டணும். நீங்கள் கேட்குற கேள்விகள் மற்றவங்களுக்கும் பயனுள்ளதாக இருக்கணும். ஏன்னா நீங்கள் கேட்குற மெசேஜ் சொல்கிறது மற்றவங்களுக்கும் பயனுள்ளதாக இருக்கணும். அதனால் எல்லாரும் ஆங்கிலத்தில் பேசணும்ல, தமிழ்லேயும் சொல்லலாம். குறிப்பாக இந்த ஞாயிற்றுக்கிழமை அன்னைக்கு இன்றைக்கி வந்து எத்தனை சீரியல் இருக்குது, எவ்வளோ புதுப்படம் ரிலீஸ் இருக்குது, எல்லாத்தையும் விட்டுட்டு நீங்கள் வந்திருக்கீங்க. எல்லாரும் 100 வயசு வாழணுங்கிற ஆசையோடு வந்திருக்கிறோம் இல்லையா? 100 வயசு வேண்டாங்கன்னு யாராவது சொல்லுங்கப்பா, கை தூக்கும். இல்லை, 100 வயசு வாழணும்னா நம்ம எல்லாரும் இங்கே இருக்கிறவங்க டாக்டர்ஸோட பேச்சை கேட்கணும். எல்லாத்தோட வந்து ஒருத்தர் கொடுத்த மருந்து இன்னொருத்தர் சாப்பிடக்கூடாது, அக்கா கொடுத்தது தம்பி சாப்பிடக்கூடாது, தம்பி கொடுத்தது அக்கா சாப்பிடக்கூடாது. எல்லா விட முக்கியம் கன்சிஸ்டண்ட்டாக ஒரே டாக்டர் கிட்ட போயிட்டு இருந்தால் தான் உங்கள் ப்ராப்ளம் தெரியும். டாக்டர் அமுலோடிப்பின் ப்ராப்ளத்தை பற்றி டாக்டர் வெங்கடகிருஷ்ணன் அழகாக சொன்னார். ரொம்ப கரெக்ட். ஏன்னா அது வந்து எழுதின டாக்டருக்கு தான் தெரியும். அதனால் நான் எப்பவுமே சொல்கிறது உண்டு, உங்கள் டாக்டர் எழுதினாருன்னா அவருக்கு ஏதாவது காரணம் இருக்கும், அவர்கிட்டயே போயிருங்க, அவர்கிட்ட போய் சொல்லுங்கள். அவர் மாற்றணும்னு நினச்சா அவரே மாற்றி கொடுப்பார். நானே ஒன்று மாற்றுறதை விட I think that better the doctor who prescribed follows up and changes, it will be good. Thank you.
Good morning, sir. நீங்கள் சொன்னீங்க 100 வயசு வரணும் எல்லாத்துக்கும் ஆசை. I am ரங்கநாயகி ராஜகோபால். My age is, I am 82 years young.
Very good.
Thank you. Thank you so much. Thank you. I appreciate you all. Thank you.
You look like around 50.
Thank you so much. I appreciate you, sir. நீங்கள் சொன்னீங்க ஒரே டாக்டர் கிட்ட தான் பார்க்கணும். மை கன்சல்டன்ட் இஸ் டாக்டர் கே சுப்ரமணியம். அவர்கிட்ட தான் நானும் பார்த்துட்டு இருக்கேங்க. ஐ எம் டயபெட்டிக், கொலஸ்ட்ரால் இருக்குது, ஆஸ் யூஷுவல் பிபிஎம் இருக்குது. பட் மெடிசன்ஸ் தெர்மிஸ்டாட்டின் அண்ட் காலையில் வந்து சிலக்கால் எடுத்துகிட்டு தான் இருக்கேங்க. எவ்ரி திங் இஸ் அண்டர் கண்ட்ரோலில் தான் இருக்காங்க. இப்போ நீங்கள் சொன்னீங்க சால்ட்டு குறைக்கணும்னு சொல்லிட்டு இருக்கீங்க. சால்ட்டு நாங்கள் லிமிட்டடாக தான் யூஸ் பண்ணிகிட்டு இருக்கேன். சால்ட்டுக்கும் ஆயிலுக்கும் ஏதாச்சும் கனெக்ஷன் இருக்குங்களா? நம்ம யூஸ் பண்ணுற குக்கிங் ஆயில், இப்போ நீங்கள் சால்ட் வந்து லிமிட்டடாக யூஸ் பண்ண 1 டீஸ்பூன் அப்படின்னு சொல்கிறீங்க. இட்ஸ் குட், வி ஆல்சோ டூ இட். அண்ட் தென் சால்ட்டு போட ஆயில் வந்து குக்கிங் ஆயில் கூட சம்டைம்ஸ் இந்த ஆயில் வேண்டாம் அதுன்னு சொல்கிறாங்க, கீ யூஸ் பண்ண வேண்டாம் அப்படின்னு சொல்கிறாங்கல்ல கொலஸ்ட்ரால்க்கு. லைக் வைஸ் குக்கிங் ஆயில் கூட சேம் ஆயில் யூஸ் பண்ணணுமா, இல்லை பர்டிகுலர் ஆயில் யூஸ் பண்ணணுமா? அந்த மாதிரி ஐ ஹேவ் அ டவுட் அஸ் அ ஹவுஸ்.
சால்ட்டை பற்றி நிறைய பேர் பேசிட்டோம், அது வேண்டாம். குக்கிங் ஆயில் பற்றி ஐ திங்க் ஜேசி சேகர்
ரொம்ப நீ கேட்டது முக்கியமான கேள்விமா.
Thank you,
ஒவ்வொரு குடும்ப தலைவிக்கும் இயற்கையாகவே மனசில் ஏற்படுற சந்தேகம் அது. ஏன்னா டிவியில் வந்து பார்த்தீங்கன்னா ஏற்பட்ட ஆயில் அவங்க அட்வைஸ் பண்ணுறாங்க, இது நமக்கே தெரிய மாட்டேங்குது. நம்ம நாட்டில் பாரம்பரியமாக என்ன தான் நமக்கு நல்லதுமா. நல்லெண்ணெய் கடலெண்ணெய் பெஸ்ட்டு, தேங்காய் அளவாக சேர்த்துக்கலாம். சூரியகாந்தி எல்லாம் சில பேர் வேணாங்கிறாங்க, நிறையா பிரச்சனை இருக்குது. நெய் வந்து 1 ஸ்பூன் சேர்த்துக்கலாம், 5 ml per day. அன்ன சுத்தின்னு சொல்லுவாங்க நெய். ஒரு நாளைக்கு 3 ஸ்பூன் எண்ணெய் சேர்த்து, அதுக்கு மேலே சேர்க்கறது வேண்டாம். உங்கள் குடும்பத்தில் ஒரு ஆளுக்கு ஒரு மாதம் எண்ணெய் அளவு 6 லிட்டர் தான், அதுக்கு மேலே வேண்டாம். பிபியோ சுகரோ இல்லை 2 சேர்ந்து இருந்தாலோ கொலஸ்ட்ரால் அதிகமாக இருந்தாலோ ஒரு மாதத்துக்கு உங்களுக்கு என்ன செலவு, ஒரு பர்சனுக்கு 6 லிட்டர். ஹஸ்பண்ட் 2 பேர் இருந்தால் ஒரு மாதம் 1 லிட்டர் மேக்ஸிமம். உங்கள் அதர் சோர்ஸ் நல்ல கொழுப்பை மற்ற இதில் நீங்கள் எடுத்துக்கலாம். ட்ரை ஃப்ரூட்ஸ்லாம் கொழுப்பு நிறையா இருக்குது, உணவு பழக்கத்தில் கொழுப்பு நிறையா, அதெல்லாம் எடுத்துக்கலாம். தவிர்த்து எண்ணெய் வந்து கம்மியாக சாப்பிட்றது ரொம்ப முக்கியம். 1 ஸ்பூன் உப்பு, 3 ஸ்பூன் எண்ணெய், 100லேருந்து 150 கிராம் சுண்டல் தினம் வேக வச்சு சாப்பிடுங்க. 200லேருந்து 250 கிராம் ஃப்ரூட்ஸ் டெய்லி சாப்பிடுங்க. 1/2 கிலோ காய்கள் சாப்பிடுங்க. 2 லிட்டர் கிராம் தண்ணி குடிங்க. 7 மணி நேரம் தூங்குங்க. 40 நிமிஷம் நடங்க. 20 நிமிஷம் யோகா பண்ணுங்க. 100 வயசு தான், சந்தேகமே இல்லை.
சேகர் சார், எல்லாரும் கேட்குற கேள்வி நிறையா, பாம் ஆயில் சேர்த்துக்கலாமான்னு.
வேணாமா, பெஸ்ட்டு எண்ணெய் நல்லெண்ணெய் கடலெண்ணெய். ஒரே எண்ணெயாக சேர்க்காம மாற்றி நீங்கள் தாலிக்கு ஒரு எண்ணெய் வச்சுக்கோங்க, வீட்டில் வச்சுன்னா அப்பெல்லாம் பறிக்கிட்டு வர எண்ணெய் வச்சுக்கோங்க. அது மாதிரி பிரித்து வச்சுக்கலாம். தேங்காய் நல்லதுன்னு சொல்கிறாங்க, தேங்காய் எல்லாமே அளவு தான். ஒரு நாளைக்கு
சார் எக்ஸ்கியூஸ் மீ, கேரளாவில் எல்லாரும் தேங்காய் எண்ணெய் தானே யூஸ் பண்ணிட்டு இருக்காங்க. அவங்க நம்மளை காட்டிலும் ஹெப்டியா
இல்லைம்மா, ஹார்ட் அட்டாக் அதிகமாக இருக்குது. கேரளா வந்து மலைநாடு, அவங்க மேலே இறங்கி இருக்கணும். அவங்க பார்த்தீங்கன்னா ரொம்ப அந்த மலை மேலே ரொம்ப கடுமையான உழைப்பாளர்கள் கேரளாவில். இப்போ வேணால் ரிச்சாக இருக்கலாம், அந்த ஆரம்பத்தில் பாரம்பரியத்தில் கேரளா ரொம்ப கஷ்டமான டெரைன். அவங்க ஃப்ளாட்டாக நம்ம நாடு சமாதானம் பிளாட்டூர் நடந்துடுறோம். கேரளா அப்படி கிடையாது, அவங்க மேலே ஏறணும் குதிக்கணும், சமாதானமே கிடையாது. அதான் அவங்களுக்கு ஒத்துக்கிட்டுது. அங்கே நமக்கு அப்படி கிடையாது, நமக்கு நல்லெண்ணெய் தான். நம்ம உலகத்தில் நம்ம எங்கே பிறந்தோம், நேட்டிவ் பிளேஸ் எங்கோ, அதுலேருந்து 100 கிலோமீட்டர் ரேடியஸ் நமக்கு என்ன உணவு கிடைக்குதோ அதான் நமக்கு பெஸ்ட்டு உணவு. தெரிஞ்சுங்க. எனக்கு வந்து கிவி ஃப்ரூட் வேண்டாம், ஆலிவ் ஆயில் வேண்டாம், நல்லெண்ணெய், இளநீ, வெள்ளரிக்காய், இதான் என்னோட உணவு. வெண்டைக்காய், அவரைக்காய், இதான் என்னோட உணவு. அது மாதிரி தெரிஞ்சுக்கலாம். நம்ம
மஸ்டர்ட் ஆயில்,
ரைஸ் பிரான் ஆயில், ரைஸ் பிரான் ஆயில் சொல்றாங்க சார், அது கூட
ஆமா.
என்ன?
நம்ம சிம்பிளா நல்லா கிடைக்கும் சார். அது யூஸ் பண்ணலாமா? பட் சிம்பிள் சார் நல்லா
இப்போ நான் வந்து
செக் பெஸ்ட்.
ஓகே
நோ நோ
யா
நோ
யா
ரிஃபைன்ட்
யா
ஆயில்.
ஐ ஹர்ட் சார். இப்போ நான் எனக்கு நீ ரீப்ளேஸ்மெண்ட் பண்ணியிருக்காங்க. இன்ஸ்பைட் ஆஃப் தட் இப்போ நான் வந்து 1/2 hour டெய்லி வாக் பண்ணிட்டு இருக்காங்க பீச்சில். ரியலி 3 to 4 kilometers 5 kilometers கூட சம்டைம்ஸ் ஆகிடும். தட் இப்போ நான் கொலஸ்ட்ரால்க்கு ரோசிடேயிஸ் அது எடுத்துட்டு இருக்கேங்க. எவ்ரி திங் அண்டர் கண்ட்ரோல்னு இருக்குது. இப்போ என்னோட ஹைப்போதைராய்டிசமுக்கும் என்னுடைய பிபிக்கும் ஏதாச்சும் கனெக்ஷன் இருக்குங்களா?
ஹைப்போதைராய்டம் வந்து உலகத்தில் வாழ்வுள்ள எல்லா சிஸ்டத்தையும் நேரடியாக பாதிக்கும். ஹைப்போதைராய்டம் இருந்தால் பிபி சுகர் எல்லாமே ஒர்சன் ஆகும்.
அப்படிங்களா?
ஸோ இது ஹைப்போதைராய்டிசம் வந்து உடம்பு எல்லா சிஸ்டத்தையும் பாதிக்கும்.
ஓகே
கரெக்டாக நீங்கள் வந்து நீங்கள் பிபி கண்ட்ரோலில் இருந்தால் தைராய்டு கரெக்டாக இருக்கும். தைராய்டு கண்ட்ரோலில் இருந்தால் தான் மற்ற எல்லாமே ஒழுங்காக ஒர்க் பண்ணும்.
ஓகே
சுகர் கண்ட்ரோல் ஸோ தைராய்டு மாத்திரம் அப்போ செக் பண்ணி கண்ட்ரோல் ரொம்ப ரொம்ப முக்கியமா.
சரி
டைரக்ட் ரிலேஷன்ஷிப் கிடையாது. பட் எல்லாம் அதே ஒர்க் இன் கோஆர்டினேட்டட் வே. இது எல்லாம் ஒன்றா தான் நீங்கள் நல்லா இருக்க முடியும்.
ஓகே சார்.
உங்களுக்கு ஹைப்போதைராய்டும் கொஞ்சோண்டு பிபி ஏற்றும். அது கரெக்டாக அதையும் பார்த்துக்கிட்டு அனீமியாவும் கரெக்ட் பண்ணும், கால்சியம் விட்டமின் டியும் கரெக்ட் பண்ணும்.
சரி. Appreciate you, sir. Thank you so much.
Sir, good morning, sir. My name is Dhanraj. I want to know what is the suggested walking practice. When we go for the morning walking in the park, some people say brisk walking or fast walking is suggested. Some says normal walking is suggested. What is your feedback, sir?
Yes, sir. Actually, வந்து ஹெல்த்தி இண்டிவிஜுவல்னா பிரிஸ்க் வாக்கிங் இஸ் பெஸ்ட். நான் ஏற்கனவே சொன்ன மாதிரி உள்ள பிளட்டு ரத்த குழாய் இருக்கு இல்லையா, ரத்த குழாயில் தான் உங்களுக்கு அடைப்பு வருது. ஹார்ட் அட்டாக்கு ஸ்ட்ரோக்கு எல்லாம் அதில் தான் வருது. அந்த ரத்த குழாய் நீ பிரிஸ்க் வாக் பண்ணும்போது தான் பிளட் சர்க்குலேஷன் வரும்போது அந்த இது டெபாசிட்லாம் வாஷ் பண்ணிகிட்டே போயிடுது. இன்டர்னலாக வாஷ் பண்ணு. தட்ஸ் வாட் ஐ டோல்ட் ஏற்கனவே. நான் குளிக்கிறீங்கன்னா அவுட் சைடு, பட் இன்டர்னலாக குளிக்கிறது வந்து பிரிஸ்க் வாக்கிங். அந்த பிளட் சர்க்குலேஷன் ஆகும்போது நம்ம உள்ள இருக்கிற எல்லா கழிவுமெல்லாம் அடிச்சுன்னு போயிடுது. ஸோ அவங்களுக்கு வந்து டெபாசிட்டே வராது. நைட்டு பூரா தூங்கிட்டு இருப்போம், 7 hour தூங்குவோம். அந்த கொலஸ்ட்ரால் அப்படியே டெபாசிட் ஆகிருக்கும். உள்ளே இறங்கி உள்ள அத்ரோஸ்குலஸ் மாதிரி ஃபார்ம் ஆகும் பிளாக்கு. அதுக்குள்ளே எழுந்து ஃபாஸ்ட்டாக நடந்தீங்கன்னா அதெல்லாம் பிச்சுன்னு போயிடும். ஸோ அதனால் உங்களுக்கு வந்து அந்த பிளாக்கே வராது. பிரிஸ்க் வாக்ஸ் இஸ் பெஸ்ட். யாருக்கு ஆர்டினரி வாக்கிங்னாக்கா முடியாதவங்களுக்கு, கால் வந்து சப்போஸ் ரொம்ப சிக் பேஷண்ட்டு, ரொம்ப ஓல்டு ஏஜ், அவங்கள போய் பிரிஸ்க் எங்கே போக முடியும்? நடக்கிறதே கஷ்டம், அவங்க பிரிஸ்க் போக முடியாது. அவங்க இல்லை ரொம்ப ஒபிஸாக இருக்கிறவங்க, அவங்க பிரிஸ்க் போனாக்கா ஹார்ட் அட்டாக் நிறைய வந்து இன்னும் ஹார்ட் அட்டாக் வந்துடும். ஸோ முடியாதவங்கலாம் போகக்கூடாது. சிக்கு கோமா பர்சன் நிறைய இருக்குது, அவங்க பிரிஸ்க் வாங்கி போகிறது கஷ்டம். ஏன்னா போனால் மற்ற சிஸ்டம் அஃபெக்ட் ஆகிடும். அதனால் ஹெல்த்தி இண்டிவிஜுவல் நார்மல் ஈவன் எல்டர்லியில் கூட ஹெல்த்தியாக இருப்பாங்க. சார் சொன்னார் பாருங்க, 88 வயசு, நான் போயிட்டு பக்காவாக இருக்கிறாரு. அவருக்கு 68 மாதிரி தான் இருக்காரு. 20 வருஷம் கம்மியாக தெரியுது. அவரும் நல்லா பிரிஸ்காக போகலாம். யாரெல்லாம் பிரிஸ்காக போக முடியுமோ அவங்க பிரிஸ்காக போகிறது பெஸ்ட்டு. யாரெல்லாம் முடியாதோ அவங்க பிரிஸ்காக போகக்கூடாது, போனாக்க ப்ராப்ளம் வந்துடும். ஸோ அதுதான் வந்து கான்செப்ட். ஸோ அதனால் பிரிஸ்க் வாக்கிங் ஆக்சுவலாக என்ன சொன்னால், வாக் பண்ணோம்னாக்கா இதில் எல்லா சிஸ்டத்தோட பிளட் சர்க்குலேஷன் ஆகி எல்லா செல்லும் நல்லா வேலை செய்யும். 100 வயசில் 120 வருஷம் வரும். இஃப் யூ குட் பிரிஸ்க் வாக் ரெகுலர்லி யூ லீவ் ஃபார் மோர் தென் 100 years. ஸோ நோ இஷ்யூ அட் ஆல்.
தேங்க்யூ சார். சார் எவ்வளோ நேரம் வாக் பண்ணணும் சார் ஒரு நாளைக்கு? வாட் இஸ் தி ஆவரேஜ் வி ஷுட் வாக்?
சார் வாக்கிங்னு எடுத்துக்கும் போது, உடற்பயிற்சின்னு எடுத்துக்கும் போது குறைஞ்சபட்சம் 1/2 மணி நேரத்துக்கு மேலே நீங்கள் பண்ணும்போது உங்களுக்கான பலன் கிடைக்கும். வெறும் ஒரு 5 நிமிஷம் நான் நடக்கிறேன், 10 நிமிஷம் நடக்கிறேன்ற போது பெரிய பலன் இருக்காது. பட் இன்னும் கொஞ்சம் வயசில் குறைவாக இருக்கிறவங்களா இருந்தால் 1 மணி நேரமாவது உடற்பயிற்சி பண்ணுங்கன்னு சொல்லுவோம். பட் மினிமல் ரிக்குவயர்மெண்ட் வந்து குறைஞ்சபட்சம் 1/2 மணி நேரமாவது பண்ணுங்க அண்ட் கன்சிஸ்டண்ட்டாக பண்ணுங்க. அந்த எப்படின்னா, நான் வந்து இந்த வாரத்தில் 2 தடவை வாக்கிங் போகிறேன், 3/4 மணி நேரம் வாக்கிங் போகிறேன், மீதி இருக்க நாள் நான் ஒன்றுமே பண்ணலை அப்படின்னா பெரிய பலன் கிடைக்காது. ஸோ சில ஆய்வுகளில் நீங்கள் நிறைய படிச்சிருந்தீங்கன்னா சொல்லுவாங்க, வாரத்துக்கு 5 முறையாவது பண்ணுங்க வாக்கிங் அப்படின்னு சொல்லுவாங்க. இதெல்லாம் வெளிநாட்டவர்கள்கிட்ட இருந்து வந்த டேட்டா. ஏன் நம்ம 5 நாளோட நிறுத்தணும்? அடுத்த 6வது நாளும் 7வது நாளும் முடியும்னா அன்னைக்கும் நம்ம பண்ணலாம். ஞாயிற்றுக்கிழமை கூட நம்ம எக்ஸசைஸ் பண்ணலாம். இன்னொன்று, வாக்கிங் மட்டும்தான் உடற்பயிற்சின்னு கிடையாது. ரொம்ப நல்லது வாக்கிங். சார் சொன்னார் பிரிஸ்க் வாக்கிங் வந்து இருதயத்தை நல்லா பலப்படுத்தும், அதெல்லாம் கரெக்டு. மனசுக்கு நல்லா இருக்கும், எல்லாமே கரெக்டு. பட் வாக்கிங் மட்டும்தான் எக்ஸசைஸ்னு கிடையாது. நிறைய பேருக்கு மூட்டு பிரச்சனை இருக்கும், அவங்களால நடக்க முடியாது. அண்ட் வாக்கிங் எப்போ பண்ண முடியும் தெரியுமா? விடிய காலையில் தான் பண்ண முடியும். அதுக்கப்புறமா டிராஃபிக் வந்துடும், பொல்யூஷன் வந்துடும், இல்லை நைட்டு லேட்டாக வெயில் வந்துடும், இதெல்லாம் பண்ண முடியாது. ஸோ அப்போ என்ன பண்ணுங்க, ஆல்டர்னேட் எக்ஸசைஸ்ன்னு நிறைய கற்று வச்சுக்கோங்க. ஜிம்முக்கு போகணும்னு அவசியம் இல்லை, எக்யூப்மெண்ட் வீட்டில் வாங்கி வைக்கணும்னு அவசியம் இல்லை. யூடியூப் எடுங்க, இன்டோர் ஃபிசிக்கல் ஆக்டிவிட்டின்னு போடுங்க, இன்டோர் எக்ஸசைஸ்ன்னு போடுங்க. கொஞ்சம் பெரிய வயசில் இருக்கிறவங்களா இருந்தால் இன்டோர் எக்ஸசைஸ் ஃபார் எல்டர்ஸ்ன்னு போடுங்க. ஏகப்பட்ட நம்ம கையும் காலையும் அசைச்சு பண்ணக்கூடிய ஏகப்பட்ட எஃபெக்டிவாக பண்ணக்கூடிய ஏகப்பட்ட எக்ஸசைஸ் இருக்குது. யோகா ஃபார் பிகினர்ஸ்ன்னு போடுங்க. நம்ம போய் வந்து ஒரு பெரிய ஆசனம்லாம் செஞ்சு நம்ம வந்து அவார்டு வாங்குறதுக்காக போகலை, பாடியை ஃப்ளெக்ஸ் பண்ணுறோம், ஸ்ட்ரெச் பண்ணுறோம். ஸோ நீங்கள் வந்து கஷ்டமான ஆசனங்களை செய்யணுன்றது அவசியம் கிடையாது. யோகா ஃபார் பிகினர்ஸ்ன்னு போடலாம், ஏரோபிக் எக்ஸசைஸ் இருக்குது, நிறைய எக்ஸசைஸ் இருக்குது. ஸோ வெறும் வாக்கிங் மட்டும்தான் எக்ஸசைஸ்னு தவறாக புரிஞ்சுக்க வேண்டாம். என்னால் வாக்கிங்கே போக முடியலையே, நான் என்ன பண்ணுறது, எனக்கு மூட்டு வலி இருக்குது, நடந்தால் மூச்சு வாங்குது. சேர் எக்ஸசைஸ்னு இருக்குது. 80 வயசுக்கு மேலே இருக்கிறவங்கெல்லாம் தடுமாற்றம் இருக்குதுன்னு வச்சுக்கோங்க, சார்கோபீனியா இருக்கும், பலவீனமாக இருப்பாங்க, தடுமாறிட மாட்டாங்க. அப்போ உட்காந்துக்கிட்டே பண்ணுறதுக்கு, ஜஸ்ட் நல்லா சேஃபாக உட்காந்துக்கிட்டே எஃபெக்டிவாகவும் பண்ணுறதுக்கு சேர் எக்ஸசைஸ் ஃபார் எல்டர்ஸ்னு இருக்குது. ஸோ நிறைய எக்ஸசைஸ் இருக்குது. அண்டு மற்ற எக்ஸசைஸ் எல்லாம் பண்ணும்போது இப்போ நீங்கள் வாக்கிங் பண்ணால் கால்களில் இருக்க மசில்ஸுக்கு மட்டும்தான் உங்களுக்கு ஒர்க் அவுட் கிடைக்குது. நீங்கள் பாடியை ஸ்ட்ரெச் பண்ணிங்கன்னா உங்களுக்கு ஏகப்பட்ட மசில்ஸுக்கு வந்து உங்களுக்கு ஒர்க் அவுட் கிடைக்கும். ஸோ வெறும் இது மட்டும்தான் எக்ஸசைஸ் நடக்க வேண்டாம். டாக்டர் ஸ்ருதி wanted to add something. அவங்க வந்து ஒரு ஆப்டான பர்சன் இதை பற்றி சொல்கிறதுக்கு.
தேங்க்யூ சார். ஆக்சுவலி சார் நான் என்ன ஆட் பண்ண விரும்புகிறேன்னா, அவங்க கேட்ட கொஸ்டின்ஸ்க்கு இன்னும் நம்ம இந்தியாவில் இருக்கோம், எவ்வளோ ஆப்ட்னு தெரியல. பட் தேர் இஸ் அ மெத்தட் ஆஃப் வாக்கிங் கால் ஜாப்பனீஸ் மெத்தட் ஆஃப் வாக்கிங். நிறைய பேர் அதை பற்றி கேள்விப்பட்டிருப்பீங்க. 3 நிமிஷம் வேகமாக நடக்கணும், பிரிஸ்கா, உங்கள் பேஸில். உங்களுக்கு எது ஈஸியோ அந்த பேஸ், நாட் இன் கம்பேரிசன். உங்களோட ஒரு வாக்கிங் பார்ட்னர் இருக்காங்கன்னா நீங்கள் அவங்களோட டேலி பண்ணணும்னு அவசியம் இல்லை. ஸோ 3 minutes ஃபாஸ்ட், 3 minutes ஸ்லோ, 3 minutes ஃபாஸ்ட், 3 minutes ஸ்லோ. இந்த மாதிரி 30 நிமிஷம் நடந்தால் அது வந்து உங்களுக்கு வந்து கொழுப்பை குறைக்கும், பிளட் ப்ரெஷர் குறைக்கும், கொலஸ்ட்ரால் குறைக்கும் அப்படின்லாம் புது புது டேட்டா வந்திருக்கு. திஸ் மெத்தட் ஆஃப் வாக்கிங் இஸ் கால்ட் அஸ் ஜாப்பனீஸ் மெத்தட் ஆஃப் வாக்கிங். ஸோ இது வந்து இப்போ ரொம்ப பாப்புலர் ஆகிட்டு வருது. நிறைய பேர் வந்து இந்த 3 minutes ஃபாஸ்ட், 3 minutes ஸ்லோ பண்ணுவாங்க. ஸோ மோஸ்ட் ஆஃப் மை பேஷண்ட்ஸ் ஐ ரெக்கமெண்ட் டூயிங் திஸ் ஜாப்பனீஸ் மெத்தட் ஆஃப் வாக்கிங் ஆல்சோ. அதுவும் வந்து சுகர் கட்டுப்பாடு, பிளட் ப்ரெஷர் கட்டுப்பாடுக்கு ஹெல்ப் பண்ணுறது. ரெண்டாவது, அஃப்கோர்ஸ் இப்போ ப்ரெக்னென்சி அதிலலாம் பார்த்தீங்கன்னா நாங்கள் நிறையா ப்ரெக்னென்ட் டயபெட்டிஸ், ப்ரெக்னென்சி ஹைப்பர் டென்ஷன்லாம் பார்க்கும்போது சேர்ந்தா போல் 45 minutes நடக்கிறது ரொம்ப சிரமமாக இருக்கும், ரொம்ப கஷ்டமாக இருக்கும். அப்படி இருக்கிறவங்களுக்கு போஸ்ட் பிராண்டியல் வாக்னு சொல்லுவோம். சாப்பிட்ட பிறகு ஒரு 5-10 minutes கழித்து ஒரு 15 minutes வீட்டுக்குள்ளேயே நடக்கிறது, ஆர் ஃபிகர் ஆஃப் 8, வாட் எவர் இஸ் த வே தட் தே கேன் என்ஜாய் வாக்கிங். அது ஒரு 5 minutes டாக்டர் ராஜேஷ் சொன்ன மாதிரி ஒரு அப்பர் பாடி எக்ஸசைஸ். அதுலேயும் வந்து வி சி இந்த டயபெட்டிக் ஆர் ஹைப்பர் டென்ஷன் ப்ரெக்னென்ட் விமனுக்கு வந்து நிறைய பேருக்கு சுகர், பிளட் ப்ரெஷர்லாம் குறையிறத பார்த்துருக்கோம். ஸோ வாக்கிங் வந்து உங்கள் இன்டென்சிட்டிக்கு ட்ரை பண்ணுங்கள். ஆப்வியஸ்லி தெர் ஆர் லாட் ஆஃப் வேஸ் தட் யூ கேன் வாக், பட் வாக்கிங் இஸ் வெரி இம்பார்ட்டன்ட். நம்ம எங்கெல்லாம் நடக்க முடியுமோ, ராதர் தென் வாக்கிங் as an exercise which you can do. கடைக்கு போகிறது, படிக்கட்டு ஏறுறது, லிஃப்ட் யூஸ் பண்ணாமல் இருக்கிறது, பார்க்கிங் லாட்டுக்கு நடந்து போகிறது, இந்த மாதிரி எங்கெல்லாம் நீங்கள் உங்கள் பாடிக்கு மூவ்மெண்ட் கொடுக்குறீங்களோ அங்கெல்லாம் உங்களோட இன்சுலின் சென்சிட்டிவிட்டி இம்ப்ரூவ் ஆகும். இன்சுலின் சென்சிட்டிவிட்டி இம்ப்ரூவ் ஆகும்போது டயபெட்டிஸ், கொலஸ்ட்ரால், ஹைப்பர் டென்ஷன், இர்ரெகுலர் பீரியட்ஸ், இன்ஃபர்டிலிட்டி, PCOS, மெட்டபாலிக்லி அசோசியேட்டட் ஃபேட்டி லிவர், இது எல்லாமே ஒரே ஸ்பெக்ட்ரம் ஆஃப் டிசீஸ் தான். இது எல்லாமே உங்களுக்கு வந்து இம்ப்ரூவ் ஆகிறதுக்கு வாய்ப்பு இருக்குது.
தேங்க்யூ. சரி, இப்போ எக்ஸசைஸ் பற்றி நிறைய சொல்லிட்டாங்க. ரொம்ப நேரமாக உட்காந்துருக்கீங்க நீங்கள்லாம். நானும் எழுந்திருந்து போயிட்டு இருக்கேன். எழுந்துக்காங்க தயவுசெய்து. ஒன்லி ஃபார் 1 minute. 1 minute, ப்ளீஸ் ஸ்டாண்ட் அப், இன்க்ளூடிங் டாக்டர்ஸ், ப்ளீஸ். All of you can stand. This is another form of exercise that you are supposed to do. If you are sitting for more than 1 hour, you are inviting trouble. It's almost equal to smoking. So please stand for only 1 minute. Again, go back to your seat. Be comfortable.
அதுக்கு முன்னால் நிறைய பேர் வாக்கிங் வந்து நான் போகிறேன் சார், பக்கத்தில் ஒய்ஃப் வச்சுருப்பாங்க, அவங்க ஒபீஸாக இருப்பாங்க, அவங்களையும் சேர்த்து கூட்டிகிட்டு போங்க. இல்லை ஹஸ்பண்ட் வாக் போனால் ஒய்ஃபும், ஒய்ஃப் வாக் போனால் ஹஸ்பண்டையும் கூட்டிகிட்டு போங்க. தட் இஸ் த வே டு இம்ப்ரூவ் த ஃபேமிலி. Yes.
When I was walking, I was actually trying to have a company of non-medical people, not like Venkatakrishnan or Parandaman. You will be asking all umpteen number of questions about molecular biology. I always enjoyed the company of non-medical people with me because I wanted to have these sort of facilities. So we used to engage in a lot of discussions during that time, including politics, cinema, everything. So please be seated. Please be seated. Thank you very much. Thank you. I think we are now coming to an end. Yes, sir. Bernie.
I'm a neurologist and yoga man. So regarding the exercise, we talks about body, mind, soul and thought in yoga. Your body is a instrument. It tells you what to do, what not to do. Don't follow any standard protocol. Whatever you do, whether you do yoga, whether you do exercise or whatever you do, the body wants you. Suppose you walk for 5 kilometers and one day you feel better, one day you feel tired. So don't follow the same protocol every day. If you are feeling tired the second day, don't go to 5 kilometers, maybe reduce 1 kilometer. The minute you exert more than what the body requires, you will get into problems. Second thing is about hypertension. Hypertension in neurology, and if you don't control the hypertension, people may get two kinds of stroke. One is a bleeding stroke and another is a blocking stroke. So control the hypertension, the risk of stroke comes down significantly down. Uncontrolled hypertension can produce a small block in the small blood vessels in the brain, can produce Parkinson disease like manifestation and dementia. So it's a very silent disease. If you go to the outside and take 100 people and check blood pressure, many people have silent hypertension. I think the real treatment starts in the society. We should go to the society, the school, railway station, bus stop. There is something called pediatric hypertension. The incidence of pediatric hypertension is increasing. We never check the BP for the children. So it's very, very important to check the BP of all ages. And keep an eye on your emotion. Most of the time, heart attack and stroke happens when you're in extreme emotion. When we are shouting in anger, the blood pressure tablet doesn't work. Hypertension, BP shoots up in spite of your BP medication and BP under control. When you're shouting in anger, BP can shoots up. Right time for getting stroke and heart attack. Keep all these things in mind.
Thank you, sir, for your ideas to how to practice exercise and also yoga and meditation and anger, everything. I think now we will come to the end of this session. I think I will request Dr. Chandrasekhar to honor the,
Thank you so much, doctors. A big round of applause to all the dignitaries on the dais here today. I hope all your questions were answered. எல்லாருக்கும் அவங்களுக்கு சம்பந்தப்பட்ட டவுட்ஸ்க்கான பதில்கள் கிடைச்சதா? Did you all get your questions answered? Yes, ma'am, we will save it up for later, maybe after some time. We will have the doctors around so you can talk to them directly as well. All right? Okay, it's time to felicitate the dignitaries on the stage, for which I would like to call Mr. Dr. S. Chandrasekhar. Can we have him on stage, please? He'll be doing the honors. And he's going to be felicitating Dr. K. Kannan, the chairman of Indian Institute of Hypertension. We have Dr. S. Chandrasekhar, secretary of the Indian Institute of Society Hypertension, TNSE, from Stanley Medical College. Up next, Dr. S. Chandrasekhar will felicitate Dr. Y. Vijay Chandra Reddy. A big round of applause, please. Thank you for being among us today, sir. Thanks for your wonderful time. Dr. Y. Vijay Chandra Reddy, the interventional cardiologist at Apollo. Up next, we'll be felicitating Dr. K. Shanmugam, the senior consultant physician at Stedford Hospital. We have Dr. S. Chandrasekhar doing the honors. Up next, I'm going to be calling up Dr. P. Parandaman. A big round of applause for Dr. Parandaman, Department of Medicine, KMC. Next up would be Dr. R. Kannan, the treasurer and the professor of medicine and vice principal of Savita Medical College. And next we have Dr. Arvind Duruvasal from Armora Heart Care. Dr. J.C. Sekhar, the general physician from Dindikal. Thank you so much, sir, for joining us today all the way from Dindikal. A big round of applause for Dr. J.C. Sekhar. And for now, last but not the least, I would like to call Dr. R.P. Rajesh, the general physician from Chennai. Once again, a big round of applause for him. Thank you so much. All right, ladies and gentlemen, thank you so much. Thanks for being such wonderful patient audience. We're going to take a small break, after which we will have a lot of insightful discussions happening. We will have different rounds of presentations and different rounds of panel discussions happening, and we will have some of the best doctors moderating these sessions. All right, we have Dr. Soundararajan as well, consultant nephrologist. A big round of applause. சார் வந்து ரொம்ப அழகா புரியுற மாதிரி எல்லாம் தமிழ்ல வந்து எடுத்து சொன்னார் எல்லாருக்கும் ரொம்ப எளிமையா புரியுற மாதிரி a big round of applause. Thank you sir, thank you so much. You would like to say a few words? And of course, we have Dr. K. Shanmugam doing the honors and felicitating Dr. S. Chandrasekhar. A big round of applause. Professor of Medicine from Stanley Medical College. Can we have all of you together for a photograph, please? All of the gentlemen on stage, can we have all the doctors together? ஒரு பெரிய கைத்தட்டல் தரலாமா for all their wonderful efforts, for being the backbone behind this wonderful awareness initiative today. And the best part is they've been doing it consecutively every year, and every year it's been a success. Thank you so much, sir. Thanks for all your efforts and contribution. Thank you. Thank you so much, gentlemen. Thanks a lot. We'll now take a small break. Oh, we'll start. We'll start talking.
We'll start. Yeah, we can start. So good morning, ladies and gentlemen. So I think we can move on to the scientific program. No. So we can move on to the scientific program. To chair the first session, may I now invite Dr. Vamsi Mohan and Dr. S. Geeta and Dr. K. Shanmugam on stage, please. I request them to invite the speaker and be time conscious, sir.
Yes. Fine. இது வந்து ஸ்க்ரீன் வந்துடும், அதனால நான் கொஞ்சம் அட்ஜஸ்ட் பண்ணுவேன். இல்லைன்னா இதை கொஞ்சம் தள்ளணும், இதை தள்ளி போட்டு ரொம்ப வெயிட்டாக இருக்கும்.
All right, so please settle down. In another 2 minutes, we'll get the main session started, the first session for the day. We're going to be having a lot of sessions back to back. We would like to have your presence as well, so please stay intact. Please regroup in another 2 minutes. And for this first session, we're going to be having one of the most eminent doctors here with us. But before that, I would like to introduce the moderators of this session today. We will have with us Dr. S. Geeta, Dr. K. Shanmugam, and Dr. Vamsi Mohan. They would be the moderators of this particular session. And the first session today would be on home blood pressure monitoring. And the speaker of this session would be Dr. J.C. Sekhar.
சரி, ஃபர்ஸ்ட் ஸ்பீக்கர் வந்துட்டாரா? ஜேசி சேகர் இருக்கார்ல. Now we will move on to the scientific session. I think we got 3 or 4 important session regarding the blood pressure itself. It's not the treatment part. We got first thing is, home blood pressure monitoring. The next one is the ambulatory blood pressure monitoring. Then the masked hypertension and white coat hypertension. I think each speaker, I will request you to stick on to the time 8 minutes. Now I welcome Dr. J.C. Shekhar to talk about the home blood pressure monitoring, which is very, very important. And the home blood pressure monitoring should be made like the home blood pressure sugar monitoring, like your glucometer, so that they can themselves assess where the blood pressure is for themselves. And also all the family members also can utilize that. And it is a painless process. See, even if you measure the glucose, it is painful. But whereas this is a painless and very economical. With this, I will hand over the mic to the speaker. After that,
So since we just had Dr. Geeta join us, we would like to felicitate her. We'd like to do the felicitation to her, and we'll have Dr. Chandrasekhar do the honors. Can we have a big round of applause for Dr. Geeta, please, for joining us for this wonderful session today as a moderator?
Yes, 1 minute. We will honor our person who is the main hero of this event. Yes.
All right, we have with us the main person behind today's event. A big round of applause for Dr. S.N. Narsingan, the Vice President, World Hypertension League. Thank you so much for this wonderful initiative today, sir. Thanks so much. And congratulations on making this a successful one. Thank you.
So நீங்க பேசுறீங்க.
Ask them to project that slide. What I seen is a protocol person. Very, very sensitive. One minute. Are they doing it? Yeah. Already. Thank you. I'm very confident. I cannot do anything here. How can I do? This one, huh? Good morning once again. I left there for some time to inaugurate the scientific session which is happening at Pune during World Hypertension Day. Sorry for the things, of my absence for a short period. And I'm really very happy to have the important doctors who had been invited for this program as either moderator or for speaker. And we are excited to have your company here. I am sure your knowledge probably will improve the approach by all our healthcare professionals to treat their patients. I am sure. Many of you probably may not be knowing about the World Hypertension League. Quickly, I will take you only for 2 minutes because one of the cardiologists who was invited for the Hypertension Summit, he was recognized and he was awarded this World Hypertension League award. After receiving the award, he came and asked me, Dr. Narsingan, what is this World Hypertension League? So that actually had stimulated my interest to tell you briefly about World Hypertension Day before we talk about the activities of World Hypertension League. Okay, this is a non-profit, non-governmental organization dedicated to the prevention and control of hypertension globally. It is the driving force in the global epidemic of NCDs, leading risk factor for death and disability globally. There are various executive committees, and current president is Gianfranco Parati, and Marcus is the president-elect. Dr. Paul Welton was the immediate past president, and I am there as a vice president. Bader is a secretary, and Dr. Michael Weber is the board member as well as the treasurer of our organization.
And there is a certificate course, blood pressure certificate course, which is actually valid only for a period of 6 months. People who are ready to take up this certificate course can log in and then enroll yourself. It is free. It is free, and you will be taught how to examine the blood pressure for your patients in a proper manner, and they will issue a certificate, and it is valid for about 6 months. And we also have blood pressure resources, and we are concentrating in the lowest middle income and lower middle income countries like Africa. And the salt reduction program has been taken at a larger scale, and Campbell has contributed a lot of information on salt reduction for our association. And we have a quarterly newsletter also. Even this activity, what is being now witnessed by all of you, including me, will also get published in the newsletter, which appears once in 3 years, once in 3 months or so. And we have official journal called the Journal of Human Hypertension, and we have accuracy in the blood pressure measurement and device validation and salt reduction protocols. We have this journal, and we encourage the children to get into the activities of hypertension. Though they may not be knowing too much about hypertension, at least the parents must educate what is hypertension, and they are also tempted to do certain activities in the form of artwork. That has been encouraged by the World Hypertension League. Every year we recognize their artwork also by giving them awards. Even this year also they have recognized some of the children who are actually from Nigeria, from England, and even in India. Last 2 years I was actually submitting the children's artwork, which were recognized by this World Hypertension League. And we have the partners. Just look at the partners which name anybody. They are all with us. They are all with us. I am proud to get associated with this largest organization, which is doing multiple academic activities. So, ladies and gentlemen, thank you very much for your attention. Let us move on to the scientific session. I think the first speaker is going to be Dr. J.C. Sekhar, and already over the Morgan Rao is there.
No, everybody is here.
Okay, fine, excellent. I've already introduced, fine, excellent. Please.
We are starting the first வந்து ரொம்ப ரிமார்க்ஸ் போடுவாங்க, கொஸ்டின் ஆன்சர் அதிகம் போடுவாங்க. Everybody knows about this thing. எல்லாத்தையும் முடிச்சுட்டு அதுக்கப்புறம் வேணா லாஸ்ட்.
So good morning all of you. It's my great pleasure to be here with you all this morning and be the opening person of this excellent academic session. We had a wonderful patient public awareness program. It was really useful to all the public who attend the program. The one important thing that was mentioned in the program was about home blood pressure monitoring. And my topic is about the same, home blood pressure monitoring. We know in the past few years, it has become a very important strategy to diagnose blood pressure, to control it, and to maintain it lifelong. So I thought I'll rename slightly the topic of home blood pressure monitoring into home blood pressure monitoring from diagnosis to long-term hypertension control. It's not a single snapshot. It's going to continue throughout. And it can reach to anybody, not only in cities, but also I can see in the picture, thanks to ChatGPT. It's a rural area. The wife is assisting her husband passionately. He's having a pen and a notebook by his side, recording BP in the correct way, and how he's made note of it, and how it helps in diagnosis and maintenance of hypertension. Now, what is the strategy? How is it going to help you actually? What is home blood pressure monitoring? Is a measurement of blood pressure by the patient at home, not in the clinic. Very importantly, it uses a validated, automated BP monitor. Readings are taken over several days. Not a single reading is not enough. As already, it's a journey, I told you. Under standardized conditions, it's different from office BP measurement, ambulatory BP monitoring, ABM and all. And it shows the evolving science of BP monitoring. As our chairperson rightly told, there are 3 distinct entities. One is office BP monitoring, second is home blood pressure monitoring, and then ambulatory blood pressure monitoring. You can consider office BP monitoring as a snapshot. That's a single photograph taken in the clinic when the patient visits you. It's easily and widely available, but not sufficient because it misses white coat effect and masked hypertension. Second is HBPM. It's like a movie abstract or a trailer, you can call it. It's taken at home, multiple readings over several days, and unfortunately there's no nighttime BP reading. It can be done, but you should reserve the patient for that. Whereas ABPM is like a full movie. You watch a full movie for 24 hours, 24-hour ambulatory reading. It includes day, night profile, nocturnal BP, etc. But it's less available and less tolerated. So as you see, we are evolving the science of monitoring of BP, and soon we'll have better tools. But now, why home BP monitoring is important? It's important because, as has been discussed very strongly in the patient in public awareness program, hypertension is a major mortality risk factor for stroke, for myocardial infarction, for heart failure, and chronic blood pressure. Office BP may not reflect true burden, blood pressure burden. And blood pressure varies with the stress, varies with the daily activity. Morning is different, evening is different, night is exhausted, it's different. Time of measurement really matters, and medication time also has a say in it. So home BP monitoring provides repeated readings in the usual living environment. It improves the accuracy of hypertension diagnosis and follow-up. This is why it's important. How to measure BP correctly? These points, we know about it, we talked about so much. It's use a validated upper cuff device. Use a correct cuff size, which is very important. You can't have the same cuff for a obese wife and a thin man or vice versa. Avoid smoking, caffeine, and exercise for at least 30 minutes before measurement. Most important, you should empty your bladder. Morning when you get up, you should go to the bathroom, then only you should record your BP. And sit quietly for 5 minutes. Sit in a comfortable posture, back supported, feet flat on the floor, and arms supported in the heart level. Take 3 readings, 1 minute apart, and take the average of the last 2, and measure in the morning before medication or in the evening before dinner bedtime. Unless you insist to the patient, your home monitoring strategy itself will be a failure. You can take a picture of this released by World Hypertension Day 2024. It teaches you how importantly the support in the back, the emptiness of bladder, so many things. Do not talk while recording BP, support the heart level, everything, it varies the BP, a few millimeter. So it should be very accurate. You should teach the patient properly about how to measure BP. What are the advantages of home blood pressure monitoring? It improves diagnostic accuracy. This is very, very important. Number 2, it detects the white coat hypertension. 15 to 30% of the patients who high BP in the office, they have white coat hypertension. And detects masked hypertension. With 10 to 20% of the people with BP, we have very normal BP in the office, they have masked hypertension. In fact, I was a partner of India Heart Study done by Eris Pharma a few years back. And to my great surprise, even in my patients, I screened about 20 people, 2 or 3 had white coat hypertension and 3 had masked hypertension. Then only it dawned on me that these things really matter. And it provides the multiple readings over time and highlights the BP trajectory. We are more involved about the BP trajectory rather than a single BP reading. This is also very important. And it better reflects the blood pressure in daily life, indicating BP variability. Nowadays, we know blood sugar variability is getting more and more importance. Similarly, BP variability is getting more and more importance nowadays. And it helps assess the response to treatment and avoid therapeutic inertia. This is again very important. Patient will question you, so I want to check my medications are, my BP is high. Improves patient involvement adherence. When you see BP is high, we resort to normal practices. So you make him partner in BP management, and lower cost and more practical than the ABPM. And ultimately, HBPM gives you more representative estimate of the usual BP than isolated clinic recording. Now, how do you use it in the clinical? Clinically, you can use it to diagnose hypertension. First time you say higher BP, second time you say higher BP, third time also you see it, asking by apparatus. It's very cheap nowadays. Automated apparatus is so cheap, just like glucometer. You confirm hypertension, identify white coat hypertension, detect masked hypertension. Next use is treatment monitoring. Assess that response after starting therapy, guide medication titration. This is also very important. Thirdly, for the long-term follow-up, as I already told you, it's not a single day. It's a love affair, lifelong. Monitor BP control list in treated patients, improve adherence and engagement. It's also very important. And fourthly, in special situations like diabetes, CKD, elderly patients, pregnancy, hypertension, surveillance, this is going to be very, very useful as you could really see. And there are some differences between HBPM and the office readings. Home BP is usually lower. This you should remember, lower than office BP. Commonly used threshold for hypertension and HBPM is average home monitoring BP is equal to or less than 135/85, not 140/90 as usual. Enough, I have told you. Trend over several days. Relation to symptoms and medications. Do not rely on a single you can go ahead. Limitation, it has got its own limitations also, disadvantages. Inaccurate results with poor technique, as I already told you, and not all BP monitors are validated. Incorrect cuff size may give misleading readings. Patient anxiety may lead to excessive checking. They'll be repeatedly checking every time, morning checkup, evening, all days. That should not be the way. And no nocturnal BP information. And is less reliable patients who have significant arrhythmias. One question was asked in the morning about from the patient it came. A cognitive impairment can really impair HBPM. Patients unable to perform the technique properly. So these are very important. HBPM is useful only when the device, number one, the technique, number two, the interpretation of appropriate. Then only it will be of immense use and very easy to ensure all these three facets. The clinical situations where HBPM can make a big difference. You have to think about it definitely in such situations. Number one, to diagnose white coat hypertension. Number two, identifying masked hypertension. Assessing the treatment efficacy and dose titration. As already told, managing high-risk individuals like diabetes, CKD, OSA, CVD, where precise control is critical to preventing damaged organs. Detecting resistant hypertension is also a very important thing. Evaluating morning and nocturnal hypertension, this can be done sometimes, which is very important. As our sir told, dementia is high risk for early morning rise of BP and all. And improving adherence to therapy. Here it can be real make a difference. Now, teaching the correct techniques of paramount importance. Now, I finish up with just two practical case studies. This is patient number one. It's a 50-year-old male patient, no diabetes, no CKD. Office BP is 152/94. You can see he's a very anxious patient, not seated properly, is peeping the BP apparatus. And when you advise him HBPM, it's only 118/77 over a period of 7 days. You interpret diagnosis of white coat hypertension. You should avoid unnecessary drug treatment when there's no severe risk. Continue lifestyle advice and periodic follow-up. So second case, a 50-year-old female on antihypertensive treatment, office BP is 130/82. You can see the lady looking at the staff so pleasingly as if it's her own daughter. And what happened? HBM average is 157/98. She has a lousy daughter-in-law who fights with her constantly. Son is away, living in some outstation. She takes a task of her mother-in-law. Poor relationship between mother and daughter-in-law. So it's mass hypertension, uncontrolled hypertension, review adherence, drug timing, need for treatment at insufficient severe risk. Consider HBPM if needed. So this is my take-home points. HBPM is a practical, evidence-based and patient-centered approach. It improves diagnosis and treatment monitoring. Clinical trials show that HBPM-guided care achieves 5 mm mercury better systolic blood pressure. You achieve 5 mm of systolic blood pressure less when you adapt to HBPM. It detects white coat hypertension, mass hypertension, resistant hypertension, and BP variability. Best results require validated devices and proper techniques. HBPM should be integrated into routine hypertension care. Even in village like Vadamara, I'm able to do it. About 10-15% of our patients are already on HBPM. And in the current scenario, you can well come to the conclusion that an automated digital BP instrument is as important to any household as a first aid kit with bandages, a thermometer, a pulse oximeter, a glucometer, and doctor's phone number. This is very important. I finish off with the one good kural from Thirukural from the Adhikaram Marundu, Utran Alavum, Pinialavum, Kalamum, Katran Kadisayal. மருத்துவ நூலை கற்பவன் நோயுற்றனுடைய வயது முதலியவற்றையும் நோயின் அளவையும் நோயுற்ற காலத்தையும் ஆராய்ந்து மருத்துவம் செய்ய வேண்டும். Should know the patient in and out. Should know his age, his BP at various times, and how long BP is lingering. Then only can arrive at the right diagnosis. And HBM is a good tool to measure all these things. Thank you so much for patient listening.
Thank you, sir. I think we will have the discussion at the end of.
The next topic is ambulatory blood pressure monitoring, and I invite Dr. P. Manokar to deliver this talk. Yeah. He's a leading interventional cardiologist.
At the outset, I thank Narsingan sir for giving me this opportunity. In fact, when I entered the hall, I was for a moment stunned whether this is the place I'm supposed to be coming, because there were so many people in, and usually cardiology conferences don't have such attendance. So I've been given a big topic, very short time, so I'll forgive me for the speed, because myself and my good friend Dr. Prabhakar feel ambulatory blood pressure can be a one-day symposium. Going on to ambulatory blood pressure, I think this one slide settles the argument. When we talk about office BP, we talk about home BP, and we talk about ambulatory blood. So everybody understands the gold standard remains ambulatory blood. Any drug trial, any doubt, the gold standard will always and always be ambulatory blood pressure. Sir nicely spoke about home BP, but I liked the last slide where he said, if further needed, ambulatory blood pressure. So he had already mentioned that fact, that the gold standard will always remain ambulatory. But since it's a public message, I would rather say home BP would come second, and the bronze medal goes to office blood pressure. In clinical practice, it is the reverse, that most of the treatment happens on office BP, rarely home BP, and very rarely ambulatory BP. But when you look at the guidelines, look at the data, the gold standard is always and always ambulatory blood pressure. The silver standard is home BP monitoring, and what we practice today, office-based treatment, is what I call as the bronze medal. So why this is so much obsession about ambulatory blood pressure? Why? We have been measuring blood pressure for so many years. Why this obsession with ambulatory? Is it like in cardiology, we always say, any new tool in the box, everybody wants to use the tool. Is it a new tool in the box? It's just a new gimmick or something that everybody is so excited, or there is a big financial reward behind it. It is not that. If you look at physiology, up to 30% of patients are misdiagnosed. The reason NHS decided to include ambulatory blood pressure is not for a medical reason, for a financial reason. Because the NHS believed by using ambulatory blood pressure, some 30% of people don't need treatment. That means they will save more money by not treating them, because in NHS everything is paid by the government. So the NHS took up ambulatory blood pressure simply because it reduced the cost of treatment. And more importantly, for people like us, I would rather give more importance to masked hypertension. The reason is the organ damage that happens in masked hypertension is far more devastating than the loss that we do by treating white coat hypertension. That means masked hypertension missed is more damage than white coat hypertension overtreated. So both are harmful, but overall picture, missing masked hypertension is far more harmful, and that is very important in treatment of patients. So this is very simple, the technique. In fact, sir elucidated so many steps of how to take home BP. In ambulatory BP, you don't have to do so much things. You just connect, it records everything. You can set whether it is every 15 minutes or 30 minutes. Generally, what we set is every 15 minutes in the day and 30 minutes at night. And important thing which it gives is what I call as the pressure load. That is how much load the heart or the body takes through the day. It's something like we calculate smoke years, pack years. Same way, it calculates how much blood pressure load the end organ suffers through the day. That means more the time, like in diabetes we call time in target range and all those things. Similarly, it calculates the blood pressure load, the load that the end organ suffers during the process. These are all always in all the things mentioned. The point I'm trying to say is, if you have an ambulatory blood pressure high, then I think there is no need of any debate or discussion on whether you need to be treated or not. The reason we can obviously have three phenotypes: a white coat hypertension where the office BP is elevated but the ABPM is normal, masked hypertension where it is reverse, and sustained where it is the same. This is the general preference. Why there is need is 1/3 of patients, 100 patients you are treating, 1/3 of patients, the treatment will change if you do an ambulatory blood pressure. And that is why it is so important. Yes, home BP will also change treatment, but the importance of ambulatory blood pressure is 1/3 of your clinical decisions will be changed by measuring ambulatory blood. And that I think is a big reason. And sir mentioned a very valid point. Unlike this glucose patches or doing sugars, which may be little painful, these things are painless. And that is a big incentive for us to look into it. There's another very crucial aspect of ambulatory blood pressure that is missed is people who don't dip. I want to say very vehemently, people who don't dip will die early. And that is probably the most harsh way I can put the message across. Everybody should dip their blood pressure at night at least by 10%. If you are a non-dipper, that means you are selecting yourself into a category of people who will have bad cardiovascular outcomes in the next 20 to 30 years. So every 10 millimeter increase in nighttime blood pressure is going to increase the risk of stroke by 40%. Look at night BP, not dripping by 10 millimeter is going to increase the risk of stroke by 40%. It could be fatal, non-fatal stroke, but cardiovascular things are important. That's why I always feel this is a far more important predictor of events. That is which is often missed when we do a home BP monitoring, because nobody is going to get up at 2 a.m. and check their blood pressure. So this one aspect I believe is a big reason why ambulatory blood pressure makes a huge impact. These are things which are discussed in every indications of ambulatory blood pressure, but my indications are different. My indication number one is a guy who refuses to take treatment, a guy who says, no, I am not hypertensive. For that guy, ambulatory blood pressure is the gold standard for me. And for a guy, especially IT sector guy who wants to take treatment, which I believe should not take treatment. That's the second indication for an ambulatory blood pressure. And the third indication, according to me, is obviously in this list, is resistant hypertension, where people who, despite treatment, you feel that they are not being treated. Just skip a few things. You look at the circadian pattern, look at the organ load in terms whether it is matching with the LV hypertrophy, look at other parameters and things. And obviously, like sir mentioned about cuff size and all those things should be taken care. Everybody, whenever we talk in any meeting, everybody will say there is no Indian data. That's the reason I thought I'll pull in some data. We have had ample data from India, 27,000 patients. So it's a really big study which really endorses the use of ambulatory blood pressures. Very clearly, the data is ambulatory BP is superior than this. And for all people in this audience who believe that blood pressure is a component of age, and I think this is the last slide, sorry. Let's skip this thing. This is, okay. Thank you. Thank you. Sorry for the delay.
Thank you, Dr. Manohar, for highlighting the importance of ambulatory blood pressure monitoring and where we should be using this.
So we go on to the next topic. The topic is masked hypertension. We would like to have Dr. R.P. Rajesh, most renowned physician, diabetologist, to throw some light on the topic.
So respected chairpersons, senior clinicians and my dear friends, a very good morning to all of you. At the outset, I want to profusely thank the organizers for giving this opportunity. And I'm going to talk about masked hypertension, and my job was made very easy by those excellent talks by the previous speakers. So the previous speakers enlightened us about how to do an out-of-office BP. But I'm going to discuss about why is it indicated? Why are we actually going to focus upon out of office BP? So, yes. So I'm just going to give you a very simple clinical scenario which we encounter in our routine practice. So here we have a patient, 47-year-old male, having diabetes for the past 7 years. And this patient is actually coming to us for multiple follow-ups. Several follow-ups he has come to us. And you can see his BMI is 32.14, smokes 6 to 8 cigarettes per day, and works in a production unit with rotating night shifts. And if you look into the clinic BP, it is 128 by 78 millimeter mercury. So if you go by the European Society of Cardiology guidelines, or if you go by the ACC AHA guidelines, you cannot diagnose, you cannot make a diagnosis of hypertension with this particular value. All of us know that. But having known all the data, my question to you is that, can we confidently rule out hypertension in this particular patient? Can we confidently rule out hypertension in this particular patient? See, if the scenario is different, suppose if the same patient is having a blood pressure of 150 by 90, then what we do? We don't go by one reading alone. We ask the patient to do 7 days, repeated BP monitorings at least 2 times a day, for a period of 7 days. What it means is that you cannot diagnose hypertension by one reading. At the same time, what we need to understand is that we cannot rule out hypertension by just one reading. So this is what we need to understand. So there is something, all of us know what is white coat hypertension. Professor Chandrasekhar sir is ready to give the next talk on white coat hypertension, but let me enlighten you about what is this particular entity, masked hypertension. So what is masked hypertension? Patient's office BP. Office BP is inside our clinic, not in patient's office. It is inside our office. So patient's office BP is less than 140 by 90, but out of the office BP, that is out of our clinic BP, when you do a home BP monitoring or when you do an ambulatory BP monitoring, then the BP is persistently elevated. It is in the hypertension range. So inside our clinic, it is normal, but outside our clinic, in his workplace, in his home, the BP is elevated. So this is very, very important. This is called masked hypertension. Previously, there were many terminologies to denote it. We call it reverse white coat hypertension, and so many names are there. I'm not going into that. So how do we diagnose masked hypertension in our clinic? So you can see the office BP. If you take any criteria, if you take the European Society of Cardiology criteria, if the office BP, that is inside our clinic, the BP is less than 140 by 90 millimeter mercury, or if you take the ACC AHA guidelines, you go by less than 130 by 80 millimeter mercury, whatever you take it. So in the clinic, inside our clinic, when we are recording the BP, the blood pressure is normal for this particular patient. But when we do an out of office BP, whether it is a home BP monitoring or an ambulatory BP monitoring, any one criteria should be there. If they do a home BP monitoring, the blood pressure, if it is more than 135 by 85, or if the patient is undergone an ambulatory BP monitoring, if the daytime BP is more than 135 by 85, or if the 24-hour BP is more than 130 by 80, or if the nighttime BP is more than 120 by 70, then this patient is having masked hypertension. This is what we need to understand. So in this way, if you look into it, a substantially good proportion of people who are sitting in front of us in our clinic having apparently normal BP may actually have hypertension. That is what we need to understand. And again, what is the prevalence? In the general population, no comorbid conditions, nothing at all. If they are coming and sitting in front of you for some other ailment, and if you are going to record a BP, understand that at least 10 to 30% of these people, even if the clinic BP is normal, they will be having masked hypertension. But what happens if they have a comorbidity? Somebody has diabetes, somebody has CKD, somebody is obese. So there, in high-risk individuals, you can see the prevalence of this masked hypertension is somewhere around 30 to 40%. And you have something called as the masked uncontrolled hypertension, MUCH, where there are people who are treated for hypertension. They present to us, they're all on treatment, and in our clinic, the BP will be normal, but actually their BP will not be under control. So that prevalence, if you take into consideration, it goes even up to 60%. So this is what we need to understand. And whom to suspect? See, this is very important. You need to have a high index of suspicion when you want to pick up these cases. So see, when a patient is having high normal BP, the clinic BP is somewhere around 100 and more than 130 and somewhere less than 90 diastolic, or if the patient is having a normal BP but having a target organ damage like an LVH or a CKD or a retinopathy or a microalbuminuria, and especially in these high risk patients. Who are these high risk patients? Patients having diabetes, CKD, obesity, OSA, smokers, high stress occupations, young hypertensives, that is treated people. I'm talking, this is about the much. But if they are doing shift work, these are the high risk people. You have to have a very high index of suspicion. Even if the clinic BP is normal, we have to always think about whether this patient is having masked hypertension or not. So, and why do we at all bother about it? Why? Because we should understand that masked hypertension is not benign. The incidence of complication is almost equal to a person who's having hypertension. So here, the risk of stroke, whether it is LVH or CKD or CAD or atrial fibrillation, all these risks are elevated. I'm not going into the details of all these things. And how do we unmask it? It is a masked hypertension. How are you going to unmask it? This is where out of your office BP is very, very important. That is why the previous two speakers told about home BP monitoring, about the ambulatory BP monitoring. If you are going to depend only on the clinic BP, it will just give you a snapshot. It is like paying for a movie. You want to go to a movie theater, you pay for the tickets, but you watch only the poster and come. You don't get any data about what is the movie at all. So you want to get the real movie, that is the real, what is really happening to the patient, you have to go for an out of office BP measurement. So the take home message is that very simple. Normal BP in our clinic does not mean that the patient's BP is normal. It doesn't mean that the patient is not having hypertension. Just like how you cannot rule in hypertension just with one reading, same way you cannot rule out hypertension with just one reading. So high normal BP, whenever a patient presents to us with a high normal BP, we always have an index of suspicion whether this patient is having masked hypertension or not. And especially people with diabetes, not only diabetes, obesity, people who are doing night shift, people who are smoking, all these people always have a high index of suspicion. And again, target organ damage with the normal clinic BP, always it should trigger your mind whether am I dealing with any masked hypertension or not. So with this, I'll end my talk. Over to the chairpersons. Thank you.
Thank you, sir. That was a wonderful talk. Sir has elaborated whom are the people whom we have to concentrate. And particularly he has told that even when a person is being treated, they can have a 50 to 60% chance of an uncontrolled hypertension. So even treated people, when we look for masked hypertension, the incidence can be high in them. And thank you, sir.
I think we will move on to the next session, white coat hypertension. It will be done by Dr. S. Chandrasekhar, and you know that he is the head of the Department of Medicine, Tamilnadu Medical College, and also he is the secretary of the Tamilnadu State Chapter, Indian Society of Hypertension, and he is also secretary of many academic associations. I think over to Dr. Chandra.
Thank you, sir. Thank you. Good morning, ladies and gentlemen. Thank you, Chairperson, for your kind words. Today's talk is, I think, my previous speakers have set the platform for me to deliver the talk on white coat hypertension. So the conclusion which I would like to say is the white coat hypertension is not benign. It carries an intermediate risk. Please remember. So with this introduction, and this would be my concluding remarks also. So we know that there are different phenotypes which we see in our clinical practice. Of course, let us briefly see what is this white coat hypertension. Many times we may get confused with what is white coat hypertension and what is white coat effect. So I just brief you on what is this white coat hypertension is. So when the office blood pressure is more than 140/90 and on 2 occasions, and the daytime ambulatory blood pressure is less than 135/85, or home blood pressure is less than 135/85. So when your home blood pressure is normal and office blood pressure is high, when it is more than 140/90, you call it as, on 2 occasions, you call it as white coat hypertension. But the hitch is, the patient is untreated patient. So that is the most important thing. And it's not a simple high BP in our clinic. It also carries, it's a different phenotype and carries some risk of developing future complication as well as the development of comorbidities as well. Let us see like what is this white coat effect is. So I told you that like it's more than 140/90 in untreated patients. A similar kind of thing when a patient is on treatment and developing a high blood pressure during the office visit, but normal during the home visit. So that is white coat effect, and you can divide also. Like so, there are various classifications: normal, moderate, and marked white coat effect. There is a very simple formula. The clinic BP, the minus the ambulatory daytime mean blood pressure is gives the white coat effect. So this also it's kind of a thing wherein like we step in on the changing the lifestyle intervention and therapy, but it's not a diagnosis. Only the white coat hypertension is a diagnosis. So who will get the white coat hypertension? So age is an important risk factor. Somebody is having more than 50 years, having more sympathetic tone or arterial stiffness, they are at risk of developing more white coat hypertension. And women are particularly more important. This is a very common scenario nowadays. The present day youngsters, they do have a lot of anxiety. The anxiety tried, phobia, panic disorder, or any kind of previous past bad experience, or first time visit to a doctor, or first time visit to a tertiary care center, or rushed visit. So this is very common, like where we can see this white coat hypertension. Of course, what is the importance? So the literature says that for every year, like 10 to 15% can convert to become a sustained hypertension. So not only that, the overall risk for the 10 years is 42% can develop to a state of sustained hypertension. Please remember that. Of course, the pathophysiology part of it, there are many things where they are playing an important role. The condition reflects where the amygdala secretes more, sets the more sympathetic tone, and resulting in more heart rate, cardiac output, and peripheral vascular resistance. But one thing which we need to understand is with repeated blood pressure, the WH, the white coat hypertension, it comes down. So with the repeated things. So usually we make 2 or 3 readings so that the blood pressure from 162, it comes down to 140 or 130, if you allow him to settle. So that is another important clinical clue. Of course, they have an increased catecholamine surge with the increase in the heart rate. That is itself again another clue whether the patient is having a white coat hypertension or not. Various hormones also, they play an important role, including the increased RAS expression. Of course, most of them are obese and overweight, and insulin resistant and metabolic syndrome also play a significant role in the development of white coat hypertension. So what are all the investigations which we can do? So many times their investigations would be entirely normal. We usually go with the routine investigation, ECG, echocardiogram, lipid profile, and HbA1c and USCR, so the complete blood count. So these are all some of the basic investigations which we do. Of course, it is individualized. So in the ECG, we should look for the LVH, and of course, the LV strain pattern. So that also got a increased CV risk. Please remember, not only LVH, but increased LV strain pattern where the patient exhibits asymmetric T-wave inversion in the lateral leads. Similarly, echocardiogram, we should look for the LVH, of course, but in addition to that, global longitudinal strain is another thing where it signifies the subclinical systolic dysfunction even with a normal EF. So this also carries a increased risk of future cardiovascular complications. Of course, the carotid intima media thickness, angle brachial index, or other things which we can do on our patient. But remember that we should do a basic RFT and USCR. Any patient who exhibits increase in the albumin, so from normoalbuminuria to micro or macroalbuminuria, definitely carries more complications and more development of the future sustained hypertension. These patients, any patients with any other complication in the investigation which you do, or any patient who has developed a target organ damage, we need to treat. Please remember. Of course, before you embark on any drug therapy, rule out the secondary hypertension. The treatment part of it, like the lifestyle intervention, is the key to manage patients with white coat hypertension, starting with your sodium restriction, DASH diet, aerobic exercise. In fact, a patient who does regular walking, it also brings down the sympathetic tone. It also helps in white coat effect, so which I already alluded to. And of course, we need to do a risk stratification, whether the patient is at low risk or high risk, and depends on that, like if we need to treat. When these patients require a treatment, when the patient is having a LVH, microalbuminuria, increased intimal carotid media thickness, or having some high risk for developing myocardial infarction or stroke, or if the patient is or overshooting sometimes, like then also we should treat. And any patient with blood pressure of 180 by 110, we should treat as a sustained hypertension. So that is the most important thing. But of course, if the patient do not have all these things, you take a individualized treatment, take a shared decision making with the patient, and prefer a long acting drug like a ACE inhibitor or ARBs are the drugs of choice. Of course, the calcium channel blocker. Of course, beta blockers are not the first line. It could be an add-on drug. Diuretics also can play an important role. This is my final slide. Correct early. So that is the most important thing. And ABPM is not optional. As Dr. Manohar sir has said, it's compulsory that like if they should do a ABPM. And it carries an intermediate risk. Of course, lifestyle interventions are the main key. And drug therapy, preferably choose a long-acting drug. And of course, in the Indian context, we need to standardize this ABPM that can enable us to detect this white coat hypertension at the earliest. Thank you for being a wonderful audience. Thank you.
Thank you, Dr. Chandru. I think I request all the speakers to come on the stage. We'll have a very short discussion. Important, relevant questions which you want to ask, please. Because already we are late. Audience, I request the audience to have your own interaction. Yes, sir. Mike.
Because you rightly mentioned, excellent speech by all of you. Wonderful occasion. Many new points I learned. You rightly mentioned about so-called Indian contest, right? Always Indian contest. We are a country which is popularizing yoga and meditation. International Yoga Day is coming. Meditation is coming. I think so-called non-lifestyle, the non-interventionals, I think that part of it, I think any validated informations should be pulled down. People like Narsingan should take it to the International League Forum, where the benefits of yoga, a nation internationally, globally is acknowledged. I think that part of it, somebody to take it up. Second thing about the terminology about white coat hypertension. Many of us have given up the habit of wearing white coats, including government hospital. Should we find a substitute for that? Just make it as a coat hypertension. No, even the minister says,
All the terminology in 1983, Dr. Thomas Pickering is the one who coined this terminology, because they used to come to the medical fraternity wearing white coat, doctors and nurses. So that's how in 1983 it was coined.
Now even the
I think time to revise it.
Yeah, the Honorable Chief Minister has started wearing coats. I think we should make it as a coat hypertension.
I think Narsingan will do in the next World Hypertension League. Make
So we can take some comments also from the senior faculties.
Good morning, respected doctors, senior doctors.
Mike.
Do you have validated centers for monitoring, BP monitor? How many centers we have now in Tamilnadu? Validated centers.
For ambulatory blood pressure monitor.
How do you validate the devices?
Devices.
No, actually the BP monitor validation and all those things are now being taken up as a big task by throughout India. Probably we'll get some data with respect to the upgradation of all these instruments, how it is going to be beneficial for the patient for the correct method of diagnosing hypertension. It will take some more time for us to get data. Okay.
So I think there is a thing called the TNMSC. So in Egmore, we do have a thing where we have the biomedical engineering, group of biomedical engineers are there. So they may try to help you out in case if you want to validate the thing. And IPCA people also are doing a great job in helping us.
In fact, IPCA had taken up this job of conducting trials also by using this, and then they will come out with the good data probably by the end of this year.
In the most of the
people also.
In the most of the institution, they got that, but only the private general practitioners.
Biomedical engineer will sort out the issues. So most of the corporates they have, and if you want a freelance one, you can approach TNMSC in Egmore, opposite to Ashoka Hotel.
So NHS, they did a validation study. They took about 540 different instruments by different companies. And they found only 32 met the criteria. The rest were all inaccurate. So we are still having a problem with the device.
Yeah, if you permit me, can I just ask
Yes,
Manohar?
yes, sir.
Dr. Manohar, how often you are using ambulatory blood pressure monitoring to titrate the dosage of the drugs what you prescribed?
Usually whenever we use ambulatory blood pressure, the primary indication would be to diagnose or refute treatment. But very often when we come across patients who are not resistant hypertension, we have given all the drugs in say half the doses of full. I think in those patients, I would rather do ambulatory blood pressure once in 6 weeks, try to find out whether they are responding to treatment. So once people do ambulatory blood pressure once, they understand the value of it very faster. And then those patients can be motivated to do repeated tests also. So some of the patients I have done every 3 months, especially patients with borderline CKD and all, every 3 months also frequency we are able to do blood pressure for those patients.
What about your comment on cuffless BP apparatus? Cuffless.
I feel cuffless BP apparatus has still not reached that stage of validation. For example, all this newer phone-based and all these wearables are coming, but I still feel they need more validation. Maybe next 5 years, yes, but definitely not today.
So regarding the Professor Soundarajan sir comment, Professor Soundarajan sir, regarding your comment on yoga and hypertension, and I'm the chairman for the Yoga Therapy for the World Federation. Sir, please. And I am collecting a data on these level hypertension patients with meditation. So I train all my patients to practice 3 minutes of meditation whenever they feel stressed, because most of us are killed by our autonomic nervous system. So when the ANS fluctuates up and down, the BP shoots up and rhythm get disturbed, and this emotion has a lot of effect on controlling the emotional component of level hypertension. So it's very positive. I want to collect a large amount of powerful data before publishing. And so whenever you see a level hypertension, apart from treating medication, try also a short-term meditation, even in the office setup. Because we have something called chair yoga. They can practice in the chair itself. It has a significant benefit from whatever data I have collected.
I think yoga and meditation had been incorporated as a method of bringing down the blood pressure, number one, can prevent the onset of hypertension also, as per the recommendation given by International Society of Hypertension in 2020 itself, when I was the referee for that. So I knew about the data, what these people had published. So they recommended yoga and meditation during that time, acknowledged by World Hypertension League also as a method of probably controlling the blood pressure.
So I think the mindfulness has come a long way, and now it has been recommended by almost all the guidelines also. Even when you talk about American guidelines also, the Indian guidelines, all these things they give a lot of importance to the mindfulness.
I think Shanmugam, with your permission, can we go to the next session, please?
Yes.
Yeah,
Yes,
we'll
sir.
honor the speakers now and the chairpersons. Can I get the...
No, I think there are some questions written. I think you can communicate with the speakers in the tea time or the lunch time. Yes.
No tea time, straight away lunch time.
Thank you.
We're now having the team IPCA doing a big round of applause, please. to all the wonderful speakers and moderators of this first session. Please put your hands together. A big round of applause to all the doctors. The moderators of this session, Dr. K. Shanmugam, Dr. S. Geeta, Dr. Vamsi Mohan on the dais. And also we would like to thank the speakers of this session, Dr. J.C. Sekar, Dr. P. Manogar, Dr. S. Chandrasekhar, and Dr. R.P. Rajesh. Once again, ladies and gentlemen, a big round of applause to all the gentlemen and the lovely lady on the dais today. Thank you, doctors. That's Dr. Geeta for us. Thank you so much. And one of our speakers today in the first session, we have with us Dr. R.P. Rajesh. I would like to call upon stage Mr. Ramanujam. Dr. Ramanujam is joining us. Oru peri kaithatal tharalama, please. A big round of applause. Thank you so much for being here with us today, sir. And he'll be doing the honors and felicitating Dr. Shanmugam. Once again, ladies and gentlemen, a big round of applause, please. Up next, can we have Mr. Thank you so much, sir. We have Dr. J.C. Sekar. A big round of applause once again for Doctor. He spoke on home blood pressure monitoring. I'm sure everyone found it very useful.
Some of them
Already received it. Oh, lovely. Thank you, Doctor. This is for Mr. Chandrasekhar.
I think everybody will
Thank you, Dr. S. Chandrasekhar. Thank you. All right. Thank you so much. Thank you so much, doctors. I request you all to be seated. Moving on to the next session. All right, for this topic, I would like to call upon the stage Dr. V.R. Mohan Rao and Dr. S.N. Narasimhan, who will be the moderators of this session. And the speaker for this session is going to be Dr. Y. Vijay Chandra Reddy, and the topic is acute coronary syndrome in setting of accelerated hypertension. So I'd like to call upon stage the speaker and the moderators with a big round of applause, please. Moderators Dr. S.N. Narasimhan and Dr. V.R. Mohan Rao, please come up on stage. All right, joining on stage would be Dr. V.R. Mohan Rao and Dr. R. Kannan as well. And can we have the speaker on stage, please? Dr. Y. Vijay Chandra Reddy.
Good morning, everyone. Thank you, sir. At the outset, we extend our gratitude to the organizers, especially Professor Narasimhan sir, for giving this unique opportunity. So next we'll move on to the very interesting topic. You all know the hypertension actually involves many organs, damages not only your heart, brain, even retinal vessels and kidneys. So today we are going to discuss about the accelerated hypertension in association with the ACS, acute coronary syndrome. So accelerated hypertension is an overlap of hypertensive emergencies, because the incidence of acute coronary syndrome in accelerated hypertension is estimated to be around 18%. by causing the change in the oxygen myocardial oxygen supply and also the myocardial ischemia. I think very interesting topic, very renowned speaker. I think Reddy is well known in the field of cardiology for several years. I think without wasting much of time, I think he needs no introduction. So over to you, Dr. Reddy, for your unique presentation.
Thank you very much, sir. Thank you, Narsingan sir. So we all know that the commonest killer disease continues to be atherosclerotic cardiovascular disease, globally and locally as well. And if you have to identify the single most weighted risk factor that contributes to this amount of magnitude of morbidity and mortality, it is hypertension. Such a small numbers, easily measurable, and once upon a time, we used to think it is nothing but a simple either increased cardiac output or peripheral resistance, no more. We now very well know that this small, easily detectable number is a result of a complex pathophysiological mechanism of an interplay of genetic factors, lifestyle factors, and environmental factors, leading to a dysregulation of the multiple neurohormonal systems, endocrine, paracrine systems, resulting in multiple metabolic problems. That is the reason we get the clustering of diabetes, dyslipidemia, etc., and finally leading to structural as well as functional alterations in the target organs. Such a complex disease, and what these small, easily detectable numbers convey is a big issue. We know about the staging. We want to get it down to less than 130 by 80. We have a lot of strategies, therapeutic lifestyle changes. Almost now 12 types of drugs are available. The last one being the renal denervation therapy as well, which is also available in our country to treat refractory hypertensions. What I will focus on today is see how challenging this syndrome of the number of the blood pressure is high, and what are the challenges in diagnosing and treating this important conundrum. It could be a simple pain due to a herpes zoster on the skin causing a reactive hypertension, or it could be a catastrophe in waiting due to something like an aortic dissection or an acute ST elevation MI. And it also brings up the challenge of hypertension with chest pain with so much of multiple systems involved. As if you understand the pathophysiology of hypertension, it is not a single target organ disease at all. So many things can go wrong in these patients. At one side, the heart muscle might be damaged. At another side, the blood supply, the electrical system might be in trouble. The associated organs, the vessels or the kidneys or the kidney blood vessels, anything could be going wrong. The CVA in these patients presenting with accelerated hypertension and chest pain. What I like to bring forth is to showcase a few clinical real-life scenarios so that one's clinical horizon will be expanded into encompassed scenarios. This is a 75-year-old hypertensive physician, chest discomfort for 3 hours, BP quite high, 200 by 118, pulmonary edema, anterior ST elevation MI. Not much of a diagnostic challenge, but very important clinical scenario because these are the patients we might occipital headache at presentation. That brings up the challenge of you have to do with the primary angioplasty and stenting. Probably the entire procedure might take about 8 to 10 minutes with an excellent result. And this is how you save these patients who come with ST elevation MI. Sometimes there might be slightly different scenarios. Elderly diabetic hypertensive dyslipidemic lady, chest pain for a few hours, breathlessness, BP is high, 180 by 80, again pulmonary edema, but then creatinine. Nowadays we know that when the patient comes, we do the point of care, one blood test, the VBG, and we know the creatinine is 1.8. That brings up a lot of issues of challenge as well. Global ST depression and HS troponin positive. So this could be a simple ACS, which could be a ST elevation, non-ST elevation MI like thing, or it could be a left main equivalent, or it could be something else. Like in this patient who was thought to be having a gross global non-ST elevation MI, loaded with clopidogrel, aspirin, statin outside, shifted over to here. Because of the creatinine of 1.8, we had to rule out other causes of nephropathy like an obstructive of nephropathy as well. Then we do the renal artery stenosis. We had to keep in mind, we had to think of drugs which we should not use, and the contrast we are going to use in angiogram is going to be a renal friendly angiogram dye. So this patient undergoes an angio with 10 ml of non-ionic dye only, iodixonol, and what we find surprisingly is the coronaries are near normal. So TROP positive, global ST changes, pulmonary edema, high blood pressure, chest pain, multiple risk factors, but this is also nowadays not uncommon. This is called MINOCA, MI with no obstructive coronary disease. Unless we had done the angiogram and then taken it forward, we would have been unnecessarily putting her in so many medication and then totally going out of the way in managing her appropriately. The third scenario I would like to show is a multiple, again, a similar type of patient like in the last, but a gentleman who has a history of paroxysmal AF, already had a stroke, already on apixaban, the blood thinner, and aspirin, 2 blood thinners, one for preventing stroke, one aspirin, now coming with chest pain and headache. It's a double challenge. You have got a headache in a patient getting 2 blood thinners, and he has also got now a chest discomfort, again high blood pressure, pulmonary edema, AF now, ECG, no STG changes. But the echo is showing LAD territory hypokinesia. This is again not uncommon. UCG can miss things, but echo can pick up. HS troponin positive, again the same issue. Your headache is there, 2 blood thinners, a CT scan, emergency, no bleeding. Now we can go ahead and take up to the lab, plain CT, normal, cath lab, emergency, and again we find the same problem. Extensive, the disease, the ostial LAD and the left main. If you go only by ECG and not do the echo there, then you will end up in trouble. Of course, this patient, you cannot do great things. You can't do a surgery immediately. Left main, a simple stenting is done. You can't use much of great blood thinners. So we do an imaging guided angioplasty. Perfect result, only 2 blood thinners and discharged. Another trouble we see in chest pain patients with hypertension is the problem of generalized atherosclerosis. As I said, hypertension is not a small disease, a numbers game. It can cause generalized atherosclerosis. Coronary disease could be one presentation. See, this gentleman has cerebrovascular disease, multiple strokes before, peripheral arterial disease with bilateral common iliac occlusions, renal artery disease with bilateral renal artery stenosis documented before, and a Doppler with a creatinine of 1.6. Angiography, coronary artery disease, 3-vessel disease, advised bypass, but very high risk because of multiple, tried to be on medical for a long time, but now coming with accelerated hypertension, 226-118, gross pulmonary edema, chest discomfort as well. How to treat these patients? There are multiple challenges, but here in this admission, fortunately, there are no new ECG or echo changes, and the biomarkers are negative. So we have to decide what is the current problem due to. So multiple atherosclerosis is there, very high blood pressure. In this patient, now we assess that the current presentation is due to renal artery stenosis, refractory hypertension. The other term we used to use for this scenario is called as cardiac disturbance syndrome, bilateral renal artery stenosis. So we'll do the bilateral renal artery stenting first, then think of a surgery for the CABG and the vascular surgery later on as per symptoms. So this is how we go ahead with the renal protective dye. If you can see the left kidney, so critical, left renal artery stenosis, direct stenting. Again, renal artery stenting, nowadays we are doing from the left radial artery. The procedure takes about 3 minutes for each kidney. And then the same thing on the right side, you can do this procedure with as little as 15 ml of dye. Another scenario is this 36-year-old, not uncommon nowadays, obese, hypertensive, high BP, not well controlled, ignoring the things. He goes for a gym and then weightlifting, suddenly has a chest discomfort, transient unconsciousness, again recovers. When they come to the hospital, the BP was 190/100, pulmonary edema, anterior, NSTEMI, LAD territory hypokinesia, TROP positive. This is a scenario we should always keep in mind. Youngsters doing these heavy weights, this person most likely could be having a spontaneous coronary artery dissection. An angio was done in the local hospital. They found this CAD. Spontaneous dissection is a real interventionalist challenge because while passing the guide wire, if the wire goes into the false lumen, the patient can drop dead on the table itself. So he was referred off to us. If you can see here, the LAD, the starting point, the flow is good, but there is a long linear white flap in the middle of the LAD. This is a dissected artery. We don't know where is the true lumen, but we have techniques now to cross into the true lumen and then tackle this patient easily. He also is a obese patient, sleep apnea analysis done, AHI was 35, ODI 30, he was appropriately treated for that as well. We should also keep in mind some of these patients, when we treat the ACS, we have to follow up for the ruling out the secondary causes, aggressively see whether the 24-hour BP control is achieved, encourage home BP monitoring wherever needed, ABPM as well. We also should, I'll take this opportunity to show that sometimes these patients, where they're highly refractory, like in this gentleman, 7 drugs, not controlled BP, very good compliance, pulmonary edema, recurrent admissions. What do? EF is 40, coronaries are normal. So these are refractory resistant hypertensions. Once upon a time, we used to say we cannot do anything more. Now we have a renal denervation therapy. Once you rule out all the secondary causes, we can take up for this therapy, which is again a small catheter procedure like an angiogram we had to do from the groin only. Radial technology is not available. It's a class 2B indication. If you have used 3 drugs or 4 drugs and are not able to control the blood pressure and you have ruled out the secondary causes, you can put in a catheter into the kidney arteries and try to use a radio frequency ablation. It just is a very simple procedure, cost effective, and the risks are extremely low. Here at 1 year, BP was controlled on this patient for 4 drugs. Sometimes can be real googlies in hypertensive patients who come with atypical symptoms like this gentleman. Absolutely normal, only problem is headache. He was treated by the physician, headache, but ST changes are there. All causes of headache ruled out. The CT brain was normal, there was only an ST elevation MI on the ECG. These are the rare causes of cephalalgia as a sole presentation of an MI. We take him up to the lab, and then one stent and is taken care. One should not underestimate the possibility of an acute coronary aneurysm or a thoracic aortic dissections, because if you miss this in a patient with chest pain and high blood pressure, it can be really catastrophic because you are hunting up the wrong tree. And the most sinister scenario, I always keep telling my associates, is if someone comes with severe central chest pain, ST elevation MI, especially in the inferior wall, always make sure it is not alone due to the coronary, but also an aortic dissection, which has avulsed the coronary. So if you miss treat only one, you'll be landing up in trouble. So the take-home message, chest pain, accelerated hypertension is a real big challenge. It could be a small disease. It could be a very, very catastrophic problem in waiting. Varied pathophysiologists, think gross, think globally, think wide. Several challenges for treatment as well. Cath lab is a very important thing where treatments revolve around that area. Post-acute management, of course, you have to work up for secondary hypertension, including sleep apnea, and treat aggressively. Aortic syndromes, always keep in mind. And newer therapies like renal denervation therapy have a great promise, and we can use that in a lot of our patients. Thank you.
Thank you, sir, for the nice case presentation, sir. Thank you once again. Audience can ask 1 or 2 questions because we are running short of time.
Sir, in the setting of ACS alongside the accelerated hypertension, so how do we balance like the target goal, or what do we avoid in the initial first hour without compromising the coronary perfusion alongside the accelerated hypertension in a setting of ACS?
See, in ACS, BP control is not that much of an issue because many a time it could be a reactive hypertension. The moment you sedate them, the pressures might come down to normal. So we are not aggressive in treating that number. The only time when you do that is if you are going to thrombolize. And if you, with sedation and relaxation, also the pressures continue to be high. To reduce the chance of IC bleed with thrombolysis, you might use an NTG infusion. Again, we don't rely on oral drugs because you need something to put it off. Off effect is very important. The pressures might drastically come down. Use NTG infusion and bring it down a little bit. Don't be aggressive in dropping the pressures in an acute scenario.
Actually, the mean arterial pressure should be reduced by 25% within that first and second hour. And yes, what is your experience with nitroglycerin? Are you successful with infusion, sublingual or patch?
The one caution is never use a sublingual nifedipine to reduce blood pressure. It can induce an MI or a stroke. And NTG infusion is very useful because you can titrate it, up titrate, down titrate in necessity. Many a time we do angiograms in acute ST elevation when the pressures are 190 systolic. You take them to the lab and give one sedation, the pressures come down to 120. A lot of it is sympathetic related, probably helping the scenario. Don't aggressively treat that unless you are only thrombolizing and keeping this in mind.
Excellent talk. As a nephrologist, somebody refers me
fitness for contrast study. I never say no. I cannot say kidney losing the heart. So I always tell my registrars, cardiologists ask for fitness. Please give fitness, hydrate them. Whatever risk comes, we will dialyze them. So never hold nephrology fitness for a contrast. Second,
Yes.
about the denervation, I have no experience. I think the excellent reports probably are there in the literature. In your experience, there is a chance of regeneration of because the denervation cannot be complete. You cannot go near the hilum, you cannot go intra hilar and all that. So how successful your denervation experience has been?
The initial catheter was not a great therapy, no success, because we were initially only doing the RDN in the main renal artery. Now, after the anatomical studies have shown that the sympathetic nerves converge on towards the hilum. Unless you do the main branches of the renal arteries, tackling the main renal arteries of no use. So now the entire technology is a spiral catheter where you go and do the renal derivation for all the branches and then come back to the main renal artery. You don't enter inside the parenchyma. Outside the parenchyma, all the branches have to be dealt with. And this denervation is based on RDN, which is axonal damage to the sympathetic nerve. So there is absolutely no question of regeneration. So it is on effect. Once it is done, the effect is going to be long term. No case reports of any severe hypotension have been documented, but this effect is going to be sustained forever. It is an axonal. There is no question of regeneration.
Sir,
See a patient above 40 ml of EGFR, submit him for RDN. That's all.
My philosophy is very clear. Kidney is a wonderful organ. 2 kidneys are there. 1/3 of kidney is enough to go keep going. But that's not the case with heart. So I always give top priority for the heart. So whatever my patient's outcome after cardiac pressure, my dialysis machine is there to take care, right? Our team is there to take care. So I don't hold any patient for any cardiac patient on renal contraindication. Right? That's the way I look at it.
Last question, sir. One more. Yes, sir. Sir, last question. Sir wants to ask.
Excellent presentation, sir. Thank you very much. Just one problem case, intracerebral hemorrhage with anterior myocardial infarction.
Yes, there the priority shifts to intracerebral hemorrhage. Many a time ICH patients can develop an MI also. The entire focus will be on managing the intracerebral hemorrhage. The MI patient, we only have to deal with non-blood thinner remaining strategies we use. So thrombolysis you can't give, angioplasties you can't do, blood thinners you can't give, but all other therapies we can institute, the primary focus being on intracranial hemorrhage.
Sir, before we conclude, I'll ask a very basic question, sir, because it is asked by many of the patients. On the behalf of patients, I'll ask. Nowadays, we see a lot of patients with CT angiogram coming in, a lot of calcium scores, sir. Can you give some practical tips for our patients so that the calcium score can come down, so that the calcium deposition is very less, sir?
See, calcium score significance is, it is just like a tomb, micro tomb for the plaque. Once you see calcium score, you know that atherosclerosis has started. The severity of atherosclerosis on a global burden of atherosclerosis in the coronary arteries and the calcium score are parallel, but presence of a calcium score of 500 or 800 does not mean there is severe CAD. So a CT angiogram or a routine angiogram has to be done. 3 points. One, if the calcium score is above 400, CT angiogram loses its value. We can't see through well, so we have to do catheter angiogram. The presence of a calcium does not mean therapy has to be modified. In fact, if you know statins can increase the coronary calcium, exercise of a vigorous nature can increase calcium, aging will increase calcium. So the aim is not to reduce the calcium. The aim is to make sure that atherosclerosis is tackled properly, aggressive use of all the preventive strategies, diet, activity, habits, modification of weight, as well as statins and blood thinners is important. Calcium score is not a target of therapy. And calcium score is of no value once the diagnosis is already there of a CAD or a CVD. It is only in those patients where a primary prophylaxis is being thought of. Once a patient of CAD, calcium score is immaterial. For us as a cardiologist who go inside and do angioplasties, calcium can be a trouble. We have to use special equipment to tackle it.
So thank you for the eye-opening message, Dr. Reddy.
Thank you.
So we'll wind up this session by telling thanks to the organizers.
A big round of applause to Dr. Y. Vijay Chandra Reddy on this wonderful session today. Wonderfully put presentation, sir. Thank you so much. And thank you so much for patiently answering to all their questions. ஒரு பெரிய கைத்தட்டல் தரலாமா? நல்ல இன்னும் கொஞ்சம் louder-ஆ please. Yes. Thank you so much. And also thanks to our moderators of this session, Dr. V.R. Mohan Rao and Dr. R. Kannan. A big round of applause to the moderators of this wonderful session today. And it's time to felicitate them as well. Ladies and gentlemen, an energetic, nalla energy oda, nalla louda. Yes, please, thank you. I understand it's almost lunchtime, but yes, we have a lot of more eye-opening sessions to look forward to, so please hold on for a while. Thank you, doctor. Thanks a lot.
The sessions will continue, but you will get an opportunity to take the soup as well as vada, which will be served to you now. Thank you.
Okay, that's bring up a few smiles here. Thank you so much. Thanks a lot, doctor. Moving on, we'll have the next session now. And the speaker of this session would be Dr. V. Mahadevan. And the moderators of the session would be Dr. A. Aravind, Dr. K. R. Sivanesan, Dr. K. Dhananjayan, Dr. Ranjit Pradap. Can we have all the moderators, all 4 moderators on stage, please? And also the main speaker of this session, Dr. V. Mahadevan, who will speak on isolated systolic hypertension. Over to you, sir.
So good afternoon all. We can start the session 3. We have 4 topics: isolated systolic hypertension, diastolic hypertension, as well as hypertension in the young and hypertension in women.
Patients more than 65, even more than 80, you can target of BP less than 140 if they are able to tolerate it very well. So what are the preferred medications you'll use? So many of the times we don't prefer thiazide diuretics in a humid atmosphere like India where we are prone to electrolytes, but data are very strong to support the thiazide group of diuretics stands first as the first choice of treating isolated hypertensions, and many things has shown drastic reduction in stroke. So you want to treat isolated hypertension mainly because you want to reduce the central aortic pressure, which is a surrogate marker for developing a stroke in near futures. So thiazide diuretics, especially clothiazide, goes over than hydrochlorothiazide in terms of reduction of the central aortic pressure that translates benefit in terms of reduction of BP. Next in line, you can use calcium channel blockers, and ARB does not have any benefit in isolated. But they say isolated hypertension with the CKD, isolated with diabetes, there is a role of ARB or ACE inhibitors based upon this renal status. And combination therapy, ideally you have to go for thiazide group of diuretic with the calcium channel block as a first line. If not optimized, you can go for a second group of legs from ARB and on. So beta blocker is not being routinely used in elderly patients mainly because it has a pseudo effect. It may reduce the brachial artery pressure. Systolic BP, automatic diastolic BP also going down, and diastolic BP is a major component that is going to perfuse your coronary arteries. So dropping more than 110, or when you drop the diastolic BP, automatically you are going to damage the coronary perfusion, and also one size does not fit all. You don't go all by all the recommendations. This patient has to be aggressively treated, and HOPE trial clearly told aggressive BP control. Even the SPRINT trial showed benefit, and there is more risk factors. So SPRINT trial, they targeted BP of less than 130 in age about 85. The incidence of syncope is very high, incidence of CK high, kidney injury is very, very high, the SPRINT trial. But HOPE-3 trial, even modest reduction in the elderly patients is translated in terms of more benefit than going for aggressive BP control. And so individualized management of isolated hypertension is a cornerstone. So one does not fit for. If you want to go, start with diuretic hydrochlorothiazide or chlorothiazide, depending upon the patient's renal status and electrolytes, and then you can shift. So already you told only 8 slides.
Yes, that was a wonderful presentation. We'll have the question at the end of the session. Now I invite Dr. Namita Narayanan, Madam. For her lucid presentation on isolated diastolic hypertension. Madam needs no introduction. She is prominent in API activities and other association and a good speaker. Welcome, ma'am. Over to you.
Very good morning, rather good afternoon, one and all. At the outset, I thank Narsingan sir and the organizers for having given me this opportunity. So much has been spoken about hypertension from morning. So elevated blood pressure, we all know, is a well-established risk factor for cardiovascular disease. Systolic blood pressure has always been, excuse me. Yeah. So elevated systolic blood pressure has been consistently associated with adverse CVD outcomes, and the prognostic relevance of diastolic blood pressure has been deemed less clear, especially when we have only elevated diastolic blood pressure in isolation. So we have two definitions as always. The American College of Definition, where the systolic BP of less than or equal to 130 millimeter mercury and a diastolic of less than or equal to 80 millimeter mercury. So this definition substantially increases the prevalence of isolated diastolic hypertension, particularly among young adults, and a traditional ESC guidelines and the JNC definition of less than 140 millimeters of mercury and are you changing from there? So, okay, I think they're changing. Oh, I didn't do anything. Yeah, I'm only controlling, but that's running also. Yeah, I'll do it. Yeah, so IDH phenotype is more commonly seen in young adults with obesity or other metabolic derangements. So pathophysiology, I think Dr. Mahadevan has made it very easy for me. The hemodynamic mechanisms of IDH vary by age, and in younger individuals, IDH often reflects increased peripheral vascular resistance and heightened sympathetic activity, which may contribute to early vascular remodeling, whereas in older adults, it is the arterial stiffening which leads to elevated systolic blood pressure and widened pulse pressure, reducing the prognostic value of diastolic blood pressure. So this age-dependent difference in mechanism signal the need for an age-stratified reappraisal for the clinical implications of IDH. So when we see the trajectory of the diastolic blood pressure, it increases progressively from childhood to around the age of 50. So thereafter, we know that systolic blood pressure becomes more prominent. So complications related to hypertension and cardiovascular issues predominantly arise from elevated SBP. So that's what was alluded to in the earlier on talk. So demographics, it is more common in men than in women. And as I said, in younger individuals with central obesity and components of metabolic syndrome. So all this gives an associated potential link between lifestyle factors and emergence of diastolic blood pressure. So the difference in these two definitions, so whether they isolated diastolic blood pressure, does it have a cardiovascular risk or not? So this difference is just not about semantics. This is from Jacobson et al. Article. And the implications of these differences is in, if we use the AACC-AHA guidelines, we know that anybody with 130 can be classified as hypertensive. And systolic BP and diastolic BP are strongly correlated. So what happens is we have studies which have seen the cardiovascular risk, but all the studies we have inconsistent outcomes about IDH and cardiovascular outcomes. And analysis from the National Health and Nutritional Examination Survey, UK Biobank, and the atherosclerosis risk in communities reported no strong associations. And most of these studies lacked sufficient sample size, and more so they had a heterogeneous adult population, so we couldn't come to a conclusion. And again, we have one study with the International Database on Ambulatory Blood Pressure related to cardiovascular outcomes, which used 24 hours ambulatory blood pressure monitoring, which demonstrated that the cardiovascular risk associated with IDH was particularly pronounced among younger individuals. So continuing with that, about the calcium score risk, I think we had a discussion in the morning also, but we expect CVD, one would expect to find clear evidence of subclinical atherosclerosis and target organ damage, but that again was not seen in studies like multi-ethnic study of atherosclerosis. And yet another study, though it showed a coronary association with coronary plaques, it was not very significant. So all these studies till now were the European and American studies. What do the Asian studies tell us? Korean nationwide study, they showed The definition they took was the ACC-AHA guidelines, and that showed a increased risk of cardiovascular risk. And yet another Japanese study that also showed an increased risk of cardiovascular risk with both stage 1 and stage 2 IDH. And this is yet another study of prospective Kailwan study, which included 87,346 patients aged 18 to 98 years, that also confirmed the association between IDH and increased CVD events. So all these studies, important aspect was that inclusion of all participants untreated at baseline as the phenotypes for either be it IDH, isolated systolic hypertension, and SDH, they're all relevant to diagnostic or treatment initiating thresholds, but not to treatment goals or onto the treatment. So together, all these studies, what do they tell us? Employing rigorous BP measurement protocols strengthen the clinical evidence for IDH, particularly its diagnostic and prognostic relevance in younger adults. So to conclude, the definition, the traditional definition of IDH does appear to be associated with the risk of CVD, but not the ACC-AHA guidelines. And the individuals with stage 1 IDH by ACC-AHA criteria do not appear to be consistently at risk for CVD than when compared to persons with normotension. And IDH is associated with development of future elevations in systolic BP. So when we detect a person with IDH, we know that they're going into a systolic BP and then again to cardiac events. So persons with stage 1 IDH, lifestyle and dietary counseling should be given, and they also should have periodic intervals of BP monitoring checks, and we need to monitor that also. And when systolic BP increases or when the BP goes to stage 2 as per ACC-AHA, we put them on treatments. I'm not delving into the details of the treatments. This was one latest study of about 51 trials. It was a meta-analysis. The key question here was, is the efficacy of antihypertensive therapy in preventing major cardiovascular events comparable between patients with and without isolated diastolic hypertension. The finding here was, over a median follow-up of 4.2 years, a 5 millimeter reduction in systolic BP resulted in 10% relative risk reduction for MACE in both individuals with and without IDH, consistent across all diastolic BP categories and alternative diagnostic thresholds. So take home would be blood pressure lowering therapy should be offered to patients with IDH who are at risk for cardiovascular disease, irrespective of the specific systolic or diastolic thresholds. So thank you very much for this opportunity, and take home would be no one size fits all. Thank you.
Thank you, ma'am. Thank you for the excellent presentation, as usual, ma'am. Let us move to the next important topic, hypertension in the young. For this, I call Dr. K.P. Suresh Kumar sir to give on the dais to give the topic.
Good afternoon, everyone. My respects to the chairpersons, and thank you, Professor Narasimhan, for making me part of this excellent scientific program. Let us discuss the hypertension in young adults, where we stand and what is the way forward. We all agree that hypertension is the single and most common preventable cause of premature death globally. Coming to the Indian scenario, hypertension, there is an alarming rise in the prevalence of hypertension in the Indian subcontinent. There is an epidemic of hypertension in India, which has produced a major health problem. The prevalence of hypertension adults is about 25 to 29%. Every third or fourth adult in India is hypertensive. But look at young adults. Young adults means adults with the age less than 40, 18 to 40 years of age. It is 12%. We have got this excellent paper by Anita Saxena et al. From Old Medical Institute, New Delhi. They conducted an epidemiological study on high prevalence of hypertension, healthy school children even in rural areas. About more than 3,000 children were enrolled and between the age of 5 to 15 years. And the systolic hypertension, their prevalence was 13%, and diastolic hypertension 15%, average about 23%. That is, 2 out of 10 children in rural areas in that area was hypertensive. There's an alarmingly increasing rise of hypertension in young adults. After that, there are different studies. Most of the studies has brought around 15 to 18% or 15 to 18%. Secondly, hypertension is multi-dimensional. Most of the time we talk about office blood pressure or clinic blood pressure. Most of all the randomized control trials and epidemiological trials have included this, and Dr. Manohar in his study that this is the gold standard. However, there are different BP patterns, as we know: nocturnal blood pressure, dippers, non-dippers, and reverse dippers, early morning surge in blood pressure, BP variability, white coat hypertension, and mass hypertension. So when we evaluate a patient, we have to evaluate in total. The whole is that we have to evaluate it in fully, not the clinic blood pressure alone. Now, when we talk about hypertension in young adults, why it matters? Because first I said there's a rising prevalence. It's often it is undiagnosed or untreated. Since it happens at very early, they will have there's a cumulative exposure to high blood pressure leads to increased organ damage. It contributes a high lifetime risk of cardiovascular disease. Coming to the blood pressure in adolescents, that is young, that is children, childhood BP is a very strong predictor of future blood pressure in adulthood, metabolic syndrome, very high risk of cardiovascular disease, and they progress to persistent hypertension as the age advances. They have got very high risk of developing carotid intermediate thickness, LV mass, and all the markers of worse prognosis, and it lead on to accelerated vascular age. So we all know that hypertension is no longer a disease of old age. There's a rising prevalence of hypertension due to various risk factors like stress, diet, metabolic syndrome, lack of sleep, very important, obesity, lack of physical exercise, smoking, of course the pollution. All these contribute to increased release of stress hormones, oxidative stress, endothelial dysfunction, increased sympathetic and renin-angiotensin system activity. A very high incidence of obesity and metabolic syndrome contribute to increased incidence of hypertension. Urbanization and high salt intake contribute significantly. We all know this is the mechanism by which metabolic syndrome produces hypertension. 50% of the young adults with hypertension has metabolic syndrome. They have mainly hyperinsulinemia, insulin resistant. Majority of the people will have non-alcoholic steatohepatitis, visceral adiposity. All these produces vascular inflammation, increased circulatory cytokines, which produces smooth muscle hypertrophy, reduced nitric oxide bioavailability, endothelial dysfunction, and increased sympathetic and renin-angiotensin system activity. All these lead to multi-system cardiorenal metabolic disease. In young adults, definitely you must look for secondary hypertension, and these are the main causes of secondary hypertension. However, one must remember that even in young adults, essential hypertension or primary hypertension is much more common than secondary hypertension. But anybody who presents less than 40 years, please look for secondary cause of hypertension. When to suspect secondary hypertension in young adults? You see somebody less than 40 years, when to suspect, or what are the clinical markers? Onset before the age of 30 years, especially without family history, you should suspect secondary hypertension. People present with resistant hypertension, or people who present with episodic accelerated hypertension or hypertensive crisis, and somebody has disproportionate target organ damage. All these conditions, you should suspect secondary hypertension. Of course, other diseases or endocrinopathies which produce a secondary hypertension has to look into. Clinical evaluation, we know that we have to get a good history, measure the blood pressure properly, and look for other causes of secondary hypertension, look for target organ damage, look for endocrinopathies. Investigation, the general investigation which we do for all patients, again the renal profile, look for endocrine diseases, ECG, echo, and renal Doppler. Ambulatory BP monitoring. European Society of Cardiology says whenever you diagnose hypertension in anybody, you must do ambulatory blood pressure monitoring at least once. And you should repeat it every 3 to 5 years, because then only you will know the nocturnal pattern of hypertension, white coat hypertension, mass hypertension. All these have got an implication on when we talk about the cardiovascular risk. Non-dipping pattern and mass hypertension are very common in young adults. How will you manage? Okay, lifestyle modification, all of us are aware of that. Coming to pharmacotherapy, beta blockers have got a great role to play in young hypertensive, especially they have got increased sympathetic drive. Why in the day-to-day clinical practice, why hypertension in the young is missed? because one is a bias. We think that you are too old to develop hypertension, too young to develop hypertension. Somebody of 18 years or 20 years come to you. So we won't generally sometimes check the BP, or you do lifestyle modification, something we say. The second is white coat hypertension or presence of mass hypertension. Third is poor measurement technique, which we have already discussed. Inadequate trust. The moment he comes, we check the blood pressure. And when we say mild blood pressure, we dismiss it as a borderline hypertension. These patient needs very close follow-up, and they need a home blood pressure or ambulatory blood pressure measurements. So why it matters? Because a lifetime exposure to high blood pressure lead on to increased cardiorenal risk. And don't dismiss mild hypertension in young adults, especially when they have got a family history, metabolic syndrome, NASH, dyslipidemia, and insulin resistance. Hypertension in young patients is a special challenging situation because they are not convinced about the diagnosis, and they don't feel that they need the treatment, and they won't come for follow-up. And there is a cumulative effect of high BP lead to subclinical organ damage over a time. Early diagnosis and treatment is important. These are some of the recommendations. They say routine BP is needed in certain programs, especially young adults and adolescents going for driving license or going for some other programs. It's better to check the blood pressure. So take home message, hypertension in young adults is increasingly common, often undiagnosed and untreated. Hypertension in young adults is often overlooked until target organ damage appears. Early detection is the key. Always look for secondary causes. Lifestyle modification is foundational, and timely pharmacotherapy improves. There's a changing pattern of hypertension. Hypertension phenotype has shifted from old vascular stiffness driven disease to young metabolically driven inflammatory phenotype. Young adults are screened less often. They are not involved in most of the clinical trials compared with older adults. Less likely to take medicine, less likely to come follow-up, less likely to continue medicine. Just a borderline blood pressure is a first clinical visit, is a first reversible sign of lifelong cardiorenal disease and should never be missed. Improving the awareness, early detection, and prompt lifelong treatment is the need of the hour. Thank you very much.
Thank you, Suresh. Thank you, Suresh Kumar sir, for the lucid talk on young hypertensive. Next, I invite Dr. K. Kannan sir, Director of Cardiology, Rajiv Gandhi Hospital, to deliver the less talked about topic, hypertension in women. Slides movement ida. Just move on. Good afternoon, friends. We are going late, and I'll just hasten my topic because majority of the slides would be a repetition of what has been discussed from the morning. I thank for the opportunity of Narsing and the team, and it has been a pleasure to be in the Indian Society of Hypertension Tamilnadu chapter as an office bearer and they're doing good work. So regarding the first slide, we go here. As we see the three scenarios in which the BPs are monitored: the clinic, home, and ambulatory. And the home and ambulatory comes to the office, out of office, which has got a strong relationship to cardiovascular diseases. And but majority of the guidelines, treatment modules are all based on office BP, which may not really reflect what is happening in the ground situation. So among the diseases which are attributable to women as risk factors, the most important is hypertension. It overtakes all the other risk factors. And in women, there are four factors: social, metabolic, reproductive, and vascular. So this is a very unique group of risk factors which contributes to the treatment of hypertension as a separate group. So if you see among 1.27 billion people with hypertension, 626 million are living in hypertension worldwide. And moving to biological or behavioral, and in India, 220 million adults with hypertension are there, which shows us a huge disease burden. So the main important factors in hypertension in women is the non-traditional risk factors. They have more of non-traditional risk factors in women: central obesity, kidney disease. The variability is also more, especially in perimenopausal women, and also the non-dippers are also more. And hypertension-mediated organ damage is more in the form of heart failure, preserved ejection fraction, diastolic dysfunction, diabetes, and CKD. The important is that hypertension increases and control declines with aging in women. and the risk of cardiovascular disease begins 10 millimeter lower in brachial blood pressure in women compared to men. So this is a very distinct risk factor profile. And for every 10 millimeter increase in systolic BP, the cardiovascular risk in women increased by 25% compared to 15% in men. So this shows that the control is more important in women than in men. Can you help me with the slide? Yes. Okay. So the difference in pathogenesis also is that there is more amount of autoimmune diseases and racial differences in women. And what is important is that in hypertension in women, you take it as 5 stages, menarche, and then you take it adolescence and the patient of childhood, and where they go to the reproductive years, and then they go to menopause and old age. And it's very important to know that a younger age group, you look for secondary cause of hypertension. In the reproductive years, the hypertensive disorders of pregnancy, PCOD, hormonal pills, ARTs play a role. And in as you go to menopause, menopausal hormone replacement therapy, vasomotor symptoms are also there. And there's also increase in vascular stiffness in elderly person. So this secondary hypertension, to look for what are the things to suspect in secondary hypertension, has been discussed by the Dr. KPS, so I don't want to go into that. So what is the important thing is that in postmenopausal women, there's a dysfunctional renal physiology leading to impaired natriuresis. That is the main contributor, and salt sensitivity plays a very important role in this group of hypertensive patients. And if you take secondary hypertension, if you take all the women, all the patients with secondary hypertension, in all the secondary hypertension, we say fibromuscular hyperplasia 9-fold in women, thyroid 10-fold, Cushing's 3-fold, hyperparathyroidism 3-fold, and drug-related hypertension also more common, except in obstructive sleep apnea, where this is more common in men. So this group of postmenopausal women are another distinct group, which have got isolated systolic hypertension is a major challenge in them, and the less efficient therapeutic response when compared to aged men. They are more common, more sensitive to salt, and the association metabolic syndrome is also unique in this group of patients. And because of the non-dipping or impaired dipping pattern, the elderly women are more prone for cardiovascular risk factors, and even the drug-related side effects are more in menopausal women. I will not go into the pregnancy-induced hypertension because there's a separate talk which is going to come after this. So what is the important thing is, whenever you treat a pregnancy-related hypertension, you remember that the risk that this person is going to have is not confined to the pregnancy. It's a lifetime risk. And so these patients have to be followed very closely, because the risk of complications is double for cardiovascular disease and 5 times for the development of hypertension in later life. And the goal of treatment for this is also set lower. So when we talk about menopause and hypertension, this is the next stage of hypertension we have in women. There's a genetic predisposition which predisposes these patients to hypertension, and the environment also contributes. It's very important to know that there is reduction of estradiol and the estrogen testosterone ratio, which associates with endothelial dysfunction and increases with BMI, type 2 diabetes, sympathetic activation, renin release, and angiotensin 2. And if you're going to give hormone replacement for postmenopausal women, you must only give for less than 10 years postmenopause and less than 60 years of age. 17 beta estradiol is preferred, but it's very important to know that this depends on what route you administer, and the progesterone also matters. So drospirenone is preferred, and you can use micronized progesterone or dihydrotestosterone in BP neutral. So this, depending on what stage of patient we are dealing with, we should use the drug. And now transdermal therapies are there, which have got very minimal effect on BP. The 2 crucial stages of autonomic nervous system also occur during the menopause. One is the increased activation of the sympathetic outflow and enhancement of the sensitivity. So because of that, postmenopausal women, beta blockers must be still a drug which is of a real use in this group of patients, because the sympathetic nervous activity is significantly steeper than in men of the same age. The current newer concepts are going towards immune regulation and the T regulatory cells. The dysregulation of the T cells immune response is one factor where we are looking at the area which has been explored. Is now presently more in male population than the female, but this will be a focus of research in future. So whenever you have to manage hypertension, you have got challenges. There's a lack of knowledge regarding the pathophysiology. We don't know exactly. There are some female specific factors, and we should also know that global control of BP is only 23%. So the different stages of women's life, the effect of sex hormones, variability in access of care, and they are less represented in major trials. And the threshold for treatment and control of men and women currently set are the same, but in future they may require a little more stringent control. So if you should take a proper history and examination, emphasize lifestyle and early pharmacological therapy with patients with stage 1 hypertension and history of pregnancy with hypertension has been considered. So these are the different types of which have already been discussed, lifestyle modification. This right now we should know that in anti-hypertensive drug therapy, there's no differential treatment between for men and women. But there are definite gender-dependent differences exist in pharmacokinetics and pharmacodynamics. And basically, you have three categories of patient, irrespective of the age group. You look one if patient has got any compelling indications. You have a typical, for example, ISDs or CKDs or heart failure with preserved ejection fraction. Because these group of patients, they have to be treated differently. And most importantly, when you treat patients, is look at whether this patient is going to go for pregnancy or not. Because if the patient is planned for pregnancy, your approach is totally different. There's a definite role of mental health in hypertension, but the association, which is very complex and it is very difficult to pinpoint one point of that. So is there need for a stricter control? A prospective study has shown that if you do an ambulatory BP, the 125 by 80 of in women and 135/85 in daytime and a nighttime BP 120 by 70 and 110 by 65 seems to be the goal. So future, it needs to have a globe. You need to have three partners. You are the patient, you are the doctor, and the government. And you need to each have to contribute in controlling the menace of hypertension. So the steps in hypertension is you look at comprehensive public health interventions and a heart's technical package, healthy lifestyle, evidence-based treatment protocols, access to medicine and technology, risk-based management, team-based care, and system of monitoring will be the future. So in this calendar of this lady, of a female patient, the multiple areas, multiple challenges, and the treatment of hypertension has to be approached differently depending on the individual patient. Thank you so much for the question hearing. Thank you.
Thank you, Dr. Kannan, for the excellent closed presentation. Kannan is currently Director of Cardiology, Madras Medical College, and Nodal Officer for NHM PTCA procedures. Mahadevan can come to the stage. We can have one question per speaker from the audience, please.
So my question to Mahadevan sir. Sir, in using thiazides to elderly patients, how do we negate the risk of hyponatremia? Thiazide-induced hyponatremia.
Before giving thiazides, you may estimate the serum sodium or electrolytes for that matter. If the individual is prone for loss, maybe due to pre-existing disease, thiazides cannot be restarted. Maybe gout, some other things which may predisposing factor we should not start. The patient is eligible for thiazide group of diuretic can start. If you want to update a disease, you have a fear of hyponatremia. The patient starting on thiazides, patient developing profound hypernatremia, you have to definitely stop the medications. Nowadays, even diuretics, they are monitoring the urine excretion of sodiums. Even ICU setups, we are updating the dosage based upon not upon the urine output. We are deciding on the urinary excretion of sodiums. So they can give a clue whether these patients develop hyponatremia or hypokalemia for that matter.
So sometimes the health freaks, in the gym, they collapse all of a sudden. Is it due to the post-viral sequelae? That's what we say. What do you reckon on this?
See, aggressive, unaccustomed physical exertion, in a gym, very common. The commonest cause is coronary dissection. If somebody falls in the gym, they come with an acute emergency to casualty. Always think about coronary dissection and aortic dissection. These are very, especially coronary dissection, very, very common in young people. Especially they do vigorous gym, especially unaccustomed, very common.
No, they give the history of viral episodes earlier to the death. Is there any link?
Myocarditis. Maybe probably may have a viral myocarditis.
Viral myocarditis, okay.
So with regard to the young hypertension, so the speaker said the ideal drug and the most suitable drug is beta blocker. But any drug can be given, even AC, ARB can also be given because long-term beta blockers can result in erectile dysfunction. So loss of libido, all those things, social problem can arise.
I was about to ask the same thing, sir. Why to use beta blockers? Is there anything alternative? Because in the young, besides the risk factor for CV, stroke, I also these depression also it produces a lot of bad effects. So
All these complications of beta blocker, which I said, all with older beta blockers. Now the newer highly cardioselective beta blockers like nebivolol, bisoprolol is absolutely safe with a very, very negligible even sexual dysfunctions, and they did not cross the blood-brain barrier. So fatigue and depressions and everything is not there with the newer generation beta blocker like bisoprolol and nebivolol. Secondly, young people, it's the adrenergic drive which is very high. So definitely they need much, much better. They feel very comfortable if you give a small dose of beta blocker. Of course, you can combine with AC inhibitors, ARB, calcium block, anything. But a touch of beta blocker will give them a lot of comfort and lot of benefit, especially they got increased adrenergic drive. Thirdly, the beta blocker will not prevent stroke. There is again, the studies have come with atenolol, not with bisoprolol and nebivolol. And young people, we are not thinking about stroke. Young people, we are thinking about coronary artery disease, where beta blockers have very high role of preventing coronary artery disease.
So there is something called, a small comment from Dr. Payani. There is something called pharmacoeconomics, because some of the drugs are expensive, some are not that expensive. When the international recommendations are made, it is made based on pharmacoeconomics. But we have the liberty because our medications are affordable. I think we have to choose the drugs based on the underlying comorbid factors rather than purely based on the international recommendation. And
absolutely.
And your comments, please.
See, because the majority trials also are not done for these molecules. No one is willing to support atenolol studies at this point of time. That's another challenge.
What is the drug of choice for postmenopausal hypertension?
Postmenopausal, there are two categories, sir. One, they have more chance of isolated systolic hypertension. For them, calcium channelers, glucose may play a role. But there's another group of patients who may have new onset hypertension post-menopause. In that, adrenergic drive may play a role. There is a role for beta blocker. But if it is a systolic hypertension, calcium channel blockers, small dose diuretics, and now RNAs have been given a place in isolated systolic hypertension.
Thank you, thank you, speakers, for wonderful.
Since you said it's a high, nearly 25% of the youngsters are having a BP and you would like to treat them with beta blockers, why do we not do away with very poor ones like atenolol? I think Dr. Narasimham sir was telling that day that in our younger days, I am a CMO, over 30 years I've been prescribing atenolol, and because it is cheap drug, 4 paisa, 5 paisa for the government. So why should we not stress this society is a very strong body with big salvats. You should bring to a point to do away with the government supply of atenolol. All over India, government hospitals, every month patients come and collect atenolol and NVAS.
Government right now,
I was stressing on it.
See, there is no much difference between enalapril and ramipril if you go into the thing. It's only the class effect. Atenolol, even metoprolol is available. Carvedilol is also available in the government. Those were the eras when we had only atenolol. Now we have both carvedilol and metoprolol.
All drugs are available.
All are available. Absolutely.
Nowadays, the beta blockers like the atenolol, we are slowing it down, madam, because of its the other effects. Of course, we have learned quite enough from Life and Ascartel BP arm. So the usage of atenolol has drastically come down, and it has been replaced by other beta blockers, which are very much available, which are cost effective also.
Thank you.
Comment.
Thank you, sir, for this comment. And it was a mind-blowing and highly interactive session. I thank Professor Narasimhan sir for a great opportunity given. Thank you all. We'll close this session.
Thank you so much, doctors. A big round of applause once again. A big round of applause once again for these lovely topics that were discussed, and to all the speakers and the moderators of this session. Once again, I would like to thank our moderators, Dr. A. Arvind, Dr. K. R. Sivanesan, Dr. Ranjit Pratap, Dr. K. Dhananjayan, and also the speakers, Dr. V. Mahadevan, Dr. Namita Narayan, Dr. K. Kannan, and Dr. K.P. Suresh Kumar. A big round of applause once again. We have with us Dr. Narasimhan doing the honors and felicitating each one of them present here. And also joining Doctor would be Dr. Chandrasekharan as well. Can we have a louder round of applause, please? We have Dr. S. Chandrasekhar and Dr. S.N. Narasimhan doing the honors and felicitating all our wonderful speakers of this session and the moderators. That's Dr. Kannan for you all. A big round of applause once again. May I request all the doctors together to stay for a picture, please? I kindly request all the doctors to be present here for a picture, please. Just a quick moment that has to be photographed. We have all the lovely doctors. Once again, a big round of applause to each and everyone present here on the dais today. Thank you, doctors. Thank you. You may get back to your respective seats. Moving on, we will now have the next session. The next session, which is the fourth session of the scientific program today. And the moderators for this session would be Dr. S. Suresh Khanna, Dr. R. Balaji Nathan, Dr. K. Venkatakrishnan, and Dr. RBS Manian. Can we have all the moderators on stage, please? Ladies and gentlemen, please put your hands together to welcome our distinguished moderators on stage. And today the topics that are going to be discussed in this session are hypertension in pregnancy, hypertension in the elderly, hypertensive emergencies, and hypertension and diabetes. To begin with, I would like to call upon stage Dr. Prabha Ganapati. Please come, ma'am. Dr. Vaishnavi, please do come upon stage. Over to you, ma'am.
So,
Good afternoon,
Dr.
everybody.
Prabha will be discussing on hypertension in pregnancy.
First of all, I would like to thank my teacher and my mentor, Dr. Narasingan, whom I just treat him like my guru, my God, and everything for me without his consent. We do not move forward in our family. He has been our family physician since more than 3 decades. Thank you very much, sir. Today, the topic given is hypertension in pregnancy. If you go to see the hypertensive disorders in pregnancy, it compasses a spectrum of chronic hypertension, which can move on to a multi-system disorder, preeclampsia, which can progress to complications like eclampsia and multi-organ failure, like left ventricular failure, renal failure, pulmonary edema, and hepatic failure too. Preeclampsia and its complication is a major cause of maternal and perinatal morbidity and mortality across the world. Preeclampsia, eclampsia, and the HELP syndrome, that is hemolysis, elevated liver enzymes, and lower platelet syndrome, remains significant worldwide, with estimated prevalence of about 0.43% and 0.39% respectively. Pool prevalence of hypertensive disorder in pregnancy in India is to be about 9%. Preeclampsia, eclampsia is responsible for about 5 lakhs fetal and neonatal deaths and 70,000 maternal deaths per year worldwide. So we go on to see the classification of hypertensive disorders in pregnancy. The first one is a pre-existing chronic hypertension, which could be at the onset of pregnancy or which would have come in before 20 weeks of gestation. Gestational hypertension will be hypertension which is coming in after 20 weeks of gestation in the absence of proteinuria or any other sign of preeclampsia. Preeclampsia will be gestational hypertension with proteinuria and other maternal end organ dysfunction, including neurological findings, pulmonary edema, hematological findings, kidney injury, hepatic dysfunction, and last but not the least, which is coming in so much, is uteroplacental dysfunction, which is generally not been there since many years, but which has gained a lot of importance now, the uteroplacental dysfunction. Preeclampsia superimposed on chronic hypertension is hypertension, a patient with hypertension who can get into preeclampsia before 20 weeks of gestation. So we have screening methods for preeclampsia, and thereby we can prevent preeclampsia. So what are the methods? The first, this is a risk factor score or gestosis score. This has been devised in India for your information. First, we have demographic factors like age older than 19 years, age younger than 19 years, obesity, the primigravida, women born as small for gestational age. Then we have family history of cardiovascular disease, chronic vascular disease like dyslipidemia, excessive weight gain during pregnancy, and mean arterial pressure more than 85 millimeters right at the onset. And now we have IVF and ICSI pregnancies. They all have score 1. And if you go to score 2, we can see that it will be family history of preeclampsia, gestational hypothyroidism, gestational diabetes mellitus, hypertensive disorders in previous pregnancy, multifetal pregnancy, and obesity with BMI of more than 35 kilograms per meter square. If we go to score 3, it will be pre-gestational diabetes, chronic hypertension, inherited acquired thrombophilia, maternal chronic kidney disease, autoimmune diseases like systemic lupus erythematosus, antiphospholipid antibody syndrome, rheumatoid arthritis, and pregnancy is assisted reproductive technique using ovum donor or surrogacy. A total score of 3 or more we have a high chance of developing preeclampsia. Other than this, we have some markers like mean arterial pressure, uterine artery Doppler seen by ultrasound, which we do it around 11 to 14 weeks. When we are doing our NT ultrasound, we do this for preeclampsia screening. Then we have a biochemical marker, that is PAP-A. Then we have angiogenic markers, which is very important, that is placental growth factor independently and SFLT1 by placental growth factor ratio. This is soluble FMS like tyrosine 1 kinase and placental growth factor ratio, which is gaining a lot of importance now in our field in diagnosing and predicting the preterm preeclampsia, and thereby when we are able to get to know that this is abnormal, we can give aspirin 75 mg to 150 mg as early as 12 to 16 weeks when we diagnose it between 11 to 14 weeks. Aspirin 75 mg we give even with just risk factor score with clinical characteristics when score is 3 or more. But when we have a multimodal screening where we have mean arterial pressure, uterine artery Doppler, PLGF, and the score, clinical characteristic score, all together put in shows us that we have a chance of developing preeclampsia. We can go up to 150 milligram dosage, which is generally given after 12 weeks, at least before 16 weeks we have to start. Even up till 20 weeks we can get the benefit out of it. We can reduce the percentage of progression to preeclampsia by nearly 50%, and this aspirin prophylaxis plays a great role in preventing preeclampsia and preventing the severity of the disease. Going to see the hypertension and pregnancy. Individuals with hypertension who are planning to become pregnant or have become pregnant, as we have already seen, labetalol and extended release nifedipine are the preferred first line management. And as we have already seen, should be counseled for a low dose aspirin to reduce the risk of preeclampsia and its sequelae. What drugs should be avoided, we already know, but to reiterate again, atenolol, ACE inhibitor, ARB, direct renin inhibitors, nitroprusside, MRAs, and which can avoid fetal harm. Pregnant individuals, the BP, we keep it as a cutoff as 140 by 90, and the severe one is 160 by 110. So diagnostic criteria of preeclampsia will be, along with our BP, it's going to be proteinuria, which is 24-hour collection, more than 300 milligram, protein creatinine ratio more than 0.3, and dipstick reading will be 2+. And we have important criteria of thrombocytopenia, reduced kidney function with creatinine more than 1.1, or impaired liver function, pulmonary edema, new onset headache, unresponsive to medication or visual symptoms. Common oral hypertensive agents, we know labetalol, nifedipine, methyl-dopa, and hydrochlorothiazide come as a second line. And when we have emergencies, we have labetalol, IV also, hydralazine, IV, nifedipine is the best because we can give it orally in emergency. When you're shifting the patient, we can give the medicine orally and send the patient. Regarding eclampsia, all convulsions during pregnancy are to be treated as eclampsia unless proved otherwise. So imminent symptoms will be severe headache, visual disturbance, epigastric pain, breathlessness. So we do give prevention here when we have imminent signs and symptoms with full dose of magnesium sulfate. Management will be airway, breathing, circulation, and delivery is the definitive treatment. Magnesium sulfate will be the first drug of choice. We have a loading dose and maintenance dose, which has given 24 hours after delivery or lost convulsions. And we have to monitor for toxicity of magnesium sulfate too. So delivery will be after maternal stabilization. Delivery is the definitive management, and the timing of delivery is very crucial to avoid the maternal and perinatal morbidity and mortality. Gestational hypertension, not on hypertensives, it will be around 37 weeks plus. Chronic hypertension and preeclampsia without severe features, also 37 completed weeks. With complications will be 34 to 37. We have to take care of the baby with antenatal steroids and magnesium sulfate for neural protection if necessary. Preeclampsia will be severe features with worsening maternal fetal parameters. We have to deliver as soon as we stabilize the maternal condition, and it is irrespective of the gestational age. Postpartum monitoring, follow-up, future risk counseling, lifestyle and preventive care, as we all know, is very, very important in these patients for their future cardiovascular risk and metabolic syndrome. Thank you very much.
Thank you, madam, for that excellent and focused presentation. For our next topic on hypertension in elderly, it's my privilege to welcome Dr. P. Parandaman sir, a great teacher and a wonderful speaker. Over to you, sir.
At the outset, I'd like to thank our teacher, Professor S. N. Narasingan sir, having given this wonderful opportunity. I'll be talking on the hypertension in the elderly. As we age, what is it? Slide? No. As we age, the stiffness of arteries. On top of it, you have hypertension, diabetes, further worsening of stiffness of arteries. So it is synonymous with this arterial disease. It is found that 1/3 of the world population, adult population, is hypertensive. But see that 70% are elderly. Among the 1/3, 70% are elderly. And these arteries are aging faster than what we think. Why? Because of internal changes. How does it happen? Arterial stiffness, elastin, loss of elastin. Breakdown elastin, increased collagen, cross-linking stiffness, that resulting in systolic hypertension. See the endothelial nitric oxide decrease, so no vasodilatation, vasoconstriction. See activation of renin-angiotensin systemic sympathetic nervous system. So renin water retention, sodium water retention. So all these compound to systemic hypertension. So this is a pathology happening. Not only that, there is a decrease of baroreceptor reflex, increased sodium retention, LVH, heart, increased white coat hypertension, everything was discussed. So it's all happening in elderly hypertension. And what happens, the pathophysiology is a structural change, hemodynamic change, neurohormonal axis, oxidative stress, target damage. So all these are happening in hypertension that results in high systolic hypertension. That is the hallmark of elderly hypertension. What are the clinical phenotypes? The unique for elderly. One, isosystolic hypertension is a hallmark. It increases CV events. Two, orthostatic hypertension, very common in elderly, orthostatic hypertension. Sometimes they fall, frequent fall, they come, they say that's a problem. Third, it is a nocturnal hypertension. Already all previous speakers spoke about nocturnal hypertension. So these are very common in elderly. And white coat hypertension also common. That results in prognosis, worse prognosis, then pseudo hypertension. Thus, that can be easily detected by Osler's maneuver. And this is very, very important. The blood pressure drops 20 to 30 mm mercury after meal. So any person comes with the dizziness while walking after food, see that this drop in blood pressure, very peculiar to elderly. And lot of guidelines, these are the guidelines. What are the targets? The targets, see ESC guideline, European Society of Hypertension, European Cardiology, AZ, everything less than 130/80. But see, if it is elderly, it should be less than 150. This is acceptable. Elderly more than 80 years, less than 150/80. And if it is younger, anywhere between 130 to 139, that is 140. That's accepted by the guidelines. So what are the pharmacology? Which pharmacology use? See, now say there are discussion about the beta, the adrenergic stimulation, you give beta blocker. Actually, the adrenergic stimulation increase the vasoconstriction by L channel of the blood vessel. So if you give calcium channel blocker, it brings in the blood pressure caused by systolic, that is caused by the sympathetic nervous system. See the mechanism. In a person who's having anxiety, catalabin, the blood pressure is due to L channel activation of the blood vessel, that is causing hypertension. You give calcium channel blocker, BP will come down. Apart from here, in addition to this, and the ACE inhibitors is a renoprotective, that's advised, and thiazide is prevention, stroke prevention. Beta blocker, it's only for those who are HIV, the coronary heart disease, heart failure with a reduced ejection fraction, and spironolactone used for there is a resistant hypertension. Avoid alpha blocker in elderly. Again, the there is a postural hypertension is very common with that. So what are the combination? The combination uses step 1, combination of drugs in elderly. Step 1, add CCB plus ACI or ERB. Fixed dose combination. Initial, start with the dual therapy. 2, CCB, ARB or ACI, add thiazide, 3 drugs, maximum reduction. Step 3, if it's resistant, add your spironolactone. Step 4 is not improved, refer to the specialist who can do intervention. So single pill combination improves the adherence in the elderly. Adherence will be 30%. So please, that particular thing is advocated. What are landmark trials in elderly hypertensive? Evidence that change the practice. Following this trial, the practice has changed. What changed? See a sprint trial, 2015, using 9,000 odd patients, more than 50 years, intensive blood pressure control, less than 120. And to the conventional control, the intensive control brought down the CV rate by 27% and mortality by 27 to 25%. It's like close to that. So the intensive target shifted the guideline to the lower the target. This is the first to suggest lower the target in the elderly. This IVA trial in 2008, around 4,000 population done. Indapamide decreases the CV rate reduction. And SHIP trial, 1991, using more than 4,700 odd people with isolated hypertension more than 60 years. They said chlorthalidone, atenolol decreases the stroke events, and it is used for isosystolic hypertension. And this systemic and European trial that has suggested that nitrogen is better control, and this also brought down the CV rate. ACCORD trial. This shows intensive with the standard and the no CV benefit with the intensive control. So it suggests it's not always beneficial, bringing the lowering. And the STEP trial shows that is in China study shows intensive blood pressure control improves the outcome and decreases the mortality. And it's found that 10% reduction in blood pressure decreases stroke by 35%, decreases MI by 22%, decreases heart failure by 28%, decreases CV by 18%, decreases all-cause mortality by 13%. So it is very well clearly mentioned in the studies. What are special situations? Dementia. Elderly dementia is very common. What is the advised drug? Advised drug is telmisartan. It's supposed to bring down the cognitive impairment by 15%. What is the next? CKD. Very common in elderly with comorbids. Advised drug, that is proposed drug, ACE inhibitor, first line drug to reduce the proteinuria. And heart failure, again ACI, ARB, and you can add the other drugs, beta blocker and spironolactone, if at all there. And atrial fibrillation, rate control is very important. This diabetes mellitus, you know all these things, and this trinity, you have to optimize the dose. So all the lifestyles, smoking, alcohol, is all decrease the blood pressure by 4 to 5 millimeter mercury. All lifestyles, everything. You add 30 millimeter mercury comes down. It is a lifestyle is a medicine. What are my take-home messages? Friends, treat hypertension at any age. Age alone, never a contraindication. Isosystemic hypertension more common in elderly. Target 130 to 139 for a fit individual, and less than 150 more than 80 years. CCB plus ARB ACI is preferred first line drug, and single pill combination improves adherence by 30%. Always measure orthostatic hypertension who gives history of fall. Decrease the 10% systolic pressure, decrease all these mortality CV events. Lifestyle is a medicine. Restriction of salt less than 5 grams. 150 minutes of walking. Quit smoking. That is, each reduces the incidence of CV reduction. So healthy blood pressure means healthy brain, healthy heart, and a healthy aging. Thank you very much for patient listening.
Thank you, sir. Thank you for your wonderful and lucid presentation. Very clearly explained about the clinical phenotypes, pharmacotherapy, about hypertension in the elderly. Thank you so much, sir.
Thank you.
Next, I invite Dr. Susavan Mitra, a renowned physician, to talk about hypertensive emergencies. Over to you, sir.
This is working now. Good afternoon, all. Thanks the organizer for giving me the opportunity. I know exactly you will be looking like this hypertension emergency because I am just standing in between the lunch and the topic. So I would try to make it as fast as possible, like how we treat the hypertensive emergencies. Let's go for the few case scenarios and we'll see how it goes. I think everything, okay, that's okay. Everything has been discussed previously, so that all these targets and all that exactly I'm not going to discuss all these things today. We'll give you some case scenarios and this thing. This is very common. You will see, I think, every day and night. Like when 68-year-old male come to you with sudden onset of weakness, has a right nice weakness, no seizure, no LOC. You take the detailed history, you find out patient is hypertensive, type 2 diabetes, smoking, and we examine the patient, very important. Like we examine the patients and we found out that the patient having right hemiparesis. Kindly see the BP is 220, 120, and we get stuck that what we'll do, like that, what will be our choice and what will be going to think. So we all knows that was stroke. This is stroke, and we'll do the CT. We'll show that with the acute ischemic stroke. We will not go to this pathway to discuss about the strokes and all. I'm not going to do that here to making you more bother. We are only focused on the blood pressure, which is going to see that. So this is exactly that we all of will be confused all the time that what will be our targets. The most common thing, remember, you don't have to dramatically reduce the BP. Your target will be 1. If you are going for the lysis, which is very common in city of Chennai now, and we do day and night in our institution. So if you are doing, our target will be less than 185 to 110. Please remember, don't ask me that why it is 185 to 110. This is done by a extensive cohort, which from that only they got this number. And that exactly we have to maintain. Now, you don't have to reduce the blood pressure very religiously because that exactly will reduce the blood flow to the penumbra and your stroke will be increased. So do not be very over enthusiastically reduce the blood pressure. Now come to the agents. The agents preferred should be IV labetalol. It's very, if in the exam, if somebody is going for the exam, your drug of choice will be nicardipine, which is not available in India. In India, it's IV labetalol, and that's very important to do that. If you are outside the thrombolysis window, your BP target will be quite high, 221, 1020. Please remember, again, do not do religiously control the blood pressure. The reason is same for the penumbra region. We are going to do that. What hypertensive drug? As I mentioned you, please remember the doses are very important. It's not about 2 mg or 1 mg. It's 10 to 20 mg IV per minute. That is the IV labetalol dose. The message should be very loud and clear. It's 10 to 20 mg per minute. That's exactly the things. Should you eat NTG? NTG is very good for the heart, not good for the brain. Please remember, it can cause excessive hypotension. It can cause the unpredictable response, which actually make your stroke bad. And that's exactly the message I'm going to do that. Is there any data is there? Yes, we have data, which is also showing that like ENOS guideline is very clear that please do not use NTG if you are going to treat with the brain. Okay. So these are the few trials, and if you see the trials, that NCHAT trial or Interact 4 trial has very clearly mentioned that how is your, please go back. Next scenario, you will find out that the intracerebral hemorrhage. Okay, is there anything different? Yes, it is, little bit. Your target should be 140 to 160. That is very equally important. Please remember these values, like it's equally important. If you do not have to reduce the blood pressure very enthusiastically, it will actually going to harm the patients like that way. So again, the drugs remain same, labetalol, nicardipine, clevidipine. In India, in city of Chennai, we have IV labetalol. We can vary it, use it, and it's based on this attached 2, which came in 2016. It's there. Now the values, if you see this Interact 2 and attached 2 trial, which an AHA 2020 guideline, they are very clear that they have to keep it by less than 140. Now, one more scenario you will face that you have done the mechanical thrombectomy, which is very common in city of Chennai. Majority large vessel is going for mechanical thrombectomy, and the blood pressure monitoring is very important like that way. Please remember, if you go for the pre-perfusion, it should be 140 to 180. Post-perfusion, again, 180 to 105. That is equally important. Please keep the numbers in your mind. Okay. So, too much BP fluctuation is actually bad for the brain, and that's what exactly I'm trying to tell you that. One more scenario, subarachnoid hemorrhage, it should be less than 160. And when I say subarachnoid hemorrhage, not the traumatic one, it's an aneurysmal subarachnoid hemorrhage, which is we're going to do. That's exactly I'm trying to tell you today evening. Okay, then another person, This is very common. Again, you'll see you get a gentleman who have a breathlessness, history of P&D, come with BP to 220, 130, heart rate is high, JBP elevated. By this time, all of you know this is the hypertensive heart failure. Now here, I'm not going in detail that whether it's a heart failure with preserved EF or heart failure with reduced EF, but the treatment is that we are only going to focus on the hypertension control. Here NTG has got a role. If it is hypertension, yes, NTG has got a role, and please use the NTG here very carefully, the dose what you're going to do that. That exactly I'm trying to do that. So you have to know this NTG. One drug which all of you use if the blood pressure is not controlled is the sodium nitroprusside, but not in the setup of acute coronary syndrome. Let's see why. It is, if you're going to use the IV nitroprusside, you have to be very careful about the cyanide toxicity. It need IV artery, the arterial line monitoring. Do not use IV nitroprusside if you're setting up acute coronary syndrome and in the setting up ICP. Please remember like that way, and you have to be very careful when you use the drug. You also should know that how to monitor the drug. That is equally important. You have to do the ABG to find out that whether the early signs of toxicity is developed or not. Again, this is one scenarios. We have a patient, we have episodic hypertension, severe headache, palpitation. By this time, all of you know this. You have done all the CT abdomen, which showing that the plasma metanephrine is high and adrenal mass is high. Definitely, this is pheochromocytoma. Now, for me, specifically put these slides was equally important because the management of pheochromocytoma, hypertension emergency is entirely different like how you manage normally. Here, you have to give the alpha blocker, beta blocker, calcium channel blocker is important. Now, the doses, you just in the monitor, you can very well see that there's the doses, you have to be very careful. The one scenario you always face that and commonly ask that the patient go for surgery and then you will have to control the blood pressure. The important point is that when you do the tumor manipulation, patient will have hypertension. When you done the tumor manipulation, patient will have hypotension. So you have to treat very carefully with the drugs. And that's the reason for me to make you aware of it, these slides. One more. This is like nowadays we are all in the monoclonal antibodies. Patient on the sunitinib, some EGFR, and will come the patient to you with high blood pressure. And this is the scenario. If there is no end organ damage, I think the previous all speakers exhaustively discussed that. This is called the hypertensive urgency. I'll finish in 1 minute. Like that. Please remember all the drugs. These are the drugs which I show you like that way. The one point which I wanted to say you that if you get a patient of hypertensive urgency, do not forget to examine the ophthalmoscopy. If all of you have the ophthalmoscopy, please examine the ophthalmoscopy. We do it in ICU in ophthalmoscopy. It is equally important like that way. That will give you a lot of guidance. Please remember like that way. And these are the drugs which you are going to do that. So these are the difference between hypertension, urgency and emergency. Now this is the one CKD patient come with hypertensive emergency. This is, you can see, this is very commonly you do that. The putting the slides equally important is that BP control is important. The more important is that you don't have to dialyze and take the fluid out very enthusiastically. Equally important. If you want to, the previous speaker, they have already told that your reduction score is less than 25% is very equally important. So do not do very religiously to do the take the fluid out, patient will get better. It will not, it may harm you. So please remember that you have to be very careful. So the take home message is that you have to remember that the BP elevation is defined by the end organ damage. I think by this thing all of you know, you have to target the organs. It's very time sensitive. You have to know the medication. Unless it is a hypertensive urgency, it should be IV and you should know the dose. The goal is very clear. You have to reduce the 25%. And that always identify the cause, avoid the overcorrection and local control. I know you are exactly feeling how is it. Thank you for patient learning. I just crossed a little bit time that exactly hypertensive emergency will do that. Thank you.
Thank you, sir. Thank you for your wide scenario-based coverage of hypertensive emergencies. Next, I would like to call upon Dr. Shruti Chandrasekhar for delivering a talk on hypertension and diabetes.
Thank you. Thank you. Very good afternoon. Thank you, Chairperson. And it's been a great learning experience since morning. I should thank Dr. Narasingan sir for that. Lot of learning points, practice changing, important points for me as well. So I'm going to keep it very brief. I have only like 7 minutes. So I'm going to talk about management of hypertension in patients with diabetes. How do we manage it? It's not moving. The slide deck is not moving. Okay, so I'm going to start in the interest of time. Just not going to wait for the slides to move. So management of hypertension in patients with diabetes, I think there is some problem with the display as well. Mukkavasi, most of the guidelines that I've taken for my talk today is from the IAP guidelines from 2024 and also the RSSDI guidelines from our own Indian data. And the ADA guidelines from 2026 and 25 slightly differs in terms of the drugs and how do we manage it. But for the Indian specific criteria, I have kept it very simple in terms of the guidelines from the Indian perspective. But if you look at the epidemic, thank you so much. Thanks a lot. So this is the guidelines that I was talking about. Idilenda Mukkavasi slides I have made. If we talk about the, can you move it from there? Neenga anga move pandringla? Okay. Sorry, I'm taking 5 minutes because of this technical glitch. I'm sorry, I don't know what's wrong. Thank you. Thank you so much. Thanks. Okay. So if you look at the epidemiology of this, I can't look at this because I'm talking this. You see there's a comorbid overlap between hypertension and diabetes. This is exactly what Dr. Rajesh was also talking in the panel discussion today. And it is a national threat. And from the ICMR data from Dr. Mohan sir and the team, we know there is a increase in rural acceleration between the diabetes and hypertension in terms of prevalence of hypertension, pre-diabetes and diabetes. And if you look at the pathophysiology, if you look at the left part of my slide, there is a strong bidirectional relationship. Hypertension and diabetes ko a strong or interconnecting loop. That is what I've mentioned here in terms of the pathophysiology of activation of the RAS system or be it the endothelial dysfunction that happens in patients with hypertension. So what exactly is the take-home message? Insulin resistance, hypertension, rendume interconnected. And this is going to drive a lot of metabolic disorders that we've been talking since morning. And if we have to target blood pressure, there are a lot of studies that have done, but if you have to target blood pressure for your patients with diabetes, the magic number is less than 130/80. I think this is an important take-home message for the attendees today. And in terms of the diagnosis and measurement, we have talked enough about this, but the bottom line is, unga patient office la adha ungaloda clinic la neenga blood pressure measure pannalum, you need to have the ambulatory blood pressure if affordable, if your patient can afford that and if it's available, or home blood pressure monitoring. It's very important. Rajesh talked extensively about masked hypertension. Office blood pressure normal irukkalam, but with the risk factors of CKD, diabetes, PCOS, metabolically associated fatty liver disease, they might have a masked hypertension which we cannot miss. So we really need to have every home glucose reading or continuous glucose sensors that we are doing for our patients. So அதே மாதிரி home blood pressure reading is mandatory. I think that's one message that I learned for myself. So என்னதான் நம்ம ஆஃபீஸில் blood pressure measure பண்ணாலும் we need to have an ambulatory blood pressure and a home blood pressure. If you do that, you have this 2x2 grid. அதில் வந்து this is the exact part that I want to talk, masked hypertension. You look at the number. It's really alarming from the data that we have. It's about 66% of your normotensive patients whom you see in your clinic could have a masked hypertension or high out of office blood pressure, which you will not measure or which you will not diagnose unless you ask your patients to check their home blood pressure reading, which is fairly easy, simple with available machines that we have right now. This can be done, and this is a very important take-home message. It is especially very, very important in patients with diabetes because it accelerates the end organ damage, the CKD, the retinopathy, and the other complication that can sort of coexist between our patients with diabetes and hypertension. And once you do that, you have a risk stratification. This is very important. So the first part we all know, age, sex, systolic blood pressure, smoking. We had extensive discussion about cholesterol, everything, right? This is all like we all know. But once you do have there are diabetic multipliers which will worsen the hypertension. So you have the target end organ damage. You could have a patient with CKD, or they could have patients with retinopathy, neuropathy, which sort of adds on to the hypertension complication. And if you look at the India-specific motivators, what is difference in our Indians? I think from a practice perspective, this is we talked about hypertension in women, early menopause. We don't get a history of menstrual cycle. We don't put them on HRT. We don't talk to them about HRT because HRT has become a taboo. So the HRT, the early onset menopause, increases the risk of hypertension, diabetes, cardiovascular disease, and a lot of other problems. Pollution, very common. Pollution, Delhi lala inga. So that is another India-specific modifier. And we talked about LPA, lipoprotein A, why that is important. And in terms of the autonomic resting heart rate of more than 80. So these are all the Indian-specific modifiers which are going to further aggravate the diabetes and hypertension complication in your patients with diabetes. And in terms of the treatment, the major treatment is still the dietary prescription. You ask them to restrict the salt, less than 2,300 milligram per day. Good healthy diet, the DASH diet or the Mediterranean diet, Nariya fiber, fruits, healthy eating patterns, also listening to your chronobiology and not eating very late and sticking to this eating pattern, which is very important. And physical activity. We talked about the physical activity in the panel also this morning. 50 to 60 minutes, 3 to 4 times a week is very important. Yoga has been strongly propagated in the Indian guidelines. Romba strong recommendations for yoga in terms of postures, breath control, meditation, especially the Savasana. All those things have been talked in terms of the blood pressure reduction, both systolic and diastolic. So this forms the key management like any other hypertensive patient, especially in patients with diabetes. Ilenna added advantage na, the sugars also will get better with lifestyle changes. So ore kalla rendu manga madri, so we can even address the diabetes and the hypertension and the other metabolic problems that are associated with that. In terms of pharmacology, you have the drugs. This we have discussed a lot. ACE, ARB, first line therapy, CCBs, diuretics. We talked about thiazide and chlorothalidone, beta blockers. Beta blockers are not the first line therapy for patients with diabetes. It can mask hypoglycemia, but if you have patients with coexisting cardiac condition with reduced EF or post-MI, obviously beta blockers would be there in the prescription. So you pick and choose the medication. And what is important is like anti-diabetic therapy la pandra madri, we use drugs with multiple, use an early combination therapy, hit them early, hit them hard to sort of prevent this complication. And that is exactly what we do in patients with diabetes and hypertension as well. And if you look at the generational comparison, somehow the Indian guidelines, other than this is where there differs from the ADA and the American and the NICE guidelines, Indian guidelines, there is a difference which I learned while preparing for this talk, is clinidipine has been propagated as a safer, superior option in patients with diabetes when compared to the other calcium channel blockers. I'll finish in like 30 seconds. And in terms of the beta blockers, you use it for specific population, not the first line therapy. Coexisting cardiac condition, you use it. And now we have excellent anti-diabetic drug, SGLT2 inhibitors, GLP-1 receptor agonist, Finrenone is coming in a big way. So use the right drug for your patient. Even diabetes and hypertension prescription should be tailored according to your patient's, condition. And this is the last slide. So the goal is this. You initiate weight loss, the therapy, upper first line pharmacotherapy, usually dual combo. They recommend CCB with ACE inhibitors or ARB. And then compelling indications, you can add beta blockers. And you can escalate to triple combo if your blood pressure remains out of control, if it's less than 130/80. You can have a triple combo. And you also have a specialist referral. Whenever you need it, you send them to your colleagues, for them to sort of help your patients to get them to the target blood pressure. So with this, I finish and I thank the organizers for this opportunity. Thank you.
Thanks all the four speakers for the wonderful presentation. So any queries you can ask during lunchtime, you're free to ask them when you're in person. Thank you. For lack of time, we will be closing the session.
Check. A big thanks to all our speakers. Can we have a wide round of applause, please? We'd like to thank our speakers, Dr. Prabha Ganapati, Dr. P. Parandaman, Dr. Susovan Mitra, and last but not the least, Dr. Shruti Chandrasekharan. Once again, can we hear it up for them, please? A big round of applause to all the speakers, and I would like to thank our moderators as well for moderating this wonderful session. Thank you, Dr. Prabha Ganapati, for speaking on hypertension in pregnancy. And we have Dr. Susovan Mitra, who spoke on hypertensive emergencies. Can we hear it up for him, please? A big round of applause. And thanks to Dr. Shruti Chandrasekharan for providing us with so much insights on hypertension and diabetes. A big round of applause, please. And thanks to our moderators, Dr. S. Suresh Khanna, Dr. K. Venkatakrishnan, Dr. R.B.S. Manian, and Dr. R. Balaji Nathan. And thank you, Dr. Vaishnavi, for being a part of this wonderful session today. Thank you, Dr. Vaishnavi, for moderating this wonderful session. Thank you so much for being a part of us today. Thank you, doctors. Thanks. All right, moving on. We'll now have the last session of the day. And for this, I would like to call upon stage Dr. P. Soundararajan, Dr. N.D. Ramanujam, and Dr. M. Subashri. They will be the moderators of this session. And today's topic, the first topic for this session would be Hypertension and CKD by Dr. Edwin Fernando. Can we have Dr. Edwin Fernando, the first speaker of this session, with a huge round of applause, please?
Dr. Edwin Fernando needs, as usual, no introduction. He's carrying the flag of Stanley Medical College Nephrology nationally and globally. I think he's a big competitor to Madras Medical College Nephrology. I think content to be in Stanley, which has created history. His dean is there. I'm sure he will support him widely, and he has done the transplants programs very successfully and PG training program in par with Madras Medical College. Many more things to speak. We are eager to listen to Dr. Edwin Fernando. Thank you.
Respected chairpersons, Stanley is second to none, sir. We are in no competition with anybody. Managing arterial hypertension and chronic kidney disease is what I'm going to speak on. So this is a self-perpetuating disease. Hypertension affects the majority of CKD patients at all stages. Elevated BP accelerates renal dysfunction and cardiovascular risk. So even a modest increase in systolic BP is linked to a faster eGFR decline, LVH, heart failure, and stroke. And this bidirectional relationship demands nuanced clinical management. Why BP control remains suboptimal? Altered pharmacokinetics of the drugs, the volume overload, which is a major problem, neurohormonal activation, the RAS and the SNS overactivity, and the diagnostic pitfalls of white coat hypertension, masked hypertension, which have already been highlighted. So basically, we are looking at BP control in renal failure, not purely pharmacological. It's closely linked to fluid management. So dry weight optimization, very essential to maintain intradialytic hypotension. The sodium balance, dietary and dialysate sodium management is pivotal. Individualized targets, there is no single ideal intradialytic BP range that has been robustly established by clinical studies. So the mechanisms of hypertension are both the sodium retention, volume overload, endothelial dysfunction, arterial stiffness, impaired natriuresis, sympathetic nervous system overactivity, the RAS activation, and this leads to cardiovascular effects. Reduced nephron mass impedes natriuresis, promoting the ECF expansion and elevated cardiac output, particularly in early to moderate CKD, where fluid overload often goes unrecognized. 80% prevalence of hypertension in end-stage kidney disease is associated with LVH, stroke, and mortality. Aggressive volume and salt restriction is recommended. So we are targeting the RAS activation, we are targeting the sympathetic nervous system overactivity, and then also targeting the vascular and endothelial dysfunction. So this is a target that we are looking at CKD patients at least less than 140 by 90, less than 130 by 80 if there is proteinuria, diabetes, cardiovascular risk, and 120 by 70 as recommended in the sprint is not what we are looking at. And enough has been said about the office BP, the home BP, and the ambulatory BP. Very important to look at volume assessment where we look at the bioimpedance and the natriuretic peptide and dry weight calculations. So here we are looking at the therapeutic targets being the ACE inhibition, the diuretics, SGLT2 inhibitors, calcium channel blockers, and beta blockers. So ACE inhibitors and ARBs have been the cornerstone of all our renoprotective therapy. Diuretics, loop diuretics can be used even in late stages of CKD. Chlorthalidone up to stage 4 CKD can be used. And calcium channel blockers are effective for systolic hypertension. Safely can be combined with the RAS inhibition. So beta blockers are useful in patients with heightened sympathetic activity, arrhythmias. SGLT2 inhibition has been recommended with all the major trials, cardioprotective, reduced proteinuria, modest BP reduction, and also been supported by the GLP-1 receptor agonist in the FLOW trial and the MRAs, the finerenone anti-fibrotic agents. So almost all drugs we use, we have to use it at different stages of the disease, and one has to understand the basic pathomechanisms underlying the disease to target the right drugs. Renal denervation has been studied in CKD patients also. 3 pilot studies show stabilization of renal function with renal denervation in CKD stage 3. There has been long-term data regarding renal denervation from the Global Simplicity registry, where 475 patients with a mean GFR of 47 was used, and the 24-hour systolic BP reductions were comparable to non-CKD patients. If you're looking at adherence to drugs, which is very important in diabetes, so here's the good news for you. This is an RNA interference agent called zilebesiran. This drug needs to be given subcutaneously only once in 6 months. So just imagine giving an antihypertensive once in 6 months. It targets the angiotensin synthesis in the liver using RNA interference, reduces angiotensinogen concentrations and BP. It has been demonstrated to show BP reduction in uncontrolled hypertension. And this once approved, this is in phase 2 trials now, once approved, may improve the therapeutic options and also improve the adherence. Dialysis patients are again a major problem with blood pressure either dropping or becoming high. Hypertension dialysis patients controlled with RAS inhibition and beta blockers RAS inhibition can be used, but has to be used very cautiously. SGLT2 inhibitors are not currently recommended in stage 5 CKD, but there are some ongoing trials on that. Of course, this is a right time, this is the right proportion of patients where we use ambulatory blood pressure monitoring and also intradialytic monitoring. There are some myths that hinder optimal care. One is office BP is sufficient. No, that's a myth that has been already addressed by the previous speakers. It is not necessary to stop RAS inhibition when the EGFR falls. In fact, a lot of harm has been done by stopping RAS inhibition even when the EGFR drops. And dialysis causes hypotension, so don't treat hypotension. That's another myth. So here it's a combination of volume overload as well as the renin, and both has to be balanced. So the key takeaways that I would like to leave all of you with: hypertension in CKD is multifactorial: volume overload, RAS activation, sympathetic nerve system overactivity, and vascular dysfunction. Accurate diagnosis is functional. You have to understand which patient is volume overloaded, requires more diuretics, and which patient has got RAS activation. Individualized therapy. Never abandon RAS inhibition prematurely. So ACE inhibitors, diuretics, CCBs, finerenone, and SGLT2 inhibitors have got all well-defined roles. And discontinuing RAS inhibition out of fear actually accelerates progressive disease. And renal denervation is an emerging adjunct. It has not been, it's right now very expensive and is used in very resistant hypertension. However, with ongoing trials, maybe we'll be able to get better patient selection and long-term outcomes. Thank you very much for the patient listening.
Thank you very much, Dr. Edwin Fernando. Good afternoon to everybody, and we are going to have food for stomach. But before that, we are going to give an appetizer, scientific feast, and food for thought. And that is by Professor Dr. Payani, who is going to talk on intracerebral hemorrhage and hypertension. He is an all-in-all person, and he is not only a neurologist, but also astrology and Tevaram and other things. He is an achiever of many things. He left no stone unturned. So I request him to give a talk on hypertension and intracerebral hemorrhage. Thank you.
So, good afternoon. Thank you very much for the invitation. And I love this 8 minutes talk, and I just stick on to the points. The important point we have to remember is we always have a question: what makes the hematoma or the bleeding in the brain to stop? Because hypertension produces rupture of the blood vessel, uncontrolled hypertension, and the bleeding, blood seep into the substance of the brain. But what happens on a long-term hypertension? It produces a lot of vascular changes. So that produces quite amount of damage which we don't pick up in the image, and that decides the amount of hematoma. So long-term hypertensive patient, uncontrolled, they have bad bleed compared to the regular patients. So uncontrolled hypertension is the most common cause of spontaneous intracerebral hemorrhage. Hypertensive ICH is a type of stroke with intraparenchymal bleeding from hypertensive damage to the blood vessel walls. Chronic hypertension produces microangiopathy characterized by lipoaluninolysis, fibrinoid necrosis, and development of Charcot Bouchard aneurysms affecting penetrating arteries throughout the brain. So it's very important. By the time that we see these patients, a lot of damage happened to the small vessels of the brain. So the predilection sites for the bleed are basal ganglia, lobar region, thalamus, pons, cerebellum, and other brainstem sites. Data from the numerous studies have identified high systolic blood pressure as a major risk factor for ICH. Systolic variability predicts poor outcome and neurological deterioration. There are 2 large randomized control trials have demonstrated that yearly intensive lowering of BP, that is systolic BP, to less than 140 millimeter mercury is safe without significant outcome impact. Acute lowering of systolic blood pressure to 140 millimeter mercury has been recommended for the management of spontaneous ICH. So it's challenging to promptly and effectively control systolic blood pressure in patients and at risk for resistant hypertension. Resistant hypertension is defined as a blood pressure that remains above normal despite of concurrent use of 3 antihypertensive agents of different classes. Data derived from the cross-sectional studies and post-hoc analysis of clinical trials have estimated the prevalence of resistant hypertension to be about 8 to 15% of all patients being treated for hypertension. So these are the patients we have to focus and find out the history of hypertension in the past, what medication they are taking, and very, very important in acute management of hemorrhagic stroke. So IBMA might be a risk factor for resistant hypertension, while proteinuria likely reflects a end organ damage from chronic hypertension. So it's not only going to produce problem inside the brain, it's going to produce many end organs in the body, we know about it. In one of the study, majority of ICH patients were Hispanic and Asian. Some of them had never seen a doctor in the past. This may explain the higher prevalence of resistant hypertension in the studied ICH population. This is one of the study in the United States. They found the group of population selected was totally different compared to the other population. It's not a proper mixture of the population. And so what we see in our practice is totally different from what people see in the Western population, because by the time people had irregular treatment, not had proper treatment, and they had extensive disease to the small vessels of brain due to long-term hypertension, which decides the amount of bleed. With intensive BP lowering in study groups, there was significant difference in average increase of ICH volume at 24 hours and functional outcome at the hospital discharge. We have to monitor this patient. We have to do a repeat scan to make sure the hematoma is not expanding. So evidence-based recommendation adults with spontaneous ICH not requiring intensive care treatment. This is one of the latest recommendations from the European Stroke Organization. Recommend admission to an organized stroke unit to reduce the risk of death or dependency. Very, very important. This patient has to be admitted and treated in a proper setup, so the outcome is better compared to if they are admitted with the regular other patients. The expert consensus statement was lowering systolic blood pressure below 140 millimeter mercury within 6 hours of symptom onset in the minor or moderate ICH, that is hematoma volume less than 30 ml, to reduce hematoma expansion. For adults with spontaneous ICH, avoiding a reduction in the systolic blood pressure of more than 70 millimeter mercury from the baseline to avoid active reduction of systolic blood pressure below 110 millimeter of mercury, especially when the patient is going to take for any surgical purpose. Caution is advised when lowering very high blood pressure for patients with large hematoma volume or when there is a planned hematoma evacuation. We should not bring down very low that affects the outcome of those patients. So evidence-based recommendation adults within 24 hours after spontaneous supratentorial ICH. We classify into supratentorial ICH and infratentorial ICH. The suggested minimally invasive evacuation of the hematoma to reduce mortality and to improve functional outcome in adults with the lobar ICH. They done a study and they done a evacuation in the lobar hemorrhage, not in the deep hemorrhage, because the outcome is still controversial. Whereas the effect of the deep hematoma remains uncertain, as I was telling. The quality of evidence is low. Even if you do a lobar hemorrhage, unless there is a risk of severe ICT or the patient is going for any herniation, that's a different story. But routine evacuation as a quality of evidence, low quality of evidence, unless there is important need for it. So infratentorial ICH represent 10 to 20% of all spontaneous ICH. In infratentorial hemorrhage, the cerebellum is 55%. If you see a cerebellar hemorrhage more common in older people compared to young people, the incidence 55%, and brainstem bleed is around 45%, and many of these people are younger people. So if hypertension produce a bleed in younger people, you have to be very, very careful that because these people are more prone for brainstem bleed compared to the elderly population. Patients with cerebellar intracerebral hematoma have less severe symptoms at presentation. You would have seen people walking to the clinic with cerebellar hematoma, but at the same time, brainstem bleed patient will be unconscious in the emergency setup. So the more favorable outcomes compared to the patients with brainstem ICH. So when you say infratentorial hematoma, cerebellar hematoma, they do well compared to the patients with brainstem ICH. So the important thing is all the time when we are talking about hypertension, we see a bleed. We should not forget that there are 20% of intracerebral hematoma or hemorrhagic stroke is non-hypertensive bleed. There are times people have some elevation of blood pressure because of so many reasons like ICT and all those things. So this the slide at this side is basically a bleed. The other one you can see there's a large cavernoma had a bleed, and you should not miss sometimes people can have a arteriovenous malformation. The real confusion happens when there is a combination of everything. People have a chronic kidney disease, uncontrolled hypertension, resistant hypertension, and the patient has some vascular malformation in the brain. There are times we see these combinations, but we have to keep in mind a proper clinical examination and proper approach, proper investigation to make sure it's only hypertensive bleed before proceeding further. And these patients has to be treated in a proper stroke unit for a proper good outcome. Thank you very much for listening to me.
Thank you very much, Dr. Paini.
Very good talk, sir. I have only one question to ask you. You have gone through, you have got an extensive list of academic excellence in multiple areas, including astrology and yoga. Do you believe in the term called cerebrorenal syndrome, like you have hepatorenal syndrome, cardiorenal syndrome? Do you think that, major organs do crosstalk each other? Do you believe in that term, cerebrorenal syndrome?
So now people are talking about axis, like gut-brain axis. They are talking about bone-brain axis. And there is axis connection between every organ with each other. And you know that we are all developed from a single cell. So when there is a disturbance in the brain, people get disturbance in the cardiovascular system. We have seen people with acute stroke. The kidney function also goes down, especially the refractory hypertension. People have uncontrolled hypertension for a long time. Same time, that end organ also responds with their problems. So we always make sure that these patients are thoroughly investigated when we see a stroke and call all the appropriate specialists to make sure that these people go with a proper care of all the available organs in the body. So I agree that there is a cerebrorenal connections.
Thank you, because I am sure my colleague, Dr. Friend, my nephrology colleague will also agrees. This is an obsolete term. I think it was mentioned in earliest journals of nephrology 1986. Acute cerebral insult causing acute kidney injury in the absence of hypertension, nephrotoxic drugs, or any other comorbid factors, which are usually reversible after brain surgery. Because I got a VIP profile which is going on for that. I think you won't have something to say on that, Dr. Edwin.
Yes, as you mentioned, it's not recently mentioned, but somebody having a stroke and having other risk factors like hypertension and diabetes could have coexisting kidney disease also. So one of the manifestations of, most of our patients don't die of kidney disease. They die with kidney disease, of heart disease and strokes. So it is possible that they have some underlying kidney disease per se, and at that time the stroke manifests. And many a time the kidney disease goes undetected unless it's detected whenever there is some other hospitalization.
Thank you. Thank you.
Just a comment.
So before that, sir, one of the study I mentioned, Professor
We'll
Soundararajan,
discuss
sir.
it in the end, sir. We'll discuss discussion in the end. We'll call the next speaker, Dr. V. Kannan, to talk on hypertension with ischemic stroke. Yes, sir.
So very good afternoon, because I thank the Professor Narasimhan sir and the team for this opportunity, sir. So this is a common topic. I try to finish as quickly as possible. Next slide. The content covered are only the without reperfusion therapy and after reperfusion therapy, or in other scenarios. So 70% of the patients with acute stroke have BP of 140/90 at the time of admission, and for maintaining a fine balance is non-negotiable, so that the cerebral outer release is not impaired. Cerebral blood pressure should be maintained between 60 to 150, which is necessary for the perfusion of the brain, and the sudden drops in blood pressure reduce the cerebral flow, thus increase the volume of ischemic damage and also the penumbra. The high BP can damage the blood-brain barrier, cause the cerebral edema. So stroke is a global incidence of 15 million people. The high BP is a modifiable risk factor. You all know in acute stroke, 75% of the patients have high BP, and among these 50% of those have a prior history of hypertension. Although BP spontaneously falls in 2/3 of the patients in the first week of following. So in the first week, there's a 2/3 will have fall in BP to the normal level. 1/3 remain hypertension, have increased poor outcome. Appropriate control of the blood pressure ensures a good outcome. So pathophysiology, you all know the cerebral autoregulation is very important. So to maintain the cerebral autoregulation, the blood pressure should be maintained in appropriate levels. So the acute hypertensive response seen in stroke has numerous potential causes, including fluctuations or elevations of pre-existing hypertension, diabetes, hypertension, increased serum creatinine levels, infection, and stress-related hospitalization due to stroke. Then activation of the other stress-induced factors like cortisol, natriuretic peptide, or RAS system, and sympathetic neuroendocrine systems. Impaired cardiac barrier receptor sensitivity and raised ICP due to Cushing's reflex. So all the BPs, the less common acute stroke, which is also the poor outcome. Potential causes including already mentioned the other cardiac important is sepsis, cardiac arrhythmias, heart failure, and ischemia, hypovolemic shock, and diabetes, which was touched upon by Professor Kannan, sir, cardiologist. As higher BP may be beneficial in to maintain the viability of the penumbra, which is underperfused when there is increased collateral blood flow. On the other hand, higher BP may increase the risk of hemorrhagic transformation and cerebral edema. So data from the first international stroke trial demonstrated a U-shaped curve between the presenting the BP and outcome. The same thing in the U-shaped curve. There is a one on the other side. There is a reduction in the hypotension. On the other side, increase in the BP. There is a within 14 days. The trial shows that the death within 14 days. There is a slight increase in the in 14 days. Then the morbidity in the 6 months, it was a rising trend. This is a U-shaped curve in the trial source. Then coming to the management part, elevated blood pressure is present in more than 80% of the patients with acute stroke. So aggressive lowering of the BP, which was already dealt by Susama and Mitra, this lowering of BP may lower the cerebral perfusion pressure and thereby aggravating brain ischemia. When there is a very high BP, can worsen the cerebral edema, resulting in poor. So both reduction and elevation will reduces the outcome. Then the best outcomes observed between 140 to 180 millimeter in the systolic pressure. So this class of recommendations and the level of evidence in 2019, but now still they say that the class 1 and level of evidence sees the antihypertensive therapy medications withheld as long as systolic BP is 220 over 120 or lower. Or in the stroke patients undergoing IV thrombolysis with the alteplase or tenecteplase, the antihypertensive drugs are not used. They're not used if the BP is between 180 millimeter or lower, or diastolic BP the 110 or lower. This is the so the 2026 guideline says the same, almost same. In the patient, the acute seems to hypotension and hypovolemia should be corrected to maintain the systemic perfusion levels necessary to support the organ. Not only the cerebral perfusion, systemic perfusion, all the organs. In patients with acute ischemic stroke, early treatment of hypertension is indicated when required by comorbid conditions. Concomitant coronary artery disease, acute heart failure, aortic dissection already dealt. Patients with BP of 220 over 120 millimeter who did not receive any perfusion therapy or without any comorbid conditions requiring BP control, antihypertensive medic initiation within 48 to 78 hours is not recommended. This is very important. BP reduction should not impair the cerebral autoregulation. Initial reduction BP of 15% is advised, only 15%. Beyond that, it should not be allowed. Intensive systolic blood pressure reduction and target of less than 140 millimeter mercury with no others indications is not recommended. So the aggressive reduction is not recommended. So these are the various trials done. That's a CATIS trial, SCAS trial. So various trials. So these conclude all evidence suppose that the aggressive and the early reduction of the BP has no role in early stage of the ischemic stroke, that is within 72 hours. Coming to the intravenous thrombolysis, using alteplase and tenteplase, the class 1 recommendation is there's a IV thrombolysis should be there, the systolic pressure should be lowered to less than 185 over 110 is recommended to reduce the risk of hemorrhage. This is only to reduce the hemorrhagic complications. BP should be maintained in the range of 180 bar 110, 105. This for at least first 20 hours. This is very important to maintain the cerebral perfusion and also to prevent hemorrhagic complications. So the goal should be the already told 180 over 105. So in the treatment, labetalol 10 milligram IV given over 1 to 2 minutes may repeated or double the labetalol 10 to 20 minutes to a maximum of 300 milligram, or initial labetalol followed by nicardipine 5 milligram per hour IV infusion as initial dose, and titrate the desired efficacy by increasing the rate by 2.5 milligram per hour for 5 minutes, or lastly they consider the labetalol drip for one time. The lastly, previous speaker told that sodium nitroprusside may be administered if the diastolic is more than 140. So this is the upper part is the BP measurement should be done every 15 minutes during and after IV thrombolysis administration for the first 2 hours, then every 30 minutes for 6 hours, then hourly for 24 hours when there is a IV alteplase treatment. So these are the trials, IV thrombolysis, they conclude that the BP of level of less than 180. Non-eligible IV thrombolysis candidates systolic should be more than 220 or diastolic 140 labetalol nicardipine, or the diastolic is more than 140 nitroprusside. Blood pressure management in the endovascular therapy in 2026 guidelines says that the current American Heart Association and the American Stroke Association recommend BP below 185 to 185 by 110. This is the target BP to undergo endovascular therapy. So this BP should be achieved and then proceed for endovascular thrombolysis. So this is the trials on endovascular therapy. So the BP range of 140 to 180 millimeter mercury after endovascular therapy should be maintained. Non-eligible candidates, this the trial says that, actually the trial says that there is no efficacy, with the various trials says that only the negative implications, and also no IV thrombolysis, no mechanical thrombotic cases. They say
Sir,
there is no proven results in these trials. The outcome is not that much. In the special situations, induced hypertension. We have to induce hypertension in scenarios for the first 24 hours may be beneficial as it improves cerebral perfusion pressure. Small studies have shown that phenylephrine and norepinephrine in the first 24 hours keep the BP high normal or mildly high. Studies showed that improvement in ischemic deficits including aphasia. Improved perfusion was also noted in MR perfusion studies. The treatment appears to be promising. So regarding the TAA, just I skip the slides. This also. Regarding a small word about the press, the experts agree that severe hypertension should be treated and fluctuation in blood pressure avoided. The choice of antihypertensive agent has not been investigated, although most clinicians favor calcium channel blockers. Then the blood pressure should be reduced gradually, approximately 25% every 3 to 4 hours.
Sir, the time is over, sir.
Yes, sir. This is for primary prevention, secondary prevention. Just want a time, skip the slides. So this is the knowledge gaps. The safer lower limit of BP and early stroke management is still a gray area. The goals of BP, different stages of endovascular therapy, pre, during, post recanalization yet to be, as the hemodynamics during stages varies significantly. There is a need for the future randomized control trials, meta-analysis for more precise guidelines and undesirable. Thank you.
Thank you very much for the wonderful lecture, sir. Please be seated, sir. Dr. Subhashri.
Thank you very much to all the distinguished speakers. And if I have to add one point pertaining to hypertension and CKD, which we always do in our classes, is we also take into account the dialyzability of the antihypertensive before we conclude that whether the patient is under control or not. I think to which our chief would agree. And since everybody is sitting on the edge of the seats, I think can we allow just one or two questions max, or we call it a day? So we're calling it a day. Thank you very much.
Yeah. Yeah, we can have the discussion in the end, the lunch hour. And I'm immensely thankful to Dr. Narsingan for giving this opportunity. And the session is closed. Thank you.
Thank you, doctors. Thank you so much. I would like to thank our moderators, Dr. P. Soundarajan, Dr. M. Subashri, and Dr. N.D. Ramanujam. A big round of applause. That was the last session for the day. They did a wonderful job moderating this excellent session. And also, I would like to thank our speakers, Dr. Edwin Fernando, Dr. B. Kannan, and Dr. R. Parni. A big round of applause, please, to all our moderators and to all our speakers of this particular session. And we have Dr. S.N. Narsingan doing the honors and felicitating all our moderators and speakers of today. Can we have a big round of applause, please? We've almost come towards the last leg of today's event. I'll say clapping will first. Oh, okay. Okay. Requesting all the doctors to please stay back for a picture. We'll take a quick picture of the moderators and speakers of this session. And now it's a very, very important moment. We have all the doctors jointly presenting a beautiful token of gratitude towards Dr. S.N. Narsingan. A big round of applause. The man behind this wonderful day today. Thank you so much, sir, for all your efforts and contribution towards making a very significant event today. Can we have you all stand up, please? Can we have a quick stand-up ovation for our Dr. S.N. Narsingan, the Vice President, World Hypertension League. Thank you so much. So I request you to say a few words to the audience. Just say a few words before we sign off. Just a couple of words, sir.
No, I don't want to prolong the scientific session or the other part of it because my sincere apologies for those people who are waiting for lunch. People who are enjoying their lunch, I need not tell them about it because I need not apologize because they have already gone there. And I don't know how to express my thanks now because right from the morning, from 8:30 or so, you have been here and we enjoyed thoroughly your company, particularly for public awareness program as well as for the scientific program. The last event of this particular scientific program is to keep all the placards in your hand. those people who are having the placards can come here. We will hold it, take a group photograph. I'll be able to send it to World Hypertension League. Please come. Please come. You have something to.
Well done.
I don't need to. I don't need to.
Induced Hypertension, API Tamilnadu chapter and API Chennai chapter. In fact, really thank you, Dr. Narsingan sir, for his meticulous planning. And without his support, this would not have been possible. I would like to thank all the panelists and the doctors and the faculty and moderators for being here. IPCA is really proud to be associated with hypertension management, and we're always there for the CME programs. Thank you very much, sir. And we welcome you for the lunch. Thank you very much, sir. Thank you.
Well, thank you so much, ladies and gentlemen. We thank World Hypertension League, especially Dr. S.N. Narasingan, Dr. K. Kannan, and Dr. S. Chandrasekhar, as well as the Association of Physicians of India, Chennai chapter, and IPCA Laboratories for taking this great initiative of hypertension awareness and control in India. I'm sure all of you YouTube live viewers and hundreds of audience present here today had a great time. I'm sure you're going to keep all your diabetes and BP under control. And of course, to my left, there's a white board over there. All you have to do is take an instant pledge that you're going to reduce your salt intake. Just keep it to a minimum of below 5 grams per day. And also, I would like to thank once again all our audience who've been patient with us since morning. Thank you so much for being such humble, patient audience. You all can go and have your lunch now and enjoy the rest of the day. Thank you so much. Jai Hind.